Preload this.
Oh, cool.
So we're ready to go. And we're live in 5, 3,
2,
1.
Good morning. Welcome everyone to Seattle. Welcome to the faculty and the participants. Hopefully we're going to have some good weather. We have an amazing agenda. We have awesome faculty. I can't believe we've been doing this for 15 years. So I want to have my partner in crime, Jens Chapman, come up here. Crime. Partner in crime, Jens Chapman, come up here. And then our other co-chairs, Kojo and Charlie. Come on up. So we've been doing this for 15 years, and it's so awesome. It's probably my favorite weekend all year. I get to meet all the cool fellows and all my dear friends and faculty. And obviously, we couldn't do this without Seattle Science Foundation and our industry partners, Globus, Medtronic, Arthrex, Stryker, Alphatech, Osteocentric, Extant, Integra, Spine Art, Therapeutics, and the awesome staff here at SSF. So we have Linda Celine, Corey Kepler in the back, and then Ben Rupp, who runs all our audiovisual technical guy, and then Gary Hawley, the famous Gary Hawley, and Anthony Del Cruz in the lab. We've got, you'll see this is an amazing facility. There's the lab, and then there's 2 locker rooms. There's a dining room, and there's a conference area. Hopefully this weekend, I think what we've come to find out is we actually learn more from you guys and getting to kind of, know each other and rub elbows. You guys are gonna be fellows, but this is a really cool weekend. It's packed full of demos, talks, and really just a fun 48 hours. So look forward to having you guys. Jens is gonna say a couple things, and then we're gonna kick it off with, today's gonna be lab. We're gonna do demos and talks, and then tomorrow's gonna be talks, and then we have a lab in the afternoon. So Jens.
Hey, just another welcome to all of you, and thank you for making this the highlight of our year. I speak for everybody. I want to just recognize Rod, Charlie, and Kojo. They're just truly amazing people. People always wonder, like, what do they get out of this? This is exactly the point, you. And having future spine surgeons take care of us and our families when we become in need. So this is why we're doing this. There's no financial take or anything like this, just a lot of fun and positive energy. And I personally learn from you guys, but I also learn from the enormous faculty that they've accumulated over the years. And it's just really very nice for me to see how it evolves over time with new faces. And it's a great mix of older people, which I'm qualifying for. I'm 65 as of 3 days ago. And yes, thank you, Kojo, though. And young, fresh faces who have a lot of energy and different views. So this is always really exciting for me. And honestly, I learn, as Rod said, more than anybody else. But let me pass the microphone off to Dr. Sanser and Hamilton, because they've really actually taken this to new heights. And 15 years ago, maybe you want to reflect on what prompted you to do this and how this has just been invigorating every time, every year. So thanks, guys.
Yeah, so I was invited to be a faculty for this course back in 2009, and I can't believe it's 15 years later, but both myself and Dr. Hamilton, we've had the luxury of knowing Rod for all of our professional careers. And when I first came here, this was clearly the state-of-the-art facility for training. And you know, every year, I think it's just proven itself time and time again. So it's got a history of excellence. You know, patients will tell me ahead of time when I see them in clinic that, oh, I already know about this. I looked at your lecture on Seattle Science Foundation. These things stay in perpetuity on the internet. And it's a great teaching opportunity and a great learning opportunity for all of us.
Thank you, Charlie. So it's going to be very interactive. I want it to be interactive. My name is Kojo Hamilton, and I've been a participant, I think, in the first iteration of it as a overgrown chief resident, and I joined the faculty in 2011. So this is your course. We keep it small. We want people who make the time to come here to be invested in it. There will be guided instructions in the lab, lab demo all day, but it's for you to ask questions. Some of you are very keen on what we do, and some are also still deciding, but most of you are going to benefit greatly. You can't get the assemblage of instructors and anywhere together in a nice city like Seattle. So I welcome you all, and we need to get started.
Sounds good. So our first speaker is Dr. William Cross. He's going to be discussing SI joint disease. The eye sees only what the mind knows. So it's a pleasure to have Dr. Cross. He's an innovator in this field, and it's an honor to have him.
Thank you.
Sure.
Thanks. All right. Well, we'll kind of lead off the show, and I think it's appropriate that we start off with the SI joint first, just because it's like one of those disease entities that people don't recognize, and you can spend the rest of the course kind of saying, did that patient actually have SI joint disease? So, and as I was showing my team back home, my talk, like, they're like, who's Noonan? And so I aged myself. Does anybody know, like, Danny Noonan was in Caddyshack? Yes, Caddyshack, like, Noonan. So you just don't miss it, because you'll be looking right at it, and the spoiler alert, he actually makes the putt. But this is what actually was titled. You might know this one better. Is the eye only sees what the mind knows. And if you're not thinking about SI joint disease, you'll be looking at it, and you'll be giving patients unnecessary, interventions and surgeries, all because they have SI joint disease and you didn't recognize it. So just a bias here, I have been very involved with the SI joint for years, and have helped design a system for primarily revisions initially, but now just a great all-around primary system. So we'll kind of talk about the anatomy, diagnosis, strategies to find out what it is, and then how do you treat it. And then a little plug, I'm also on the board of this organization, SIMEG, which is this international group about SI joint education. So we have a meeting in next month in Austria, and the next year it's in Japan. So if you're interested in the SI joint and talk about the SI joint, it's a great organization. So my journey started a long time ago at the University of Minnesota with some trauma mentors with Dr. Swinkowski, Dr. Paulies, you guys may see up there, and Dr. Stark, all just kind of pioneers in the SI joint field. And then I joined Mayo and then gave a talk in 2011 on pelvic ring injuries. That's where it started, because everybody's like, oh, wow, you know a little bit about the pelvis and the pelvic ring and the SI joint and sacrum. So that's kind of where it started. And then in 2015, I actually kind of started this SI joint clinic. And now it's just like completely blown up, where we're getting a lot of patients come in for just don't know what's going on, get the diagnosis, primary diagnosis, and then we're seeing a lot more of these revisions for different types of implants and allografts and so on, which we can talk about later. But I don't know if you guys know this, but the sacrum is actually a Latin for sacred. It's in the middle of the body. Some thoughts are that when they used to burn bodies, the only bone left was the sacrum. And so that's where they thought it was kind of this holy bone, or it might be in the front or where the organs are for generative stuff. And then I Googled, I don't want to get too crazy there. Right, actually put this in AI. You'll see a couple AI generated images in there. So I said, put the sacrum at the center of the universe. And that's what it came up with. So the SI joint disease is there. If you look at what people complain about to their doctors, musculoskeletal health is everywhere, right? That's the most primary complaint that patients are seeing their physicians for. And of that, it's the back. That's the biggest issue that people are seeing their providers for. So we're in a good profession right here. With SI joint disease, however, people don't know where it goes. How do you diagnose it? Where's the true pain generator coming from? And there are some algorithms out there, but nothing's really been generally accepted. And this leads us to give unnecessary decompressions, unnecessary fusions, unnecessary hip scopes, unnecessary this and that, when all along it's just the SI joint that needs to be appropriately treated. So this is a pretty oft-quoted article from one of my mentors, Dr. Polly. But the SI joint, people think it's hip, people think it's back, and there's a huge crossover of the SI joint with all of this. So just really keeping aware of the SI joint is really going to save you. And just because he had a spine fusion, you can't rule it out, because we know that the presence of that spine fusion can cause SI joint pain to be directly attributed to it. It's all simple physics and force transfer. You take away motion up above, it's going somewhere, and it doesn't disappear. So it goes right to the SI joint, and they can really cause it to have excess motion, which is theoretically why it's occurring. So always keep in mind that it's there. That's my favorite quote for all my residents, is the eye always sees what the mind knows, and just be aware that it's there. The SI joint is a joint. It moves. It's not like a knee or a hip, but it does have synovial fluid in it. It has hyalinized cartilage, but an extremely complex ligamentous support. And there are a lot of variations of how the sacrum and the iliosacral joint is formed. You can see on the right front here, there's only about the front 1/3 to a half is actually cartilage. Posteriorly, it's all fibrocartilaginous matrix back there. And the SI joint motion on the right, if you look at the intact SI joint and you look at gap and rotation, it barely moves. And when you force this ultra congruent joint to move, that's theoretically where the pain's coming from, both from inside the joint and likely some ligamentous irritation in the back. In the back, you have an extremely stout ligamentous complex. Very, very strong, and coming from trauma, we look at this iliolumbar ligament up there as a marker of instability. With trauma, you'll see a ripped off or avulsed TP that can be representative of some increased motion there, and then the anterior SI joint ligaments. And so when I do open SI joint fusions, that is stout, and you have to take your bovi and bovi, all that off, get into the SI joint and decorticate it that way. Dysmorphism is common, and I think if you take anything home from this talk, it's recognizing a dysmorphic sacrum, because this is how you will not injure L5, which is the most oft one that's injured if you don't recognize this. So this is what I would call a normal one on the left and a dysmorphic one on the right. And in trauma, we don't count down to find out if it's lumbaralized or sacralized. We just say upper sacral segment and lower sacral segment. And so the dysmorph is common. Almost a half of patients have some element of dysmorphism, but you get the outlet radiograph. These are all the factors that show that this patient does not have a normal sacrum. And you need to recognize these, because this is going to dictate where your implant's going to go so you don't hurt something, okay? So we'll go through each of these 5 things there. And you can also see it on CT. And so we're looking specifically on the CT of that iliac cortical density, which is this line, right here, which represents the thick part of the ilium going right across here, and that's kind of L5, and I'll show that in a second. So this is the lateral view. The bottom right, we're lining up our greater sciatic notches, and I checked the lateral view right when the pin goes about right there to go into the body of 1. And you want to be, you can extrapolate where you are to make sure you're not coming out the front where you're going to bag 5. And again, this represents what the ICD really means. That's the density right there. That's where L5 rests. So if you're anterior to that line, you're going to see some foot twitching as the pin goes across there. So be very, very careful. So where's the dysmorph? So that's where the disc base is at the top of the iliac crests. You have these residual mammillary bodies on the top of that upper sacral segment. You have these bizarrely misshapen neural foramen that's coming out at you, and I'll just call it S1 At that was probably L5, but we're not counting down. Residual disc space that you can see there, and then these really acute alar dents. So as you remember, from the last couple slides there, that's where L5 is sitting right there. And if you just put your implant willy-nilly right across here, and I've seen it before, that's where L5 sits, and you can hit L5. So just really recognize where that anatomy is. So everything, I mean, you just name it, and it can cause SI joint disease. And so that's why it can be somewhat elusive, is because, you may think it's something else, but it can be SI joint disease for any number of things. In my practice, these are kind of the top factors, and I'm really interested in number 5, because I think this is kind of where we're maybe missing the boat in some patients, and I think there's some research in this cluneal nerve, and so we're starting to really investigate this more at Mayo Clinic as a cause of untreated back pain. And so this is just some research I've been doing on it lately, and overseas, and especially Japan, it's like a cluneal nerve epidemic over there, and so there's a lot of literature about that overseas. Every patient in my clinic gets these standard studies for SI joint evaluation. This should be part of every single patient you come in should get these particular studies, and they should get flamingo views, because you may be looking at that image on the right as just a normal AP pelvis standing here, but then you have them do these single leg stance views, so-called flamingo views, and they have this level of instability. So you won't know this unless you look for it and get these kind of single leg stance views. So the other thing is that we're all super hyper-focused on CTs and MRIs, and it's critical for us to really evaluate those, but the presence of SI joint arthritis doesn't really mean anything, because after the age of like 50, everybody has it, and these are asymptomatic people. And so you can't just look at an x-ray and say, you have SI joint disease, let's go to surgery or get an injection, because it might be completely asymptomatic. The most important part of the SI joint diagnosis is the exam. And so many patients that come and see me, they've never been touched before, like we examine them. So really kind of listen to their history and do their exam. This looks like a radiculopathy, but it's not. This is SI joint radiating pain that is extremely common in this very predictable pattern. And so you'll be fooled that this is some other radicular pattern, but it's not. The SI joint, when they come in there, they'll be offloading typically the painful side if it's unilateral, and that's extremely common. I do all these are all the provocative tests that have been listed. The highlighted ones are kind of my favorites, but you can pick your exam maneuver, and maybe that's yours, but it's a culmination of everything kind of put together on what makes the SI joint diagnosis, and none of them are perfect. They've all been studied. None of them have perfect sensitivity and specificity, and so it's really critical. This is what I do. I kind of start, looking for seating imbalance, then I do a standing exam where I kind of turn around, poke them around a little bit, and I do a big supine examination, listing all those tests there. And then this is my new favorite test, and I just am going to publish a video about how to do this test, but this is amazing. And my favorite by far test now, because what it does is it compresses the SI joint, and they'll get up off the table, and a lot of times if they truly have instability, their pain goes away completely. The radicular pain goes away. So if we have time, maybe during lunch, we can show that video, so I just haven't published it yet. This is the exam. So if you get an opportunity, this is, we just published this a little bit ago, but if you look at this, it shows exactly how you should examine the SI joint. So that whole list of studies there, I just show exactly how we do that on patients, so kind of handy. All right, that video's coming. The other one, the criteria 4, when I diagnose SI joint disease, positive history, positive exam, imaging positive, and injection seals the deal. But that's the most technically challenging part of kind of this diagnosis. And so if you don't have a perfect injection and you're getting this, I mean, who the heck can make any treatment decisions off an injection like that? Because they anesthetize the whole quadrant. So you don't know. So it has to be a perfectly done injection where you can see that injectate go in the SI joint, and there's not this kind of what I call an amorphous blob of contrast down there, because otherwise you can't make a decision off that. So really critical to have a good injection. And one reason I get a CT on everybody is because if they're using fluoro, they're just going chink, chink, chink up against that posterior osteophyte. They're not getting in the SI joint. They're just anesthetizing the local area in the ligament. So you really have to talk with the radiology team and know they can get a CT guided if they need to. And this is mandatory, that they have to give you a pre and post injection score documented somewhere, because sometimes patients won't remember it. And so our radiologists are kind of, have this kind of protocol to do that, or I have my PA call them like the next morning and I say, you know, how did it go for you? And then have my PA document this in the chart. And that way you have record, because they'll come back 6 weeks later and they're like, oh, it didn't work. Well, it worked for an hour. That's all we care about, you know? So it's the steroid is kind of for them. If something else is going on, I usually try to address that first. I think kind of the most common would be hip pathology, and so I'll get an intra-articular hip injection, because I think there's a huge interplay between that stiff hip and that whole hemipelvis rotating back and forth. And so sometimes if you just give them an injection, you can solve their SI joint pain just by kind of greasing up that hip a bit. Sometimes it's facet issues up above. So if it's the hip, I'll give them hip replacement first. If it's the back, usually SI joints first, because you talk what's easier, like a long multi-segment fusion or an SI is probably the SI. So hip issues, it definitely works. This patient had concomitant hip and SI. I injected them both. We gave them her hip, we gave her hip replacement, and you can see these promise scores have that crossover sign, is what you're going for with outcome studies. And we solved her SI joint pain simply by giving her a hip replacement. This patient had just profound facet issues, and so probably force transfer. This has got a hard deal. Do you go ahead and fuse her back with, you know, or because she failed ablations? And we give her SI joints, and they're getting better. She's still kind of struggling a little bit. Who gets surgery? You know, it's those 4 criteria on the right have to be met when all non-operative factors have been exhausted and documented they've been exhausted. These are all the non-operative methods, but fusion does work, and it works well. This is kind of just Mayo Clinic data. You know, you can see mean ODI, you know, is over 20 at that 12-year follow-up, and the pain scores, you know, plummet reliably, and then the SANE scores, which is this single alpha numeric score for success, you know, is above 90%, and so it really works well. Let's see, so technique, there's a lot of techniques. I template every single case exactly like this. There are hundreds and hundreds of these in our PAC system, but I template every single case to make sure I don't hit L5 or S1, and I can know, you know, how much I'm going to decorticate and so on. This is where you want to put your screws in your lateral. You want to be kind of low and anterior or kind of middle, because if you're low and posterior, you're going to hit S1 and they're going to get a radiculopathy. If you're high or you're good in cranial posterior, you're going to be pretty safe. And then cranial and anterior is a little bit less used, but I kind of like that. I call that the hog screw, right dead center in the middle, as you can see with those templates. I do it in the prone position. I draw that grid out, PSI, S long axis the femur, draw a line down, divide it in thirds. And again, this is all just online if you want to watch how we do this. But this is called the inlet view, where I do anterior and posterior adjustments. And I'll show you this on TV in the lab here in about an hour. And then that's overline 1 on 2. Here's the outlet view, you know, upon putting the symphysis over S2, and that's where we do cranial caudal adjustments. And then I always check a lateral view if the anatomy is kind of goofy to make sure I'm not anterior to that ICD. So you can see we're right in the middle of that safe zone. L5 is safe on this one. So that's the surgical technique up above there. So that'll be online if you want to take a look at that. I like doing it percutaneous. I do have done a whole host of opens in there, but that's morbid and it's aggressive, and it's about a 3 or 4 day hospital stay. I like to get a true fusion, just like we fuse ankles and elbows and whatever else, by just using these principles. I like to scrape out all the arthritis and bone graft it, squeeze it together and lock it together to really get that true fusion, which I think, you know, really minimizes chances of failure down the road. Second, I think the way that I do it really can address failures. And so all these have a fundamental problem of loosening the sacral ala, where it's butter bone. If you guys do any fixation in there, you can just push your finger through the ala. It's that porous, and the Hounsfield units are that poor. And so if you guys ever see allografts, I see a lot of these allografts, and so that's another deal all by itself. But they're easy to fix because you just blaze right through them because it's just dead bone. 2 critical steps: put that pin where it needs to go, and then decorticate and rip out all the SI joint inside there. And then you can get compression, and that gives you stability. So you can see it's really kind of compressing that whole SI joint area, and I think that's why this tongue and groove concept really hits home with stability, and that's why they get immediate pain relief. Post-op, what I do for all of my SI joint fusions, on unilaterals, there's weight bearing is tolerated, using crutches for comfort, just to offload that kind of painful side, just from the surgery itself. And then I see them routinely for imaging all the way up to 2 years. And then I follow outcomes in every single patient. They all get PROMIS CATs, physical function and pain, and they all get ODIs and a SANE score at every single follow-up. And we're just getting ready to publish our 2- and 3-year data on a recent set. So to kind of close it down, just look for it. Hopefully give you some tips on how to identify SI joint fusion or SI joint pathology. Remember, always keep it in your differential because it's there and you'll miss it if you're not thinking about it. Don't operate the first time you see them. Give them all sorts of non-op. Surgery works. There's a lot of methods out there. I just like following the principles of any fusion surgery because I think it's pretty darn reliable. So with that, I think I'll probably close, and then just later on for your table instructors or anybody else, these are just some hot topics I think that might be good to address. All right?
Thanks very much.
Whirlwind. Thank you.
Any questions for Dr. Cross before we move on to the lab demonstration? You know, one of the things that I find interesting, like you said, is the cluneal nerve.
Yeah.
And I mean, sometimes the cluneal nerve sort of traverses the ligaments that cross the SI joint. And I think that sometimes you get successful treatment of cluneal nerve injuries by fusing the joint because of the stability. So it's kind of a catch-22 situation, you know.
Yeah.
It's an interesting phenomenon.
One of the treatments they do are simple decompressions of the cluneal nerve as it goes through the fascia between the PIIS and the PSIS. And I think there's that micromotion of the SI joint, which is probably pinching that nerve as it's going through the fascia. And so one of the treatments is a decompression of that or a resection. And I'm not sure which one's best, but hopefully we'll figure that out. I think it's a real diagnosis for sure.
Do you know what ends up being, what's the side effect of the resection of the cluneal nerve, like numbness of the buttocks?
It's a fair amount of, to extrapolate from that, I usually cut the LFCN when I do lateral windows for pelvis surgery, and they get a numb patch on their thigh. That's the same thing that's going to happen on their backside. So a little bit of a trade-off.
Right.
Yeah. Yep. Great. All right. Thank you.
Cool. So we're going to move to the lab demonstration. Dr. Rada Skuyan is going to be showing us how to do odontoid screws. Let's see, yeah, we're going to get your voice soon, Rod. We can't hear you yet.
Yeah. Can you all hear me?
Can you guys hear us now? Maybe Cameron.
I can hear
Cameron
my
will do
voice
the demo.
in here.
Okay, perfect.
Yeah.
All right. Good morning, everyone. So we're going to do an odontoid screw, and I have Cameron Hogsett next to me. He's one of our fellows here at Swedish. And then Anthony Dela Cruz is going to be doing our fluoro. And then behind me is Christian Jordan, who's going to be supplying us the instrumentation for the procedure. And I put together some slides, if you guys can put them up, just to kind of, because I think the most important thing about doing odontoid screws is how you set the case up. And, you know, historically, you know, again, just because we're in the lab, we only have one C-arm, but usually you have kind of two. And then typically, again, you can use a Jackson if you want. And here, obviously, we've got a cadaver. So you basically want to set it up like you're doing an ACDF and patient supine. And again, we won't talk about indications. I'll show you a case at the very end that I did. But typically, you know, this is a surgical procedure that you're going to do in a type 2 or something that, you know, that's an acute fracture that you can reduce. And like I said, you're not going to do this in like an 80-year-old or a 90-year-old who's got an unstable, you know, posterior displaced odontoid. So positioning is very important. And you can see here in the lab, we've got the setup. We don't have two C-arms. We just have the one. And then typically we'll have an open mouth and then a lateral view at the same time. And then we kind of did a little bit of a prep, but you can see Cameron did a great exposure. Because I'm right-handed, we're doing a right-sided incision. And the reason for that is then when you're doing all your work, you feel comfortable and you have a nice corridor. And you can see Cameron's done a great incision, just like you're going to do an ACDF. Incision right over cricothyroid membrane. You go right on the disc space. And then we got some fluoro shots as well. So we got a good AP in the lateral. I don't know if you guys can see that at all. And we put an all in, and you can see there's the base of the dens. And then, so we know we're midline. And then we've also got a good lateral view as well. So the angle is important. And you kind of go into the C23 disc space. And then if we can go back to my slides, and Cameron's actually going to do this procedure, and essentially the screw length, typically, again, you can measure it on a CT scan, but it's anywhere, I would say, in my experience, from 34 to 42 millimeters. And the companies all have these great screws. So they're typically, so you have 3.5, 4 millimeter, and 4.5 millimeters. And then they also have these lag screws where only the tip of the screw is threaded. I don't know if you guys can see that at all. Oh, maybe I'll bring it in. See that? So this is your lag screw here. So this will actually catch the tip of the odontoid and pull it down. So that's the reason to use this. And then you have a fully threaded screw as well. And then if we can go back, and again, so fortunately, this patient doesn't have a barrel chest, but you got to, positioning is important. And then I always, you can use neuromonitoring, you don't have to, but you make sure you put a bite block in. And then let's go to the next slide. And then, as I alluded to earlier, and the most important thing is be able to because you're not going to really be able to see anything. So you have to have a really good AP and a lateral. Oh. And this is the setup. So the patient, you can see he's got a big bite block, and then you've got a good view. And then let's go ahead and go to the next view, next slide. And you can see from an AP and lateral, basically, and again, this patient's on a Mayfield headrest, radiolucent, so you can see both on an AP and a lateral. And then let's go to the next slide. And this is kind of the view that we have in the operating room. You want to really be able to see all the way up to C1. And then let's go to the next slide. The other way. And again, this is what typically, these are the kind of cases that you do it in. It's someone who's young. You want to maintain their rotation. You don't want to do a C1, C2 fusion. They've got an odontoid fracture, and you can reduce it. Usually, you can this was a 4.5 millimeter lag screw that we placed. We reduced it nicely. And then Cameron's going to demonstrate this now in the lab. So,
Sure,
and I will retract for
right
you.
here.
Yeah. So maybe I'll go to the other side, Cameron. So
good.
the system we have in place and all these systems are kind of the same. Typically what I do is just like Cameron has here, so I'll retract for him. And then so we have the all, and then typically what you do is we actually have a K-wire, but in this case, we're going for the interest of time, we're going to skip the K-wire. Let's get a shot there, Anthony. And you can see, so Cameron's kind of started it, and he's going to carefully go ahead and go in, and he's going to go all the way across. And then typically, again, we'll have another C-arm, so I'll be getting an AP to make sure that and this is actually an important point. Because he's on the right side, he's going to actually tend to drift towards himself. So you want to come this way. Did you guys see that move? Mm-hmm. So you want to make sure that you're really straight, because if you're off by 5 degrees and it's a 42 millimeter screw, it's going to be way off to the side. So now let's keep going.
One of the things, Rob, that you mentioned earlier, which is very critical, is the fact that you have to really get into the disc space at C23.
Exactly.
Because if you don't, then your trajectory is not going to be, you know, ideally situated. It's going to be, it's not going to really follow the length of the odontoid. So sometimes it may even require drilling a tiny bit of C3 in order to get that trajectory.
Yeah, that's an excellent point, Charlie. And again, usually, you know, the nice thing about this is when we use a K-wire, you're able to carefully, you know, you can redirect pretty easily. You just bring it back and then try to get it to go more. Okay, so now let's do this. So I will hold it in place, and then Anthony, why don't you go ahead and do a quick AP. And the one thing that's a little bit tricky with the K-wire too is when you tap over it, it can easily advance. So you have to be really careful, and especially on this case. So you can see there, we're a little bit off. Go ahead and shoot that. So that's a little bit better. So, so keep going, Cameron. And so you can see, can you guys see the base of the dens? Go a little bit more, Anthony, if you can. Let's see if we can get a little bit. So shot there. Good. So we're not across. So let's go ahead and, can we lengthen? We got to keep.
This is one of these situations where if we had access to the angio suite, it would be ideal to do this case, you know, in the angio suite, you know, having biplanar fluoro.
Yeah, that's a really excellent point, Charlie. I've never thought about doing it in the angio suite.
Yeah, Dr. Chua. Or navigation.
So,
But the thing with navigation,
So
though,
bring it back.
what I feel like you need is like both navigation and fluoro.
Let's get a shot.
Yeah, because you need real time.
But you guys see that there? See how we're adjusting even by 1 millimeter, it can throw you off. Go ahead. So go ahead, Cameron. But you can see if you're off just by three degrees one way, it really can throw you off.
Shot there.
So that's pretty good. You guys see that? So Cameron's doing a good job. And then let's see, what's the drill set at? Can you go a little bit further?
Yeah.
Okay, and then now let's go to a lateral, and then let's leave that in place. And then let's go ahead and, what was the tip, what's the drill?
We were initially at 40, right? Then we just moved it up.
Was it 40?
Initially.
Okay,
So I'm just going to remind the audience that
so let's
these
take a
patients
look.
who get odontoid
Shot there.
screws, they're mostly going to be young people
Okay,
who have like, pliable tissues.
okay. So
You
let's
know,
go
you want
and
to
bring
preserve
that out.
motion,
Yeah,
young
that's fine.
motor vehicle accident victims. This is like the classic situation for an odontoid screw. Not ideal for like an 85-year-old.
Do you have let's see the guide wire really quick. So I want to show you guys that these are the nitinol guide wires that typically we'll place and then we'll drill and we'll tap. So let's see a tap. So go ahead and put that in that little, okay, shot there. So I think you'll probably have to drill it a little bit more. Let's get the, or do you have a tap? Let's go ahead and tap over it. I just want to show how, I mean, the guide wire kind of has a mind, can have a mind of its own. So
have that set on?
typically what we'll do, and they actually have this, I should
just
use
take
this.
this.
So can you guys see this retractor? It's a really nice radiolucent retractor, and you can just put it right over where you're working. And then Cameron's going to go ahead and tap. And again, typically we use we'll use like a power drill.
X-ray there.
Perfect, so keep going. And then exactly, so I will hold on to it and make sure you don't advance. And then again, Cameron, you got to be really cognizant of what it's easy to drift, exactly.
X-ray there.
Keep going. But you can see, I mean, it's really not
there.
technically demanding, but you got to make sure that you have it, the patient positioned correctly, and that the odontoid's got to be fairly well reduced. Otherwise, it can easily displace. So keep going, Cameron. And this is a 3/5 tap? Yeah, so these screws are not very aggressive, so you do have to keep going, Cameron. So you can see we're almost getting across. Usually this is where you might need to drill it. Okay, come out. And this is actually, this is what happens during cases, right? So
Oh,
he did go, usually you have to drill all the way. Usually it's very hard to get across the fracture plane. So that's another important point.
extra.
Is you do have to, when you're doing this, you can't just, you have to go all the way across the fracture plane, especially if you're going to reduce it. Good, keep going a little bit more. Okay, fantastic. And then let's see, so what's the length on this going to be? Okay, so probably we'll take that longer screw. So go ahead and bring that out. And actually, you know what, let's do a quick AP just to double check.
Sounds good.
Make sure that we're in the right plane. So come around. And again, the nice thing about this, you guys, is
over the wire.
that, you maintain, that's not bad, actually. Okay, great, come back around. It's not perfect. Cameron's a little bit, you can see, I probably would have, strained it out a little bit more, but the key is, yeah, go ahead.
So Rod, if at the university in in Salt Lake City, the Afflebaum group, they advocated for double Odontoid screws.
Yeah.
And so you could see with that trajectory, you could put another one right next to it.
Exactly. And I don't know, honestly, Charlie, like these screws now, this one is this a 4.0 or 4.0? Do you have a 4.5? We do. Let's have a 4.5. I don't know. I think it's kind of overkill. I don't know what Jens and Kojo and the rest of the faculty think, but you definitely can put 2 screws, but typically, like you said, usually it's in a young patient, they have good bone. The key is to reduce the fracture, in my opinion.
Dr. Chua, you wanted to make a comment?
Yeah, I think in the early days, Dr. Afflebaum described 2 screws, but shortly after that, there were some biomechanical studies that showed that 1 screw is just as good as 2 screw, and obviously you reduce your risk by half. Right. So I think most people just do 1 lag screw now.
Yeah.
Yeah, this isn't cannulated at the end.
And then the other thing too, I think, basically when you're, and Charlie, I don't know how often you do these, but it's pretty rare. It's usually, someone getting thrown off a horse, bike accident. It's usually someone young. And the break has to be such that, it's not seriously displaced. There isn't any other significant injuries. So I don't know how often, Charlie, how often do you guys do it at shock trauma?
So at shock trauma, these go to these are C-spine without deficit, usually goes to orthopedics.
Oh, so Steve Ludwig is stealing all the cases,
yes,
huh?
Steve is stealing all my cases.
Wow. That's classic for Steve.
So we do C-spine with deficit.
Just keep going. Shot there.
Falls in our domain, and so
Did you guys see that? See how the K-wire can do? That was Cameron's fault, by the way. Not me. Cameron, watch. So what? See how it can grab it? Shot there. Okay. Delete that from the CR. Just kidding. So you guys are learning the tricks here. So I don't know if you guys know, but this is actually an important point. So Charlie and I were residents at University of Virginia with Kojo and David Okonkwo. And the ABCDs of neurosurgery are very important. And you guys just saw it right there. So this screw is obviously too long. So let's go ahead and get a smaller one. Bring it out. Is that, so A is
See that
very
wire back?
important. In fact, all
See the
my
wire
daughters
back?
know this.
The
is
wire?
The number one rule in neurosurgery is to know your ABCDs. So A is accuse. So anytime something happens that or goes wrong, you want to accuse someone, right?
Like,
B is blame. So you guys saw I immediately blamed Cameron. And then C is to criticize, okay? So you want to criticize like I was criticizing Cameron. And then the most important, go ahead and grab it now. I'll grab the soft tissue. Is you have to deny. So those are the ABCDs of neurosurgery. So no, don't do that. Here. So let me see just a forceps. And then what size screw do we have now?
See, that's the solid UVA education. Rod.
Exactly.
30. Probably need like a high 30.
Huh? Yeah, 42 is fine. This was a 50? Okay. So Christian,
Dr.
you're,
Sanser, can I make a comment?
you're fired.
Yes, yes.
So key thing for all of us to know is that odontoid fractures have changed in their patient population
Shot there.
dramatically. So this is a fracture of aging
Good.
patients nowadays, and aging patients don't do very well with upper cervical exposures. However elegant this is, and this was my favorite true MIS procedure in the world. It's motion preserving, very elegant, but
X-ray
it
there?
requires a lot of precision.
Yeah, perfect.
Just as you and Richard pointed out. So the point is that indications
Good.
for
Shot there.
odontoid fracture,
That's fine.
fixation with screws
Good.
have almost vanished.
Let's do AP.
I think you referenced that. I just want to emphasize that. And the biggest problem in the Utah series with Ralph Applebaum, I actually got to visit them, was dysphagia.
Yes.
This is what we found in our AO study also. I think you were part of that, actually. Multi-center study with odontoid fixation. And dysphagia, so swallowing difficulties, was highly prevalent simply because you had to retract the esophagus just enough to get in there. And older women have underlying chronic dysphagia,
That's not bad.
and this actually becomes a real problem then. So I personally love this surgery. It's one of my favorite surgeries, and I've not done one in the last couple of years. I could not, probably 3 or 4 years ago is my last one I did. And again, I love the surgery, but the indications are narrow, the technical execution has to be perfect, and a good C1, C2 arthrodesis is way more reliable.
Yeah, I think, you know, again, in my practice, the only time I've really done this is for very young patients. I did one in a 17-year-old MVA, and another patient was a revision that was done at an outside hospital where the screw loosened, and so I had to revise it. That patient, in retrospect, I probably should have done a C1, C2 fusion, but that patient had a loose screw and it was backing out, and so I had to go in from the front, and she ended up needing a peg tube, but she ultimately recovered.
Yeah, I mean, I think Jens, you made an excellent point. I mean, the indications are really important because if you do it on someone, an older patient who's got an unstable odontoid, this thing will come out in like a week. It'll just back right out, so you got to make sure. And you can see here, I mean, to be critical of Cameron, which I'm not going to back down on, is you can see, Cameron, you had it, right? You just veered off a little bit. Otherwise, it was good. Your lateral looked good, but on the AP, I would probably make it a little bit more straight. So, all right, well, thanks, guys. That's it.
Yeah, thank you, Rod. That was
Awesome.
great. So our next speaker is going to be Dr. Jim Harrop, discussing spinal cord injury research. He's going to be presenting through the virtual format. I'm not sure if he's online with us.
I'm here, Charlie. Can you hear me?
Yes, I can hear you. Yeah, we'll go ahead and get your slides up shortly, Jim. How are you doing?
Good. I put them on my screen. I hope you guys can do it off that.
Yes, we see your slides.
Okay. First of all, that was a great presentation. And it's funny, I can't remember the last time I did an odontoid screw. But I will give you 3 points of 3 things that I think are really important. And they're really just reiterating what you guys said. One, it's all about positioning. Charlie, you guys talked about Applebaum. Applebaum used to put corks in people's mouths because he thought that was radiolucence and a great way to do it. 2 is be aggressive at the C2-3 disc, like you were saying, Charlie. I used to cut the disc out to get into the disc because all the failures I saw were people they'd scythe off the front, and as they loosen, they'd pop out the front. And the second thing I would do is I'd take a kerosene and I would find the exact midline and I would bite the kerosene, a 3mm kerosene, right on the top of the 3 body. So it gave you a groove. And then the fourth thing I did is I use a power drill because I actually like that. And one last thing, and then I'll shut up about odontoid screws and never speak about them again, is if you're going to use a lag screw, you have to go through the top of the odontoid. So it's like freaks you out because you're like, oh my God, I'm going to go into the brainstem. But when you really look up there, there's not much in that little space. So that's my summary and my expertise of odontoids.
Those are good pearls. Thanks, Jim.
All right. So I have 20 minutes. And so Charlie, yell at me when I become like 15 minutes because I tend to babble. So what I did is I kind of got this talk and I was thinking about, well, where was I? And it's kind of scary because it's almost 25 years ago when I was in other people's position. And so I thought what I'd do is I'd take you people through a routine of spinal cord injury, but do it a different way. And it's either going to be, I'm going to go up in flames. It'll be on the internet for the rest of my life and people will use this against me. And I will tell you the story about the lawyer that presented my Seattle Science Foundation video while I was defending a doctor, which didn't go well for him. But that'll be at another time. So I'm going to go through and these are my conflicts, which really shouldn't have anything to do. And I'm not going to talk about the companies I have relationships with. Spinal cord injury has drastically changed. And if you're old enough, and you might remember the aneurysm patients, used to have a subarachnoid hemorrhage and you sort of put them off to the side and then people would operate on them. And then they did a study and they said, wow, maybe if we operated on them early. And that's sort of one of the evolution of spinal cord injuries. And so when I started, if you were an Asia A, people put it on it as like, yeah, whatever, whenever I have elective time next week, we'll operate on them because it was a finite thing. And I guess the one message I want to get out of everyone's here is spinal cord injury is not finite. And if you look at the people nowadays that are even years out, they're showing the potential to recover. So that is unbelievably a message. And I think one of the things we've done in the last 20 years is operate on them earlier and understand that perfusion to the spinal cord is necessary. And so the big question is, well, have we changed anything? And this goes through the last 20 years or we look at it. The conversion rate from an Asia A, and I'm assuming everyone knows what an Asia A is. And Charlie, I'm hoping we're getting all nods.
Yeah, everyone's nodding.
Okay, so Asia A's were about 5% of people were complete. They converted. The interesting thing is it's almost tripled now. And if you follow your patients, I follow my spinal cord injuries and somehow I become the spinal cord injury people. I take a lot of chronic spinal cord injured patients. Their conversion rates are unbelievable. Like nowadays with an Asia A that gets early surgery, I almost assume they're going to get some function back in terms of a B or a C. Unfortunately, most of it's not a functional recovery, but it's pretty interesting. So if you look at this stat, I mean, we've gone from about 10% to almost 30% of people getting some recovery. And really, when I go to Charlie and I go to Jens and I say, well, what have we done differently? And the answer is crickets. There's not a lot we've done that where I'm like, oh my God, we're so much better than we were before. There is no FDA drug right now for spinal cord injury, unless someone can think about it. The only thing you can talk about is steroids, where I'm like, okay. And we're going to discuss that really quickly, but we're going to talk about it a different way. And that's it. All right. So what I want everyone in the group is to sit back and think about this from the perspective of when you're 50 years and getting ready to retire, I want you to say this problem has been solved. And so one of the biggest problems we have in spinal cord injury is we don't have a very good outcome measure. And it's hard to, it's hard to say that when you think about the Asia classification was set up 50 years ago by the rehab doctors and probably was the first outcome measure in spine. It's still, when you look at it, about 20% of the patients that come in trauma, we can't get a very good exam on them, even doing everything right. And if you've ever seen the rehab doctors do an Asia exam, it takes them about 40 minutes. And I can tell you that I do a pretty good Asia exam, but I don't spend that much time. So I think the first thing that you guys need to do is figure out a better Asia exam and a prognosis. And this is for my orthopedic spine fellows out there. The BC reflex is useless. So you can save time off the bat and not even do it. There was many years ago when I was a resident, they used to talk about spinal shock. There's a great paper by a guy named Dutuno that shows that spinal shock is it's all over the place. It's not a prognostic indicator. It's probably more of a prognostic of how bad your injury is. We looked at the NACTIN data and basically showed that the BC reflex has nothing to do with outcomes. So the second message I want to give you guys is don't believe everything you taught. All right. If you have Kojo as your teacher, you got to look at yourself and say, did that guy really just say that? That sounds stupid. It might be stupid. Sorry, Kojo. I just, you just happen to be the guy who's like, I pick on Charlie all the time. And why I want to say that is what you learned in medical school might not be right. And it's so funny because I'm, giving a Zoom talk, you get no feedback and you're like, I wonder if I'm still connected. But here is everything we've all learned about. And when I went to medical school, and I'm sure everyone is, Netter's things, this is how the spinal cord is. It's not that way. If you go back and you take a primate and you cut their corticospinal tracts, who thinks they can walk? They absolutely can walk because the corticospinal tracts might not be that important. So Schneider came up with the concept of central cord injury. And you got to remember, this was a long time ago and they had myelograms and patients. Actually, if you go back to Schneider's original paper, he recommended we don't operate on central cord injuries. But this is an autopsy from a guy named Bungie, who's down in Miami, who's done a lot of work on this. And these are central cord injured patients. And so if the central cord injury was what happened, how come all the dead axons are not in the central part of the cord, but they're all in the periphery? And it's probably because our hands have evolved and we have many more hand neurons than other things. If you have some time or want to read a paper that's extremely well written and it talks about this, it goes through that our understanding of tracks in the human spine are probably spinal cord are not where we need to be. And this is where I'm hoping we're going to evolve with MRI in different areas. So far I've told you our exam stinks and our understanding of anatomy stinks. Now I'm going to switch gears. I'm going to talk about steroids, but I'm not going to do what you guys think I'm going to talk about it because we've beaten it to death in a million years. It is probably the most publicized neurosurgical pharmacology paper that you could ever imagine about. You remember there's 3 different NASCUS? Has anyone ever heard of NASCUS 1? Has anyone read NASCUS 1? I can tell you it's crickets right there because no one's ever heard of NASCUS 1 and no one even looked at it. It was a very interesting paper and it was published in JAMA, which is kind of interesting. And it was a negative study. And it was, you go back and one of the reasons I'm giving this talk is because I want you to say, all right, if I'm doing research, where do I learn from my forefathers? And this is a great paper to read because the problem with it was what? The problem is they didn't understand the drug and they didn't look at the drug in terms of what do you need for doses in a rat versus what you need in a human. So they had some assumptions that steroids were good. So we're going to give a little versus a lot. The problem is a lot they didn't understand. And they had to give 10,000 milligrams is what you give for the trauma, the solumetrical protocols now. So it's kind of interesting there. So the lesson is understand your drug if you're going to do a pharmacologic trial. The second thing that's kind of interesting is this study failed on every freaking dimension. It failed on the fatality risks were 3 times higher in the higher steroid group. The pulmonary embolisms were higher and the infections were higher. And so I always go back and I'm like, why would you do a study that was completely a failure and then go on to a second study? And if you look at it, and that's an interesting question. I'm not going to say, this is a pharmacologic study and it was made by a company called Upjohn. I'm not going to say that because that might be implying that there was a relationship. The second thing you have to understand, and you guys probably weren't around, and Charlie, Jens, you might be around for when this happened. There's a lot of anxiety and hatred in the neurosurgical community about steroids. And to understand why is kind of interesting. There's been almost a desire to get rid of the drug. So I'm going to go way back. And I don't know if you guys know this, but when NASCAS 2 came out, the NIH actually sent a fax to every hospital in the country saying that this drug needed to be used for spinal cord injury. This is before the embargo was lifted on the med, and it was before anyone had seen any of the papers. And so it was kind of the neurosurgical community, but very upset about this because people were giving spinal cord injury dosing drugs to their patients, and no one had an idea what the paper was or what anything. And I think that's one of the reasons why the hostility of the paper. And so the message here is, if you have something, embrace it, educate everyone, be transparent, and there might not be as much hostility on the second side. And if you go through and you don't believe that, you could go back. And again, I'm not trying to say anything. I'm just trying to educate the room. Charlie, you might hate me for this, or you can make a comment. There is no data between 2000 and 2013 where the articles came out in any spinal cord injury that I know of that significantly changed the amount of data or papers out there about Solumedrol. However, the conclusions go from you could use it as a tool to you definitely should not use it. So again, our emotions get a hold of us a lot when we do research. So try to be emotionless. All right, I'm going to digress in a little second, but I just want to make, you guys have probably never heard of the word Cygen. Cygen was another study, and we'll go into it in a second, but there's a guy named Geisler that did this. And Charlie, tell me if I'm running out of time, or if I have to hurry up.
9 more minutes.
Huh?
You've got 9 more minutes total.
9 more minutes, then I'll speed up. So anyways, steroids in 2010, 2009, 2010, this is an Acton study. This is an Acton investigators. We published this because I wanted to see what influenced the drastic decreased use in steroids. Does anyone know what happened in 2009 and 2010? And I'll tell you the answer is no one does. We tried to figure it out and we couldn't figure it out. I think what happens is for a message to get buy-in by everyone takes several years. And so there was multiple debates and different things, but it's kind of drastic how this just dropped off like that. All right. So really quickly going through Cygen. Cygen's an interesting study done by Geisler. The whole theory about it is you have these membranes on your neurons. The thought that is if you stimulate them, it gives you neuroprotection and also does neuronal growth. This guy Geisler at Charlie's institution published this study, did a single study, randomized, it wasn't randomized, it was a study using this drug, GIM1, and got a fantastic result. And hubris is a bad thing. So he came out, and if you've ever met Fred Geisler, the greatest guy, extremely nice, came up with this thing. And this was right at the same time NASCAS 2 came out. And him and Bill Coleman, who's another great guy, who's a statistician, were like, we're going to show that this drug is so much better. They got significant marked improvement, 50% versus 7% by using the drug. They then went to the FDA. And what's the problem with going to the FDA? The problem with going to the FDA is they're bean counters and they're about safety. So if you're going to make a bar, they don't care what that bar, they'll discuss that bar with you, but you need to achieve that bar. If you do not achieve that bar, they will not approve you. And so it's very interesting because if you'll notice nowadays, almost every study is designed as a non-inferiority study. These guys came up with we're going to improve something called a benzyl grade, was on the benzyl we all know and love. It was a walking grade. It was unbelievable to say that you were going to change a spinal cord injury 2 grades out of 6. So they didn't meet their metrics at 26 weeks. The interesting thing is if you go back and look at this, and I came to you and said, hey, listen, you have a spinal cord injury. I can get you your recovery in 8 weeks versus 26 weeks and speed up your recovery by 3 times. You'd be like, I'm buying that drug. The second thing that's really never been brought out about this drug is it shows that there's definitely an improvement in bowel and bladder function. But again, those weren't their metrics, and that's what they didn't look at. So you have to be very clear with your endpoints. Otherwise, you're not going to get FDA approved. So another lesson learned. And now I'm going to sort of fly through this part because these are some of the more interesting things, but I want to. Cetrin was a drug that blocked your no-go antibody, or your no-go with your apoptosis receptor. This study was really interesting because what they did is, remember how I told you spinal cord injuries is progressively improving over time? They looked at a control group versus them, and they showed, great, we're twice as better in terms of our improvement in our cervical patients. And this was the second reason of no more thoracic studies got done in spinal cord injury after this study. Why? Because the thoracic injuries are probably too great. They're too high of mechanisms of injuries and too bad a blood supply that pharmacology things are not going to fix them. And so we published this, whatever. But the long story short is it closed because it wasn't successful. Now we're going to skip over, and I'm going to try to give you a couple lessons we learned. Macrophages, you ever wonder why peripheral nerves heal so well? You sew a nerve back together, they do well, the spinal cord doesn't. There's a huge thought that macrophages come in and clean out the area. You do not have macrophages inside your spinal cord. So they came up with this study where they're going to inject macrophages into the spinal cord. And this was, it actually was started in Israel, but it's a very interesting study where they injected macrophages. Safety study was very effective. And here it is. Ready, Charlie? Tell me if you're going to buy this drug. I'm going to give you a 27% conversion rate. Now, you got to remember, at that time, it was 5% conversion rate. So you're like 27%. Love that. The problem is the control group had a 59% conversion rate. And so obviously this study failed. But there's 2 things that came out of this study. People were so selective on who they decided. They only decided on the patients eligible for the study were the greatest patients for conversion. That's why I think the conversion rate was so high. And no one ever brought this up, which was kind of interesting. Did the injections actually hurt a significant portion of patients? Unfortunately, we kept on going on with these drugs. And the same thing happened in Riluzole. Looking at a control versus a randomized control, it failed. So you have to do things against an equal group. But I'm going to switch the gears a little bit. Stem Cells Inc. is Asterias. Asterias was a company that did injections into the spinal cord. Another study that had unbelievable guidelines to get into the study. What did we learn? We learned that you shouldn't use MRIs and cross-links over the spinal cord. And so it changed our practice, and it changed my practice now, because in order to get into a stem cell trial, you have to have a decompressed spinal cord injury, a decompressed spinal cord. So I've gone on and I've decompressed the spinal cord at these levels. So Stem Cells Inc.'s next study came on, and this is where we learned, which is kind of interesting. When you get the MRI on the patient, you see a bruise, you see an area. However, when you get an ultrasound on the patient and you follow them later, you understand that there's a cyst inside the spinal cord. And that's the prognosis area. And so we started doing ultrasounds. And if you probably realize, ultrasounds are much more common in spine trauma. So we noticed that as that cyst. So next came up is this company called In Vivo, who we just published. It just got accepted. I can give you guys a little heads up on this. The paper is coming out, but it showed that the trial didn't show a difference in the randomized control trial. But what we learned is that you can put, let me see. This is the spinal cord, and this is from Don Korek. So this is an injured spinal cord, and what I learned on there is the spinal cord needs to get perfusion. When you have a trauma, you have this cyst in the middle of it, which, as you can see, under pressure and comes out. But not only that, it's a very proteinaceous, probably not very good environment for your neurons to get better. So this is where we did a myelotomy, and here you can see Dom's better surgeon than I am, did a beautiful job, decompressed the spinal cord, and then you put this catheter, this cyst in it. And the real reason isn't, the real reason, again, I bring this all up is these are all things that weren't part of the study, but you can see we were evolving and we're sort of understanding all this different stuff. This is a rat study and it showed sort of the same thing, but I won't really do it. The important thing I think I learned about this is one is your arachnoid is very tough around the spinal cord. And so when people are talking about doing duroplasties and dural expansions, I'm not sure that's going to be good enough to perfuse your spinal cord because your arachnoid is still, your spinal cord can only grow that much. The second thing you're going to learn is no matter how bright you are or think you are, if you go into the literature, you're probably going to find a paper where someone had a similar idea. So this is 1911. This guy named Allen did the exact same things in Philadelphia on dogs and showed that a myelotomy improved their outcome. And I think, again, that really has to do with their spinal cord injury and ability to perfuse the spinal cord and save the neurons that can be saved. The last thing, Charlie, and I know I'm coming up against my time, is this is Susie Harkema. And if you're a young person, and I think the biggest area of advancement in spinal cord injury is going to be through neuromodulation in the next 10, 20, 30 years. What she did is she used the workman's comp spinal cord stimulators and took chronic spinal cord injured patients and stimulated their spinal cord. And the way this is thought to work is the electricity goes through the ganglion and it causes sprouting. And then by training the person, and this is the whole physical therapy, they're able to do motion. Now she's got like probably 30, 40 patients that she's had trials which showed neurologic improvement. But and these are her slides, what you don't hear a lot about is there's so many other different areas that are improvement with these stimulations. The people aren't having, their bowel and bladder functions have changed, their neuropathic pain has changed, their cardiovascular functions improved. So I do think, in summary, spinal cord injury is evolving. I think you guys are going to continue with the path and push us forward. And I just wanted to give you a highlight of some of the struggles that we've had. And that's it, Charlie.
Thanks, Jim. That was
Are you awake still?
Insightful. Yeah. Thank you so much. Any questions for Dr. Harrop? Yeah, go ahead.
Just curious what your thoughts are on lumbar drainage with spinal cord injury.
Can you tell us where you're from and your name, please?
Sure. Brian Glenn from Tulane, on 7th years. Yeah, I'm interested to know your thoughts just about lumbar drainage, when you have a spinal cord injury, and then if there's ongoing compression, is that something that you try to improve the perfusion pressure before or after the decompression?
Hey, Charlie, can I get my slides up for 1 second? I'm going to answer his question extremely quickly. At least here you go. So here's the deal. I am a huge advocate of spinal drains. I think the issue with spinal drains is what? It's all about perfusion of the spinal cord. This is a study that Nick Theodore did where you look at people, and remember, this is the top graph shows autoregulation. The bottom graph shows on the left a rat, normal autoregulation, and then when they get a spinal cord injury, they lose all their autoregulation. Nick Theodore did this study, and I think it kind of summarizes things up for me. The red line is when we jack up their blood pressure, which we do now. The blue line is a spinal cord injury. The purple line is if you use a lumbar drain. But if you synergistically use them all, you get the green line. And the reason why is when you jack up their blood pressure, I think you get an arterial effect, which is nice. And then when you put a lumbar drain in, I think it helps on the venous side. And so if you're a neurosurgeon, you know what an AV fistula is. And so I think by letting vascular outflow improve, you're now letting the spinal cord get blood in and out. So I've been putting lumbar drains in all of our spinal cord injuries that are B's and A's. We at Jefferson are very aggressive, meaning that you have a spinal cord injury, we usually take you from the emergency room right to the operating room. And so our tentative protocol is operate, decompress, put the lumbar drain in the operating room, or shortly after, and we usually do it for 3 to 5 days. I think I answered your question. It was a little hard to hear.
The microphones are the small black doodads in front of you. Just push on it, the light will come up and you can answer. So you can ask the question.
Can I see a raise of hands to see how many, at how many institutions you're using lumbar drainage in the setting of spinal cord injury? Maybe,
Still less than
maybe
50.
20, yeah, like maybe 20, 30%.
20, 30%. This is, and if you want to read a paper that no one's ever read, that this is Brian Kwan's work. I will tell you this, and the reason I changed my attitude towards it is, one is the safety data on it is very good. So if you look at all the studies that have done, most of them have been by Brian Kwan, there hasn't been neurologic injuries from them. Number two is you're talking about a population that's usually young, healthy people. And so my attitude tends to be anything I can do to help them. The third thing, and this is kind of interesting, this is again Brian's work in neurology. I don't know if you can see the whole paper. He showed that if you can keep their perfusion pressure above 55, they tend to have a significant conversion rate improvement versus less than 55. So again, all this stuff I think tells me a lot of it's about perfusion. And I went back and I showed you the improvement that we've made from 10% to 30% conversion rate. The only things I think we do differently, and Charlie, Jens, and you guys can chime in, is we operate early and we jack their blood pressure up. Otherwise, and those both to me mean that we perfuse their spinal cord better. And so that's why I think lumbar drains do improve perfusion.
Okay, that's great. Thank you so much. So we're going to move on to our next lab demonstration. It's going to be with Dr. William Cross, the SI joint fusion techniques using a principles-based approach.
All right, I can take it away.
Yes, go for it.
All right, sounds good. So we'll start off. So the patient's prone, the head is to my left, legs are to the right. And so the way I start this off is, so I have not templated this case, so we're just doing basic fluoro inlets and outlets, but I don't have that CT scan that I showed at the beginning of my talk. But so with that being said, I'll start off with that fluoro. So this is the PSIS. So I do a circle on PSIS. This is the back of the femur. So I extrapolate mid-shaft of the femur, and I draw a line connecting those two. This gets divided into thirds, and my typical starting point is usually around here. And the reason I do this is because if this is the PSIS, this is an outline of the ilium. So up here is the belly, which is a no zone, and down here is the greater sciatic notch, which is a no zone. So this is a pretty safe area to kind of put your pin to start off with in the prone position. So I start off with a small pin, and I kind of poke this in here. I don't use the big pin yet because if I need to kind of go in and out, I don't want to hurt or injure any local soft tissue. So I'll go in about halfway, and then I'll check an outlet view. So I'll take a shot here. Outlet view, as a reminder, is having the symphysis overlying S2. Just because of the table setup, we can't quite get high enough on there, but I'm going to extrapolate that we look pretty good there. I can see the border of the S1 foramen, and I'm looking like my trajectory is pretty good here. So we're going to switch to the inlet view now to go anterior and posterior. This view, the outlet view, is for cranial caudal orientation. So once I get my trajectory perfect with this pin, then I'll switch to the other pin. So here, so you can see I'm more posterior, so I need to translate anterior. So in line with my outlet view, I'm gonna make a shift to go anterior, which is gonna be this way. And now we're just gonna shot there. Okay, I'm gonna go just a little bit more and aim posterior. Go in, aim posterior, and I'm on bone, shot there. Okay, I'm gonna aim more posterior, shot there. So we're looking pretty good. So I know I'm pretty good. Let's go to the other view. So now I'm going to make a small little incision, usually about 1 or 2 centimeters, right below that pin. Okay, now I take the 3-2 guide pin for the set, and I use this step. I usually say kiss the tips. I'm going to right down there and touch the tip of the other one. And now I'm going to go ahead and do fine tuning. Okay, let's take a shot there. And I'm gonna aim a little cranial, shot there. Okay, so I'm looking pretty good to end right in the middle of the vertebral body of that upper sacral segment. Now I'm gonna check the other view. Those inlets and outlets are the workhorses. Okay, and we're looking pretty good there. That looks great. So I'm gonna aim a little bit posterior, and I usually do a little tap, tap, tap to cap in the periosteum. And then I use the pin driver on oscillate. Always oscillate so you don't bind up any of the soft tissues. And then I oscillate a centimeter, and now start checking your views again. Shot. Okay, I'm gonna mill it a little bit anterior. Shot there. Okay, now I'm gonna shift the drill so that it aims at my beam as a mental crutch on which way to move my drill now. All right, go to the outlet view. Never let go of your pin, you're always holding it. And we're looking pretty good there. So I'm gonna advance across the SI joint, and I'm gonna go, shot there. I think I'm trending a little bit cranial, so I'm gonna back it out, and I'm gonna mill it and go a little bit caudal. Shot there. Okay, shot there. Okay, so it looks like I'm gonna go right above S1 and right below where L5 is coming over the brim. Now let's go to the other view. I'm gonna shift my drill to aim at the beam. Hopefully I'm going directly midline on this view. Okay, there we go. So we're looking good. We're gonna be behind that border. So I kind of go in and out of the drill and I sound it out. Shot there. Shot there. Okay, so I don't like to cross midline because if I do bilaterals, I want to maximize my distance on both. Okay, let's go to the other view. Well, I usually save that X-ray and then, all right, take 11 blade now. Well, this blade, the reason I can only do a small incision because I don't know if my incision is going to be more there or more down. So now I'm just going to kind of aggressively make about a 5 to 6 centimeter incision just in the skin. Then I take this, I go right down there. I don't do any cutting. I'm simply just slicing the fascia right on the pin all the way down to ilium. I'm on ilium. Take it straight out. Then I think this step helps minimize glute cramping. But I put my finger right in that fascial rent. I go right down the ilium and I clean out the fascia and I go right, put my finger right on the iliac wing and I kind of just spread out and detach some of the gluteus medius and minimus from the lateral ilium. So it's right on bone, okay? After that step, I'll measure. So in this particular case, we're measuring a 75. So I'll take a 75 by 12. Now, if I templated that safe area there to be 15 millimeters or more of space between S1 and the top where L5 is, I'll put a 12 millimeter implant in. If it's less, then I'll go to a 10. If it's even smaller, or I'm going underneath a pedicle screw that's in S1, we have an 8 millimeter that can go there. So we dilate up, dilate up, dilate up. And then this one goes on the top, and these tines there just gently go into the ilium to lock everything in. So we just put that right on the iliac wing, and we just do some gentle taps. Okay, now that has locked into the ilium. It's not gonna move. We don't want it to move, and I want that pin to be right in the middle, which it is. So now I'm gonna take a 3.2 millimeter stabilization pin, and I'm gonna go right here, and I'm just gonna go on reverse, not to bind up soft tissues, and then I go on forward. Okay, one more pin. Okay, now this working portal goes in, and this is where you're gonna really help control the distance, because I wanna be able to decorticate and completely take out the SI joint and really scrape out kind of any arthritis and articular cartilage in that area. So I'm gonna use a 12 millimeter drill, so like any cannulated system, I'm gonna pre-drill. This particular pre-drill is a 7.5. So right down there, so I'm feeling the SI joint, so shoot right there. So now I'm up against the border of the SI joint. I'm gonna go in across the SI joint. Okay, I can feel the other side. Now I'm gonna go swallow up the pin. Shot, shot, shot. Okay, so we swallowed it up there. The pin's gonna come out. And I'm gonna put another pin in its place. And now we're gonna drill down to the SI joint with a 12 millimeter drill bit. And this is what is gonna help kind of create the fusion zone. And this is also where I'm gonna set my depth. I'm gonna, all based on tactile feedback and fluoroscopic feedback, I'm gonna go right to the SI joint. So that's lateral ilium. There, that's SI joint, I just hit it, shoot. So that's the side of the SI joint. So now I'm gonna take this guide and go to the laser line, and that's going to tell me where the lateral border of the SI joint is. Then I'm going to go across the SI joint. I just crossed it just a little bit of a zip, and then I'm on the other side. So now I'm going to go just inside that black line. So now I'm going to go a little farther and get bone graft. Okay, so as this comes out, this is all bone graft or autograft from the ilium that we're going to recycle and inject into the fusion zone as part of an autografting technique. Now, this is the decorticator instrument. As you deploy this, this goes out and out and out, and as you go around and around, it scrapes out that SI joint from the inside and gets rid of all that cartilage and arthritis in this fusion zone. So let's take a picture there. So you can see that the cutout is where my blade diameter is. I'm going to go in another couple millimeters. Shot there.
So I just want to point out to the audience, I think one of the advantages of this is that you're working basically perpendicular to the joint. So, this gives you the latitude to sort of swing that thing, circumferentially to ream out the stuff in there.
Thank you. Yep, I thank you for pointing that out, because there's also, as a biomechanical advantage, if you're perpendicular to the surface and you provide compression across it, it avoids a shear effect. Where if you have a joint that's in this angle, but you go across it like this and you compress it, you could create a subtle shearing effect. So we really want to compress it in line, which is the most biomechanically favorable to kind of get that tongue and groove to perfectly articulate, go back to where the patient's normal anatomy should be, and it'll compress into that native position. So then as we're doing this, based on templating, we can figure out how far we're going to go out. This guide will tell you how far you're decorticating out. Right now, we're about 30 millimeters of maximal diameter, up to 40 total. Let's do a shot there. You can see us going down the SI joint, and then as we go the other way, shoot here, we're going up the SI joint. So on templating, we can find out how far we want to decorticate without coming out anteriorly or posteriorly. So I'm going to go here, and I'm just going to do a kind of a hemilunar just caudally, because I don't want to come out the top. Okay, so here we are all the way out. Let's do a shot there. So all the way out in the bottom, so right down the SI joint. So what I'll oftentimes do now is retract it, and then using this length guide, I'll sometimes come 5 millimeters out or 5 millimeters in to increase the depth of my SI joint fusion zone for bone graft. So just for the sake of time, I'll not do that for this test. And then here, as you pull this back out, then you'll see strips of cartilage and also bone graft in here that you can recycle as part of the autografting technique. So now what we do is we're going to irrigate all of the contents of the fusion zone. So we put the irrigator in there. I plug the suction device, put the suction or the irrigant in here, and squirt it out into the SI joint, and then it comes out, and we collect it into this basin. So I've got to pull out here. You'll see some graft come out here. All that is the decorticated bone that we just kind of ripped out of the SI joint. And usually just by convention, I always just use 2. Okay, so we've kind of cleaned out that SI joint. Now, we open up our suction device, and my residents tell me this is like when we pan for gold. So we're taking this out there, and then we're usually left with a fair amount of graft in here that we can recycle to kind of put back in the patient. Okay? And then I go down here and I clear out all of the debris from the fusion zone. Usually we're left with a nice little radiolucency. Let's do a shot there. Shot again. Okay, so there's a nice little lucency in there from that decortication. So now we'll take some bone graft. So this is the bone grafting step. So this is a bidirectional bone graft application. So I'm just going to squirt out just a little bit to show you what this looks like. But as I inject this into the SI joint, it's going to kind of come out the sides, just like that. Okay, so we're going to push that into the SI joint. Let's do a shot here, please. Okay. Now, could you do live fluoro on the machine? All right, watch as it deploys. So we're going to fill that whole area up with bone grafts. So that's all the autograft in that large fusion zone. Okay, off. Now we take that back out. We're going to put our 3-2 guide pin back in. If you can't get it, we usually put it in that first dilator, which puts us directly center, push the pin in, and ideally, if nothing's changed, that should go exactly into the hole that you drilled. And if it's not going in there, check all of your imaging again to make sure you're still safe. Let's take a picture there. Okay, we're safe there. So now we take out the inner core. We're ready to put the implant in. Usually has a big clot on it. And now we're going to take a wire driver that's empty so I can pull out my stabilization pins. I'm going to take one pin back here and then the whole drill bit back here. Okay, and now we take the implant. So this is the implant right here with bone graft all in the fenestrations here. We'll put that over here. And now to make sure I don't drive the pin in, I take a shot about every couple centimeters. Picture there, please. Shot there. Shot. Okay, now I'm gonna kind of wiggle, pull this guide out. And I put my finger underneath the washer. Take the, Joe, now I'm feeling it go down on bone. So now it's flush on the ilium right there. So now, we didn't practice this view yet. Let's see if we can get it. We're gonna come to an AP view. We're gonna roll back about 20 or 30 degrees. So what we're doing now is looking down that PSIS, and we're gonna be able to see if that washer's flush on the lateral ilium. This is that view that I also showed in my lecture where we're compressing that SI joint. So I really like this step because you can actually watch that dynamically. Good, this looks pretty good. So that's that flat border is the wall there. So as I'm gonna do a little quarter turn shot there. So you see it compressing down there, and now we're going another couple turns, shot there. See it's still seating and still moving. So I'm gonna go get greedy and do another couple turns. Shot there. Okay, now it stops. We're kind of riding that line. So now I'm gonna take this out. We're gonna put in an anti-rotation screw to really help lock it in so the inlet view. I usually, if I can, put 2 screws in, although with compression, I don't think it's absolutely necessary, but I like to put 2 on there. Yeah, this way. Yep. I like to put 2 on there just to kind of be safe. I always got a little bit of an insurance policy. All right, so guide pin. So if I'm directly below my implant on the inlet view, I should not be able to see this on my inlet view. It should be hidden beneath my primary implant. Shot there. And that looks pretty good there. I'm a little bit anterior, so I'm okay. Shot there. Okay, let's go to the outlet view. So now, wire driver empty. I'm gonna put it in just about a centimeter or so to lock it in. But this is a smaller collet. And this one is typically aiming right at the S1 frame, and so you don't wanna put it in very far. So take a shot there. Good, so we're gonna go, it actually looks like it might go below the frame, but nevertheless, I'm gonna stop short of that S1 framing. Get on, oscillate, shot there. Shot there. Okay, shot there. Okay, so we're looking good there, so that's where the anti-rotation screw is gonna go. So I take everything out, we measure, then I'll take the drill next. Okay, on ilium, and I'm measuring a 35. So we'll do a 35. And so this is just the pre-drill for the other one. I just punch the outer cortex, and I don't wanna plunge. Okay, and then sometimes the drill pulls it out. So just out of habit, I lock this in there and pull the drill. I don't want to lose my pin position. And if the pin is staying in there, fortunately, so I'll lock it in there. And then we're gonna put our 35 millimeter anti-rotation screw. This is just a 6.5 millimeter, just a random screw to provide that anti-rotation support. There's just a neutralization. There's no compression associated with it. So as this kind of goes in, reverse to clear the soft tissues. And then I go in a little bit, shot there. This will occasionally drive the pin in, so usually I won't be quite that aggressive. Shot there. Okay, now I'm gonna switch to hand. I'm gonna pull that pin out just a little bit.
So what's the width of that second screw that you just put in?
6.5.
And how about the proximal and distal width of the first screw?
The primary implant on this particular patient, we put in a 12. And so it's a 12 millimeter outer diameter, 7.5 inner diameter. Shot. Good, so that's our kind of our final construct there. Let's go to the other view. All right, and there's the inlet view, so you can't see the anti-rotation screw, so you know that it's directly below that implant in a safe position. So that's kind of the SI fusion construct, so. All right, yeah, anybody have any questions I can answer about the procedure?
Any questions, anyone? Maybe I have a question, I guess. Do you ever put anything other than the autograft inside the bone chamber?
So yeah, so I'm still experimenting, trying to find that perfect concoction. So right now I'm doing just the autograft and, you know, whatever we have sort of on contract for bone graft extender. So just, I've been looking at some different brands and some different constructs, but usually something that's osteoconductive, and then sometimes something osteoinductive to help support the autograft, because the autograft harvest is somewhat variable between patients. Like, a little surprised that we got a lot out here, but sometimes very osteopenic patients, it can be just a little bit of autograft and you have to supplement it with more of the bone graft substitute.
Cool.
All right, I want to thank you to my team right here. So outstanding job from Mark the fellow, so thanks.
Thanks very much.
Awesome, man.
So yeah, next item on the agenda is a group photo, so everyone should meet in the SSF lobby.
Wear your SSF course shirts.
Oh, okay. So I think for Anna and I, we're both leading. Yeah. I was gonna send an email with. Tomorrow's my last day because Monday is the day I'm heading out. So yeah. Yep. Yeah. That was good that you like followed up though. Yeah, I was right. Yeah, that makes a lot of sense. Yeah. Great university. Yeah. It'll be an adjustment for sure. But, yeah. I'm excited, yeah.
I don't know.
Where are you at for residency? There we go. That's right. Yeah. Because of the endo stuff, right? Yeah.
Other coast.
Yeah. Last year's guy has a good attitude, so. People like him.
Oh, we got a Don t-shirt.
Yeah. I'm Alex. Yeah, Alex, I'm Rafa. I'm a 5 at. Oh, nice. Yeah.
It also takes, they did a discount.
Yeah, that's why I don't. But he's drinking Kool-Aid, he's gonna do everything.
Yeah.
Yeah, exactly.
I'll take the D-tracks. Yeah.
Yeah, I don't know, for some reason.
Yeah, it's nice. I mean, for patients, you know, it's like one of the only true MIS cervical posterior approaches, you know. But yeah, standalone doesn't really make much sense. It could be kyphogenic, but yeah, backing up an ACDF, yeah. Yeah, it's, especially if you want to get a little head restoration for really collapse the CM2 joint or something. Oh, okay. When I talked to her, she said she was having like non-positional headaches, she's still kind of crummy.
Yeah.
Maybe she's just sick.
Yeah, she's not.
I don't know how long I'm just getting lucky, that's all.
She's got like a mile.
Let's see, so, yeah,
That's sick. Yeah, okay.
They're just, she's on the.
Have what? Oh, okay. Yeah, I talked to her, whenever that was, 2 years later. She kind of had malaise, seeing her leg hurt, like, these are legs, like, wow, it's like 2 at a time. So if I except for she's kind of crummy, so maybe she's got sick. Once in a while you get weird, like, generalized symptoms like that with Yeah. Okay. So she got admitted?
Yeah, Austin said she came in this morning.
Okay, cool. What else are we not here, huh? Oh, was it? Yeah, Luke came last year, bro. I thought Luke said he wanted to yeah.
I'll take it from here. So you're doing.
Yeah, I guess.
Yes. Yeah. It's much easier. I appreciate it, Charlie. I had no idea. It's like this. I don't know if you guys have. It's like it's a Zoom. We have like these med students that come from Miami and all over, and they do like a 9-week project between first and second year. It's run by Alan Levy, and Nitin build out on judging. We have one person, so we have a site. It's like 15 sites, and now I'm like conscripted to be the judge of their presentations of their work. I know. I was like, oh, it's so painful. I was like, God, this is all Nitin's fault. He's like, oh, meeting, we have to do this. It's like, man, he makes me work harder than I want to work. I know, right? But he's pleasant. He's pleasant. I know. I know. You know what's amazing? He's like the Wharton MBA is more popular than any MBA because in Maryland he could have, in Pittsburgh, with discounts and whatnot, he could have done. You do that Maryland, or you go back to like you go what? But it really like it's a good time to maybe not one. It's like 10 right. It's he goes like Friday morning, and for us it takes like a 6 a.m. flight. I think I can stop on time on Friday. But if you did it in Maryland, like, so the whole thing has to do with first. The whole thing has to do with you're gonna be like on soccer. So you just did a Maryland, get all the discounts. But if you're paying, yeah. Well, the question is, what do you have? All right. No. Out of what? Oh, please. That's because you didn't even crack the book. You got it. Like, you only had like this, thing, and then I've never looked at it. Just steady with you. I just have because every 2 weeks. Yeah. You just can't. You can't live in this state. He doesn't know. Ready? Yeah, well, we're trying. I'll be happy to. So I know, right? Look how big they are. Wait, you don't even have to start till 9:20. Is Dr. Cho ready? Alright, I'm going. I'm going. Yeah. Different. We're ahead of schedule. Yeah, I'm not gonna mess with it, so. All right, we're ahead of schedule, and whenever we're ahead of schedule, I like to seize the day. So we will get tired soon, but if everybody's fresh and ready, we're gonna get started. Everybody places? All right, action. So it's with distinct pleasure that I introduce Dr. Richard Chua, who's going to talk to us about robotics and spine surgery. He's a professor of neurosurgery and director of MIS and robotic surgery and the medical director at Banner University Medical Center. Thank you.
Thank you, Kojo, and Charlie, I think, disappeared to go get his lab demo ready. Thank you very much, everyone, most of all for the residents and fellows to come out and spend some time, as well as the Seattle Science Foundation, Linda, and the great merch. Wanted to give a little bit of a different talk, so rather than talking about a technique, which you guys are really focused in on, wanted to talk a little bit higher level about robotics and spine surgery. Here are my disclosures. Before I go forward, I left this picture up for Dr. Chapman, of course, who's not here, but he will see it later on the video. How many of you are orthopedic residents or spine ortho fellows? Okay, how many are neurosurgery residents? Oh, we outnumber the ortho guys today. All right, how many of you in your programs routinely use navigation, some sort of 2D or 3D navigation for pedicle screws? Yes, actually less than half. How many of you use or have any experience with robotics in spine surgery? Oh, that's a great number. That's about a third or fourth. And how many of you use any minimally invasive techniques of any kind? Oh, that's really good. Okay, super. So I show this because Dr. Chapman is a self-deprecating guy and always talks about him being a dinosaur. I'm right with him. I'm one of the dinosaurs as well. But over time, I've become a dinosaur converted into a robo-doc or a robo-surgeon. And I hope someday that Dr. Chapman will also end up on that side of the slide. So the outline for today is really just want to introduce you to the topic of navigation and robotics and spine surgery, although a lot of you have had some experience. Talk about how that can translate into early success in your career as you think about your early career, not just training and finishing, but encourage you to kind of take this nugget, which was passed down to me by my father, who's a retired interventional radiologist. And when I finished neurosurgery residency, he said, "You don't know jack about neurosurgery until you start practicing neurosurgery for 5 to 10 years." And so the concept here is you're never too old or too good to stop learning. And so echoed by some of the other faculty, I learn as much probably as I deliver and teach with this course. So anyone know who Mr. Miyagi is? Right, okay. So there's gonna be some Mr. Miyagi pearls as we go through this talk. So a little bit about me, old school dinosaur neurosurgeon, trained in the 90s. Did not learn how to put pedicle screws in from my faculty. We learned that from the orthopedic spine faculty. And many of you may not know, but in the 1990s, there was a really raging philosophy against pedicle screw instrumentation. There were a lot of investigative reports in 2020 shows that showed it was bad, and surgeons that put in pedicle screws were bad and illegal and unlawful. But in those days, open spine surgery was the standard. And so I trained as an open spine surgeon, and a lumbar disc surgery patient stayed in the hospital for a couple of days. Uncomplicated, didn't get out of bed until day 1, walked on day 2, and might have gotten home on day 3. The only enabling technology in the 1990s for spine surgery was use of a microscope. Right, and the microscope's been around for a long time, but as neurosurgeons, we were comfortable using the microscope in the brain, so we easily adapted that to spine surgery. Well, spinal fusions back in the 90s was typically a posterior open lumbar interbody fusion, or the PLIF technique that was popularized by Dr. Cloward. The ALIF technique was just coming around with titanium cages and threaded bone dowels. But look at the typical hospitalization for a posterior lumbar fusion. It was 5 to 7 days, usually 7 to 10 days, Foley catheter for a couple of days, PCA pumps, didn't get out of bed for, again, a day or two. And that was the standard of care, and we had really, really good results. So
But things change, right? Technology evolves, techniques evolve, and hopefully we learn from our mistakes, learn from our successes, and become better surgeons. So in the 90s when I trained, we only had 2 goals for spine surgery: improve your pain and improve your neurological deficit or avoid a neurological deficit. That was it. We didn't talk about all these other things in yellow, which have evolved over the last couple of decades in understanding biomechanics, prehab, post-rehab, spine surgery, and trying to avoid some of the complications. And so now, I hope during your training, you'll not only just think about reducing pain and reducing a neurological deficit, but start thinking about these other goals as you're going into these cases that you're learning how to do the technique. We want to reduce the chances of revision surgery, meaning we want our first operation hopefully to be the best operation and the last operation, but we know that 10 to 20% are going to need a second operation, but maybe we can lower that down to 5 or 10%. We want to shorten hospitalizations, we want to shorten the recovery, and we want to reduce costs. And I think that's something that I did not learn in my training and have had to learn as originally a private practice surgeon, and I hope you'll think about resource utilization cost as you go about your training. So the goals of surgery not only are reducing pain and improving the outcomes, but we want to reduce the morbidity and mortality. And so I've learned a lot over the decades about using minimally invasive techniques, adding navigation, and ultimately robotics. And so that's grouped into that enabling technology group of things that we can start to employ and add to our armamentarium. I'm not going to talk anything about endoscopy. I think I'm a little too old to learn that technique. I think there's a steep learning curve for me, but I did want to introduce you to robotics. So robotics really goes very nicely with the concept and the philosophy of a minimally invasive technique. And so a minimally invasive technique is not about the incision or the retractor or the perch screw. It's a surgical philosophy. And we can take that philosophy and we can adapt it to virtually every operation we do in the spine, whether it's cervical, thoracic, lumbar. Doesn't matter the approach. It can be anterior, lateral, posterior. We should be able to execute those operations and use a minimally invasive philosophy. So the benefits of MIS when I started doing this in 2003 were not very obvious, and there was no documentation or literature to prove that, but we now have 20 years of history and literature to suggest benefits of minimally invasive spine surgery. And you don't even have to look at that list on the left, but just look at this MRI on the right. This is an MRI scan of a friend of mine who's now 58, but he was a F-16 pilot. And when he was in college, he had to have a lumbar laminectomy and discectomy for a disc herniation at L4-5. And if you look at his MRI scan from an open discectomy, microscopic, he has tremendous scar tissue and replacement of fat in his paraspinal rector muscle group. This guy is a triathlete. I don't know how he can be a triathlete after that, but you can imagine your 60 and 70 and 80-year-old patients who have potentially open spine surgery, and you've just torched the erector spinae to do a posterior operation. And so I think if you start looking at your postoperative MRI scans and understanding how MIS can help, and then you can build upon all those techniques to get ultimately a better outcome for our patients. So surgical navigation for me, I was an early adopter in about 2004, and you know the benefits of navigation because a lot of you, most of you are using it. So it improves our accuracy of screws, it improves the efficiency of surgery, it reduces the radiation, but most importantly, there's a growing evidence of cost effectiveness. If we can shorten our hospitalization by 1 day, 2 days, 3 days, we can substantially reduce the cost utilization for our spine surgery patients. And the story I like to tell that my dad used to tell me is, Rick, there's not going to be enough Medicare for you when you become Medicare age because we're overutilizing our resources and spending too much money on things that we shouldn't be spending too much money on in healthcare. So navigation, as most of you know, has shown to be cost effective because we're better at placing screws. And if we're better at placing screws, we're reducing a bad screw, malpositioned screw, neurological deficit, and adjacent level disease. And you can look at all the literature, doesn't matter what navigation device you use, we get to the high 90% accuracy in placing pedicle screws. If you look to the far left, that's open freehand fluoro. If you're honest and you look at the literature, the accuracy is around 75 to 80%. Now, I was an open spine surgeon, and I would tell you I was probably better than 75 to 80%, but in actuality, the literature suggests that's as good as we were back in the 90s. So revision surgery is costly, right? So we may think it's, well, let's just go back in, take out that screw, re-drill a hole, put in a new screw. The average resource utilization and cost for revision surgery is $25,000. That's old number. That number's probably in the $40,000 to $50,000 range now. So yeah, it's just a quick little revision, but it's an extended length of stay, it's more hardware, and et cetera. So how about robotics? I adopted robotics and added it in 2018 after being very, very gun shy early before 2018. And I was intrigued with robotics and the advanced surgical planning. So it's using a computer and my laptop to comprehensively plan my lumbar fusion, not just putting in the screws. And it sort of deserved appropriate criticism early on that with robots were very expensive drill guides, and they were. But over this 5 to 7 years, there's been a rapid escalation in the technology, both software and hardware. So now I use the computer to plan my incisions. I use the computer to plan my pedicle screws and individualize every pedicle screw. I can plan my inner body correction with static or expandable cages. I can plan my decortication for facet fusion. I can even now plan my laminectomy and facetectomy using the computer and some special hardware. So again, robotics takes us to another level of accuracy with pedicle screw placement, but more importantly, precision, standardization of the procedure, and in some cases, reducing the length of the procedure. So with most robots, there's a three-pronged goal, and that is the predictability of planning, the precision of the robot, and ultimately seeing what we're doing by having virtual and navigation pictures as we're placing the screws, oftentimes in an MIS or mini-open technique, or even in the open technique. Those of you that are early users of navigation understand the confidence you feel when you're placing in pedicle screws and you have navigation to guide you. So most robots are a little bit different. This particular robot uses a software algorithm called segmental registration, and that means that the robot is sort of looking for vertebral bodies independent of each other, so that if you have changes in position of the L4-5 segment during the operation or with positioning, the robot can find L4 and match it to L4 on the preoperative X-rays or CT, find L5 independently of L4. And with that type of registration technique, we find that it's incredibly rare to have some sort of mishap with registration and having to bail out on the registration. How many of you have done navigation and ultimately navigation has a problem and you have to bail on the navigation? Right, still happens. With this particular robot, it's a fully independent robot that had navigation embedded into it. So if the navigation goes out during the surgery, you can still put in the accurate screws with the robot, even without navigation. So here's a short video. It's sped up a little bit, but I like to use the CT to fluoro workflow, which is getting a preoperative CT on the patient weeks or months in advance. That protocol is uploaded and those images are uploaded to my computer workstation or uploaded to the robot, and there'll be a demo this afternoon and you'll all be able to put in screws tomorrow with the robot. I can individually plan my screws for the insertion point, the trajectory, the angle, the diameter, and the length. How many of you only walk in thinking about diameter and length? Right, diameter and length is the most important, but if we can individualize every pedicle, we might find that the left L5 pedicle screw needs to be a little bit more convergent than the right L5 pedicle screw, or vice versa. We can also use the computer software to plan multiple screws so that we can line up for instance, in a perc screw case or a multi-level deformity or trauma case, we can line up the rods and the screws in such a way that it makes it much easier at the end of the case to drop the rod. How many of us do all this hard work and then we just want to drop the rod, place the set screws and start closing, and all of a sudden you're effing around for another hour to get the rod bent right and to hit the pedicle screw right, and then tulips bent, and then you got to take a screw out and put another one in. You might even put cross connectors, but with software planning and predictive modeling, you can eliminate all of that. This software also allows us to plan interbody cages, and we can simulate our correction of the spine with the patient imaging studies prior to the operation. We can simulate the correction for a short segment or even a long segment. Sorry, my videos are kind of freezing here. And again, improve our ability to plan an operation and then go into the operating room and just simply be able to execute the operation. On the right side, you'll see the software can allow us to line up our screws to drop a rod. And so we can do multi-level cases, do patient-specific rods, just drop the rod in and adjust our screw trajectory to match the rod. Again, all to improve the outcome, improve the safety, and reduce the complication profile for instrumented fusions. Oh, now I got too many videos going on at the same time. There is a software module in this particular robot that allows us to do planning preoperatively for deformity. So we can take our 36-inch Scoli x-rays, upload them into the robot. Preoperatively, we can plan where we're going to do our deformity correction, where we're going to put our inner bodies, where we're going to put our hyperlordotic inner bodies, and then we plan the correction on the computer. The computer and the operator can then generate the spinal pelvic measurements, both preoperatively and on the virtual plan. You can adjust your surgical technique according to the spinal pelvic measurements, and then walk into the operating room and execute that operation. So we're taking the power of predictive modeling and some AI and be able to enhance our ability to perform instrumented thoracolumbar fusions. For most of the robots, there's 2 workflows to do this. The one workflow I like the best is to do a preoperative CT scan, again, weeks, days, or months prior to the surgery. That scan is uploaded in the computer, and I can plan these operations weeks or months in advance, or I can plan it in the morning during the anesthetic phase of the surgery when they're going to sleep and before positioning. That CT to fluoro workflow then is matched and registered with 2 fluoro shots in the operating room, and that's where that computer algorithm matches all of the imaging. The benefit of that is I can do all of my planning of the surgery before the surgery, walk in, do the shots to register, execute the surgery. The other option is to do what's called scan and plan, and that would be avoiding a preoperative CT scan. But if you have an O-arm or some sort of 3D CT device, do your image acquisition while the patient's in the prone position, then upload those images to the robot and do your planning, and then perform and execute the operation. So just a different style. If you work in a place where your O-arm crew is really fast and efficient, that works great for a lot of surgeons. If you're in a place where they're not so efficient, sometimes the CT to fluoro workflow is better for the surgeon and better for the patient. So the key here is to just introduce you to robotics and understand that robotics is just another enabling technology like navigation, like MIS, that you should be able to apply to whatever technique you're doing the operation for. And so I would argue, I'm not here to tell you that a TLIF is the greatest operation, because most of the time it is a great operation, but the idea is you can apply these enabling technologies to whichever operation you find that patient needs. An MIS or an open, a TLIF, a PLIF, any of the lateral surgeries, we can incorporate navigation and robotic technology, even anterior operations. If you have to do a 360 with an anterior lumbar interbody fusion, flip the patient over for posterior instrumented fusion, great role for robotics and navigation. And whether you're a pediatric deformity surgeon, adult, or mostly degen, trauma guy like me, you can apply these technologies. So how many of you are training or do put in instrumentation first and your decompression last? Yeah, how many of you decompression first and instrumentation last? Yeah, that's been a real change. So in our training early on as neurosurgeons, we were taught to do the decompression first. That's the most important, or should be the most important, and then we instrument at the end. The good news is with these enabling technologies, you use the enabling technology that fits your workflow. So whether or not you want to put your instrumentation in first, there's a workflow for using the robot. If for whatever reason you put in the instrumentation last, there's a workflow to use the robot. So these technologies should not make you change your workflow. And as young residents, you're learning your workflow, right? And you might change your workflow over the years, but don't let these technologies force you into a workflow that you're not comfortable with. Okay, so adding these enabling technologies, especially robotics for me in 2019, allowed me, going into COVID, to look at the opportunity of doing outpatient instrumented lumbar fusion surgery. And so some of you may or may not remember COVID, we'd like to forget it, that we had in Tucson significant gaps in our ability to do inpatient elective spine surgery. For 6 weeks in March through May, we couldn't do any surgery unless it was cauda equina syndrome or a foot drop. Just couldn't do it. They wouldn't let us do it. Then we had times where we could do outpatient surgeries or minimal 4-hour stay before we could admit patients. But I had weeks of patients who were scheduled for lumbar fusions and they're, can you do my surgery? Please do my surgery. So I thought there was an opportunity to perhaps carefully select patients and do outpatient lumbar fusions in the hospital. I didn't at that time have opportunity to work in an ASC. So took these concept, MIS techniques, navigation, robotic assisted screws, extended recovery after surgery, concepts of pre-op medication, intra-op medication, and post-op medication, and we were able to very early on successfully convert about 60% of our, what was previously an admitted elective inpatient lumbar fusion and convert them to outpatient surgery. Initially keeping them in the recovery room for 4 hours, and then 3 hours, and then 2 hours, and now 80% of my lumbar fusions are done on an outpatient basis and they go home within 2 hours. That you can see we did a really, really short study of some of the first patients we did outpatient. They're mostly T-lifts, 1 and 2 levels, including a couple of 3 levels. The surgery time isn't, terrible, and in fact, that's probably the most important indicator of getting a patient out of the hospital is your surgery time. So the results were just a handful of patients had issues with urinary retention. That had nothing to do with the surgical technique. That's on me. I like to give patients epidural morphine at the end of the operation to help with pain control. And for men over the age of about 65, some of whom already have some BPH issues or urinary retention issues, can get urinary retention after that. And so that's taught me to sort of sub-select those patients, and I don't do epidural morphine in older male patients. We had 1 or 2 patients initially that we had kept them overnight for pain control, but otherwise the most important thing was highly satisfied patients. Patients will come to you and come to us and say, I don't want a fusion, here's why. And they've got a lot of great reasons why they don't want a lumbar fusion. But when you can educate patients about maybe doing this on an outpatient basis or a short stay, 23-hour OBS, they love you. They come back, they tell all your friends and family about you, and then you get the friends and family to come see you. So the newest application of robotics is the most exciting, and that was first published last year by Chris Good's group, and that is using the robot to do bone removal. So we've talked about using the robot for placing screws and planning, but not bone removal. And so now we have the ability with this particular robot to do bone removal, which leads us to do a facet fusion, right? And potentially bone removal to do the decompression. So both the laminectomy and the facetectomy. And I'm going to show her this short video because it shows it better than I can explain, but using the computer, using the planning, and using the robotic guidance system, we can use a different drill bit to decorticate the facet joint, whether it's an open or an MIS technique, and then backfill that decortication defect with bone graft. And so now we've been able to accomplish a robotic fusion, not just robotic placement of the instrumentation. And here you can see the video planning the decortication defect, again, planning with the screws and the inner body, verifying the accuracy of where we're going to do this decortication, and then doing the fusion in the operating room. And you all get to see this in the lab tomorrow for sure, and then even during the demo a little bit later this afternoon. So here's sending the arm to the trajectory to do the decortication part, making a stab incision or in an open incision. Going down with a navigated dilator and cannula to the site of the facet, confirming it with the navigation, and then drilling the hole with this special drill bit. This drill bit is designed to pull the bone graft or the facet bone out rather than push it forward. And then once we drill that hole, we can then backfill it with bone graft. This software and hardware was just released late last year, 2023, so we're getting early experience with it. It seems to be, again, very accurate, efficient, and precision way to do this portion of the operation. Here's I call it the caulk gun. My wife won't let me use a caulk gun at home, so I have to come to the hospital in the OR and use a caulk gun to deliver my bone graft into the facet joint. She says I always put too much stuff. And so here's delivering the bone graft into that facet defect to create the fusion. So the most exciting thing that we've started in the last couple of months is taking that technology and using robotic precision, computer navigation to do the facetectomy and do the laminectomy. And that's really exciting, probably done about 10 to 15 cases now. So on this spine model, there's your facetectomy that you do, however you do it. Open, MIS, perc, osteotome, drill, burr. There's the hemilaminectomy on the ipsilateral side of your TLIF. There's the contralateral decompression, again, whether you do it open or MIS. And on the axial view, if you look at those boxes, I can now use the computer to plan those pathways and trajectories to do the decompression. This is a case we just did. Actually, I think Ryan did this case with me a couple of weeks ago. This is down a 22 millimeter tube, hard to see. You see a little bit of muscle there, but the point is I wanted to show you the anatomy. There's the L5 pedicle on the right. That's the midline. You can see the drill defect there from the facetectomy. And then a close-up view, there's the pedicle, there's the midline, that's residual lamina and facet laterally on the right side, a little bit of lamina superiorly, a little bit of the inferior facet of L4, but you can see in about 4 trajectories or 4 passes of that decortication tool, I've done my entire decompression, and then I can get to the work of the inner body. That's roughly the decompression I do for an MIS TLIF, which is both ipsilateral decompression and contralateral decompression. That's after that's all been done. There's the thecal sac and the cage in the inner body space. And again, nice wide decompression using robotic techniques. So real quick, L4-5 spondylolisthesis. I try to learn from the deformity surgeons about balance, PIL mismatch. I want to improve the SVA with this plan, even for a 2-level. With a mobile spondy and stenosis at L4-5 and a mobile spondy at L5-S1. But now I can use the robot to plan the decompression. So at L4-5, I'm going to plan about 6 or 7 trajectories on a left-sided approach. But at L5-S1, I don't need to decompress the canal. I just need to remove the facet to give me access to the inner body fusion. So what that looks like top left is L4-5 doing an ipsilateral and contralateral decompression and the facet fusion on the contralateral side. And at L5-S1, just doing a facetectomy, but an L5-S1 fusion on the right side. Again, all planned ahead of time, executed by the robot with a 2-level TLIF technique. We can take that technology and go to the trauma indication. So here's an L2 burst fracture, and I can do this with an MIS percutaneous robotically executed fusion from T12 to L4. Again, using the planning for the screws, but also the facet fusion, and get an excellent result. This operation is about an hour and a half MIS technique in a patient with multiple other trauma injuries, and we can get them up. This is a case we did last week with a traumatic burst fracture from a car accident, sort of a weird chance fracture, a big retropulse fragment in the canal. He presented with L5 complete foot drop and an L5 radiculopathy. We did an MIS technique, robotic assisted. Here's through a tubular retractor, 18 millimeter, did a decompression and took a bone tamp onto the back of that piece of bone, shoved it forward, and then did a posterior robotic facet fusion. The pictures don't do it justice. The top left is retracting the L5 nerve root, and that's the big piece of bone retropulsed posteriorly. The top right picture is the bone tamp. The bottom left picture is that bone has been pushed forward, and then the final picture is the thecal sac. We go ahead and instrument him and do a contralateral fusion, and you can see impacting the bone forward. His pain resolved within a day, and his foot drop resolved by day 2. So we can now use the robot to do every part of the operation, just like the Teslas. 90% of a Tesla is built by robots. Less than 10% a human even touches it. So it is now the coolest robot in spine surgery. And then this is a video again for Dr. Chapman, who's not here, but ultimately the robots do take over the dinosaurs. And in this particular video, they work together at the end. And with that, I'll stop. I'm sorry that the audio isn't there. I'll stop. I think I've gone a little bit over time. I apologize, Kojo. Okay. Any questions? Kojo's okay to take questions now?
Yes.
Okay.
How often do you have these goals for top-up parameters when you fail to meet them after scanning X-rays?
Yeah, great question. So again, I'm predominantly a degen surgeon. I've learned over the years to apply the technologies and techniques and goals from the deformity surgeons. We're actually looking at my series of 1 and 2 level degen patients, and so far we have about a 90% correlation with 1-year follow-up of standing X-rays with those spinal pelvic parameters compared to our plan before surgery, which I think is way better than I would have anticipated. And that's with MIS technique through a tubular retractor. So there's not a lot of bone removal other than a facet resection, expandable cages, and then computerized planning with patient-specific rods. So very, very happy that to sort of support the idea that degen surgeons can actually do deformity surgery, or we actually respect those parameters even when we're doing 1 and 2 level T-lifts.
Hey, Dr. Chu, thank you for the talk. It was great. Josh Lux, University of Maryland. I have a question about, you mentioned movement to ASCs. I was curious if you're starting to use robotics in that setting.
Yeah, so I have not. I have limited access to ASCs as a University of Arizona surgeon. The biggest issue of moving robotics into the ASCs is the cost. So any robot on the market is somewhere between $1 million and $1.5 million. And if you're an owner of an ASC, you're not footing that bill. Now, the companies have very creative ways to help you finance getting high expensive technologies, high capital technologies in ASC, and you sort of work with the ownership group or the leadership to do that. There are some non-robotic navigated systems, though, that are much less expensive and are probably specifically great capital type investments for the ASC market.
Hey, Hussein from University of Toronto. I was just curious if there's any current application running in the pipeline for the cervical spine for robotics?
There is. So robots can be applied to the cervical spine. Most of the robots are cleared for indications in the cervical spine. I don't use the robot in the cervical spine, as most robot surgeons don't use it for the cervical spine, because we haven't been able to control the movement of the spine in the prone position. And so we need pretty significant fixation without movement of the patient. So, you know, things like C1-2 might be a good indication for robotics because of the accuracy and the efficiency and the precision. But, you know, any first and second year residents here? Third-year residents, you all ought to be able to put in a lateral mass screw, you know, with fluoro, 1 shot, 2 shots. So I think we're going to find applications for cervical spine, but it's really not widespread. And Dr. Skaggs may have a different opinion about cervical for robotics, but we're not quite there yet.
All right.
Thank you.
Thank you. One of the joys of Seattle Science Foundation courses is we can transition quickly to the lab, and particularly tomorrow where you have hands-on on everything that Dr. Chua talked about. Thank you very much, Dr. Chua. All right, well, we have a lab demonstration. Dr. Sansor has graciously stepped in to give us a tour of a C1-2 fixation and interfacet fusion. Take it away, Charlie.
Okay, great. Thanks, Kojo. So I'm here with Dr. Mark Kramer, who's a fellow here at the University of Maryland, at SSF. And so I just want, we prepared this to identify some key structures when considering in C1, C2 fusion. So if we can zoom in a little bit, yeah, great. Okay, so this is just for orientation purpose. This is C1, this is C2. The top of the C1 is going to be right here, and one of the pitfalls, if you're doing the exposure and you're using the bovie and you're too lateral, is the vertebral artery. So this vertebral artery sits right here in this groove, the sulcus arteriosus, and so I usually suggest that we take a Kittner and just decorticate, or not decorticate, do a subperiosteal dissection down here, just to get exposure of the top of C1. You can use the bovie in the middle, but you don't want to use the bovie off to the side because that's where you can run into trouble. So what we've exposed here is the thecal sac right here. You can appreciate the C2 nerve root sits right here. You can appreciate that this is the ganglion. You can see sort of like this dilated portion of the C2 nerve root. That's the C2 nerve ganglion. You can either choose to retract it to make room for your C1 lateral mass screw, or you can choose to sacrifice it to fully expose the C1, C2 articulation. And so the other important part is that we have a nice gap between C1 and C2 over here that gives us the latitude to palpate the medial wall of the C2 pedicle. So as you can appreciate over here, you can literally palpate it with your instrument, the medial wall of the C2 pedicle, which is depicted right here. So you have real-time feedback about that. Important to expose the full extent of the C2 lateral mass. Here's the C2 lateral mass here. The medial aspect of the joint is here. The lateral aspect of the joint is here. So the midpoint would be somewhere in here. And that would serve as your entry point for C2 pars. Entry point for C2 pedicle is going to be a little higher up. And you can determine the lateral to medial extent of the entry point based on palpating the medial wall of the C2 pedicle. So, so I think we have Dr. Chapman, who's come back from the OR. So Jens, I'm not sure if do you want to take over or that's good. Okay, sounds good. So, so what I like to do for the C1 lateral mass, if I'm not going to sacrifice the C1 or the C2 nerve root, what I'll do is I'll take my instrument and I'll feel the articular surface of the C1 part of the C1, C2 joint. And I'm going to feel for where it's most prominent. You can feel it start to dive down. And where it starts to dive down is where the lateral extent of the C1 lateral mass is. And as you go, so I feel where it dives down, and then I go up, and I feel where it becomes most prominent, and that's going to be my entry point. So I'm going to go ahead and take this drill. So again, it dives down over here. So I'm gonna go a little bit more medial from where it dives down, and my entry point's going to be pretty much right there. I would probably use a 2 millimeter drill circumstance, but.
You have a Benfield 4? Here,
So here,
We're tracking down the,
so that's
C2 nerve.
created our entry point. Let's go ahead and take this. And so at this point, I'm going to take a look at the trajectory to determine whether or not I'm pointing towards the C1 tubercle anteriorly. So I could do a little bit of hand towards butt. Let's get a shot right there. And so that typically is going to be where the trajectory is. The typical lateral mass for C1 is about 18 millimeters long in terms of bone purchase. Let's get a shot right there. I think I need to do a little bit more hand towards butt, so I'm going to change my trajectory some. Oh, sorry.
There we go.
Shot.
Charlie, what part of the tubercle are you aiming for?
I'm usually aiming for just the right in the middle. Let's get a shot right there. And so as soon as you get to the atlantodental interval, that's typically what dictates whether or not you're bicortical. If you're right around there, you're usually bicortical. So do we have a feeler ball? Yeah. Okay, great. So Mark is going to go ahead and feel.
you got a good base.
Okay.
That's good.
So we'll go ahead and take a tap and just prepare our entry. Let me just go ahead and retract this C2 nerve root here. Okay, that just tapped a little bit proximally. So we drilled about 18 millimeters of bone of the lateral mass. So you can typically estimate that you would need a 30 millimeter screw because it's going to be another 12 millimeters or so above what you drilled in order to get it to hook up nicely to the C2 screw.
Charlie, do you use screws that have a shank to minimize the rotation of C2?
Ideally, it would be good when you're making it proud like that to have that smooth portion resting against the C2 nerve root. But if you sacrifice the C2 nerve root, then it doesn't really matter. So I figure maybe we'll keep the C2 nerve root intact on this side, and then maybe we can have Dr. Chapman do the other side and show us maybe an interfacet fusion. So this is basically the trajectory. You can see it's being left a little bit proud. Let's get a shot right there. And that ends right at the atlantodental interval. So we're reaching the cusp of the bicortical state. I'm going to advance it just a tiny bit more, shot. And so that should be bicortical right there. And so, let's see. I'm trying to unlock it.
It's Mike's iron grip. Here, up there.
Okay, great.
Are you worried about having a C2 root irritation from this screw placement? Charles?
Oh, well, in this situation, there seems to be a large space between C1 and C2, so I think it'd probably be okay. But it is resting against the C2 nerve root, so in this case, you could make the argument to take it.
So this is beautiful, and this is what you should do. This is a really nice go-to things. Jens Chapman, I apologize, I just came out of the OR. Give us a lateral shot, please. So I'm going to show you a palm screw with the collaboration of Dr. Sanzer, which keeps you out of the C2 root. And again, I've carefully, what Dr. Sansa says is so important. You don't want a bovie north about a centimeter and a half, an inch lateral to the tubercle. You don't want a bovie here north of the atlas ring because the sulcus of the vertebral artery is right there. So I usually put a Penfield 4 right onto that sulcus and then shoot me again. And you can see I'm protecting the vertebral artery. And then hit the Midas on.
Ready?
Midas on. Off, shot. And I'm gonna correct a little bit, Midas on. Off, shot. I'll drill straight down to the lateral mass. The advantage of this is, now take a drill, please. Do you have a power drill? Okay. And again, I'm gonna ask Dr. Sanser, my neurosurgical colleague, to guard the vertebral artery, so just keep this Penfield 4 usually in here. A nice controlled starting spot. I'm outside of any bleeding. I'm aiming at 10 degrees medially, shot again. And this is way too short. I usually do incremental. I never know how this one works. How's
I
this
think
one?
you unscrew it, yeah.
Oy vey. That's painful. I'm just gonna short circuit this a little bit. I'd usually drill in increments. Can you put that on top of the C1? So this is called a palm screw, posterior arch lateral mass screw. Again, it keeps you shot, left to right, ball probe, tonsil ruler. And I'd like to, Dr. Sanser is a actually highly acknowledged urologist, so he's a precision guy, tonsil, and so I measure high tech. The dinosaur technique, thank you, Dr. Chua. Don't think, shot again, that I didn't see what you said before. And here I have a very precise measurement, how long the screw is. You like that, as a horologist?
It probably 34 millimeters is my estimate.
You
Yeah.
estimate, but I measured. Aren't you impressed with me? So I had drilled to 30. And what are we worried about in the front of the lateral mass, Dr. Sanser? Why do we not want to cowboy through the front of the cortex? Shot? What structure is in the front?
Yeah, you don't want to hit the carotid.
Internal carotid artery. So we don't cowboy through there. I usually drill in increments of 18, 24, and then 32. Shot again. And I have cortex very precisely identified, so this is the screw. And I tap these. Again, there are 3 indications for tapping for me. You'll hear an excellent lecture by Dr. Skaggs shortly. The tapping is actually bad for purchase, but I use 3 indications for it: hypersclerotic bone, misdirected screws, and here we use a shank screw. I think Dr. Sands and I concur. That's a very nice neurovascularly protective screw.
This bone seems to be pretty cortical, actually.
Yep. There we go. Shot. Shot again. It wants to migrate. So I did not do a good job drilling or tapping my starting spot. Not a very convincing display of my palm screw technique, ball probe.
Should we, maybe we'll get the tap again?
Ball probe, tap. Because we had a very defined spot. Here is the spot, tap. So this is clearly a tap case, so high precision screws. And here I'm getting a good purchase now, shot again. Yeah, so that's where we want it to be. And screw back. And Dr. Sanser actually is not retracting the vertebral artery, he's literally just hugging it so that I cannot violate it. And Dr. Sanser's idea to put a tap in here, again, and properly tap it, which I did not do. Astutely observed, thank you, Dr. Sanser. We learn from one another in these courses.
Looks good.
Shot. And if you twist this, this is a great purchase.
Yeah, very strong. And you can see that we both ended at the same exact spot, like right in the middle of that atlantodental interval, just at just right in the middle of that C1 tubercle.
Shall we do C2 fixation?
Sure. So I have Jens right here, the medial
So I'll
wall
start this.
of
So before
the,
I ever drill, I actually do what Dr. Sanser said, Cobb, elevator, please. And Dr. Kramer is so kind to be pulled out of the way. I actually do what he does, but I decorticate the joint at C2-3 if we have to fuse below. Any Cobb would be fine, any Cobb or anything. I don't want to do a soft tissue. I have a medial joint, lateral joint, and here's this articular ridge. And this articular ridge is key because right here will be my starting spot. Before I ever drill, I take off the IEP.
Oh, yeah,
minus
ready?
On, yes, please. Because the screw head will obstruct this. And again, if I have to fuse below C2, off. I don't want to do it. So here, we have a beautiful access into the joint. Give me a shot, please, my friend. Thank you. And so here's the articular ridge. Here's the medial joint, lateral joint, and right here, Midas on. We'll do a nice starting spot. Dr. Sansa, would you mind putting your Penfield 4
yep,
onto the medial pedicle wall? I think we're doing the same thing
medial
across the
pedicle wall
coast.
right there.
And shot, please. And we somehow lost a little bit. Can you slide up north a little bit, please, my friend? And give us a mag times 1.
Maybe wig,
wag the
a
opposite
little
way.
bit wig.
So wag this far side towards me. And I'll take a 12 drill. So my mentor, I don't know how you do that, Charlie. My mentor, Dr. Anderson, told me to start with a 12, which is very safe. Shot again. That's better. Come up north a little bit, you're too south, so translate the whole C-arm up north. And I'm trying to ride the upper shoulder, so Dr. Sanser, shot, is so kind to show me the medial pedicle wall. And I go in 2 millimeter intervals. Now this is very painful, you know, my friend. I love your company. I'm a consultant for Globus. I must disclose this conflict of interest, but I don't like this, this thing. And I drill in 2 millimeter intervals, shot, and I probe. The thinking is that if I'm hitting the transverse foramen, I have a millimeter space. What do you think of that theory, Charlie?
Yeah, I think it's a good theory.
I'm gonna just forego this right now in the interest of time, but I literally drill in 2 millimeter intervals, shot.
Yeah, so I can feel that there's no violation. Everything feels fine.
So this is a true pedicle screw, so I'm drilling medially. Again, we have pre-mapped as usually on a CT scan. Shot. And here we are. And again, I use my precision tonsil ruler technique, shot anterior cortex. Thank you, Dr. Kramer. I'm sorry I displaced you, but it's a great honor to work with, save that left to right, and we have like a 30, right? 28, good, 28 it is. And we do a left to right always, so we have a reference, and then we'll take a quick shot. And do you want me to come around and then you'll do a translaminar screw on the other
Sure.
side? Or, and then we can do a C1, C2 arthrodesis.
Yeah, here, let
I'll come
me-
around, I'll come around.
okay.
You can do it from here over there.
Okay.
And how about I assist you? Do we have a Woodson or Penfield 4? Shot, please. And you can literally do bicortical screws with this. Again, I have a small slide set at the beginning, which shows that you want to do your osteology work, homework, before you do that same thing probably. So not just rely on an MRI scan, but have a CT. Do you have a Woodson or do we have a Penfield 4?
We have the Penfield
Okay,
one.
I'll do this. This is kind of a Penfield, okay. So I'll guard the sublaminar space. And now what do you look for, Dr. Sanser?
So what I do over here is it's easier towards the caudal end of the C2 if you want to do a translaminar. You can achieve one that's at the top and one that's at the bottom if you're putting in bilateral translaminar screws. In this case, I'm just going to, just for the purpose of the demonstration, just show what I would look for. I'm looking at the top of this C2 lamina, and I'm imagining where it would end if I maintained that trajectory. from the contralateral side. So I think this is my estimate of where the entry point should be based on the visual landmarks. So I've broken through the cortex. Now, thank you. And so I'll make this a little longer. These have the tendency to be longer screws, perhaps.
So this is a great thing again. Tomorrow, you'll hear a lecture by Dr. Skaggs about teamwork. When you do highly repetitive things in the OR, it's really important that you develop a flow state where you have repetitive things that have a clear assignment of who does them, how are they done, and how is it communicated. And this is a great example of this. So
I'm gonna drill slowly. These screws are actually a little risky because you don't have you have to rely on it finding the cancellous path, and I'm kind of pointing down a little bit so that I make room for the other side if we want to do bilateral. But so I might have breached a little bit. I felt a little deceleration there.
I don't see CSF, so that's good.
Actually, it feels fine. Maybe it's just a soft part of the bone.
I did not feel you. So you like this proprioceptive drilling, half speed?
Yeah.
Yeah.
Sometimes I also just use a Lenke probe.
Let's take a C-arm shot when you can. Can we take a C-arm shot? So what do you look for on a C-arm, or do you not use a C-arm at all?
Yeah, I would use the C-arm to make sure we haven't violated the lamina. So if
how deep do you want to go?
Yeah, I think that we could go deeper.
Yeah.
Yeah. So I guess I'll take a tap maybe. This thing's hard to adjust.
Yeah, it's hard. It is hard to adjust. So 30? You want to do a 30?
Yeah, let's do a 30.
And here we don't need a shank screw, right?
Correct.
So this is such an important thing. So when do you do translaminar screws?
I mean, I only do them when in salvage situations.
Yeah.
Oh, let's get a shot right there.
What do you find hard about them?
I find it hard to put in bilateral screws because
Spacing.
Yeah, spacing.
Really good points. So for me, the drawback is you have to actually look at this angle that Dr. Sanser has to do. It's a substantial angle, so you actually have to do more soft tissue dissection. And the second thing is that mating these screw heads to the rods is not straightforward. I usually use a transconnector. If you do a pure C1, C2, you can do a small oblique rod. But if you do a longer rod, you need to do a transconnector. And in thinner, older patients, these screw heads can actually be quite prominent. They kind of stick out a little bit.
Okay, let's get a shot right there.
Good. That's perfect. We're right behind the spinal canal. So if I put the probe down here, shot again. So this is the spinal canal, so the cord, shot again, cannot be injured with this. So we actually see with this ball probe the cord. Shall we quickly take down a C2 root and show a C1, C2 facet orthodesis?
Yes, so important when you're doing a ganglionectomy is to remove the entire ganglion. So typically what happens is you'll see that this is see how that's a swollen aspect of the nerve root, this sort of a bulbous appearance right there. I would bipolar here and bipolar here. Does that show up on the camera?
Yes.
Yes, it does.
A little hard to see maybe, but I'm going to try to pull it down into the view. Is that
a little better?
I think this screw is kind of in the way. But
one of the things that
so this is the proximal end of the ganglion right there. That's the distal end of the ganglion. I'm going to bipolar here and bipolar there, and then we resect the ganglion after bipolaring.
Beautiful, yeah.
And you want to make sure that you get
So we don't have to ligate this.
correct.
And all this in real life would bleed because this is a dense venous plexus, right? But not in your hands. Any tricks?
So typically what I do is I'll do a subperiosteal dissection above and a subperiosteal dissection below so that I can expose as much bone as possible, and I'm coagulating above and below during that process.
This is all venous plexus here.
Yeah, and then so I'll keep on coagulating, flow seal, coagulate. Then I'll go to the other side, do the same thing, and then eventually you'll be able to identify a charred-looking nerve root.
Do we have a bipolar here, a bovie? Do we have a bovie? We actually have an electrocautery here. Thank you, Dr. Kramer. I'm sorry that I pushed you out of the way. So for simplicity's sake, we're going to expose this now. And by the way, Dr. Oskurian, who's a well-known neurosurgeon, and I disagree on this. I try to preserve the C2 root whenever possible. And he taught me how to amputate it. And I can't say that one patient's cohort is happier than the other. What do we see here? Is this good now?
Yeah, you can see
That's awesome.
you can see the facet joint right there.
And so now we're going to actually enter the facet joint. We don't have the best camera angle, I apologize. Take a shot, please. And this is the C1, C2 joint. I metallically shown, and Dr. Kramer has been so nice to find us a small laminar spreader, which you can put in here now, and we can open up the joint. You can gently, if you have a screw on this side, put the screw in, and we can now scrape out the joint or drill this out. This is a facet arthrodesis that we're doing.
I might take this screw out.
No, this is good, this is good. I can, is it in the way? Okay, yeah, that's a good point. My wonderful screw is in the way of the camera. Anything for audience, right, Charlie?
Yeah, this way you'll be able to see a little bit better.
So here's the joint. I'll just do this, I'll repeat this maneuver one more time. Aiming just gently medially. We're breaking through the posterior facet capsule.
And adjust the soft tissue because it's hindering the view.
And the laminar spread is giving us a little distraction.
Yeah, so you can see the articular cartilage.
And Midas on.
Ready?
Shot. And so we're drilling out the joint, Midas on. We do not want to skip laterally because laterally to the joint is the vertebral artery. Off, shot, and here we're anterior. And now the nice thing here is we have an actually pretty clean, do you want to look around with that here, Charlie? We have a nice and clean joint here. We can almost see in the camera.
Yeah, you can actually feel where it ends and starts to become ventral. So definitely a very solid space right there.
And so now I'm going to put a allograft in there. This is a standard cortical allograft. And I appreciate our
Get a large needle driver or tonsil or something.
And I cut these in half, so I get one structural graft. There's some manufacturers who make them out of metal, but I don't like that. Can you hit the Midas on, please?
Ready?
I'd usually use a sagittal saw for this part, but we'll improvise here. Off. But this is actually a perfect little graft for this, because we can now shape this, smoothen it out, and then tamp this in there. I can smoothen this out a little bit more in the front. Do you have a little tamp for this? Is that tamp?
It's just the end of a cob.
I'll not be able to control this. I'll just flatten this out a little more. Midas on.
Ready?
Yes, please. off. So this is not interesting for the audience, but I've just basically sharpened the entry angle a little bit. And I'm struggling because I don't have my insertion tool for this, but crudely we'll try to hammer this in place now. Can you hammer me so I can have a two-hand control over this?
Ready?
Yes, please. So wants to skip off to the side because I don't have good control. Okay, hit it again. Do it again. Okay, again. Good shot. So I think
Yeah.
we're nice in there.
Yep.
And we can put the C1 screw in, C2, and compress down.
Beautiful.
I have atlantoaxial arthritis, for instance, with these.
Right, basilar
coronal cups,
invagination.
basal invagination. Elevating the C1 ring back on C2 is very gratifying. If you have no C1 posterior arch, posterior C2 arches, facet arthritis is actually very nice. In the beginning, I'd always sacrifice the C2 root, I think.
Yeah, I think for these allograft spacers placed into the C1-2 joint, I think it's necessary to sacrifice that C2 nerve root to really get your opportunity to expose everything well.
Dr. Chapman, Dr. Sansor, I learned a lot today that I don't need to beg my hospital to provide me with a very expensive implant into that joint. We can just use an allograft. It works beautifully. And I'm grateful for that, Dr. Chapman. And this is very, very excellent work. I congratulate both of you. One of the things that as you get older, you are able to glean the nuggets between two master surgeons just discussing and talking while you're working. And it's one of the joys and excellence of the SSF course. So I really want you to grab that when you're listening and watching this, because it gives you reasons why we've incorporated a lot of the lab demonstrations is very much like this, and also to make sure that as you're going through the lab stations, that something may be said with a group that you may not get, but with the demos prior, you get a good view of what's going to happen, and you can transition into multimodality learning. Thank you very much. We're going to switch forward to another talk.
Yeah,
I'm making a change in the schedule and going to give my talk at this time. So one of the things that I want to talk about, again, my name is Kojo Hamilton. I'm from University of Pittsburgh School of Medicine and Medical Center, is topics that are near and dear to me. I'm going to be giving a lot of pearls in avoiding pitfalls in cervical deformity surgery. Now, this is a past lecture that I gave last year and about a couple of years before. This is more of a continuation of that lecture. It was more of a basic lecture, and I'm going to go, at that point, if you're going into the archives of SSF, will be the cervical deformity and its implication on spinal balance. During that time, we ask questions such as, are there fully established cervical deformity classification and treatment options? And are there defined indications for surgery to correct cervical malalignment? And are there set standards to address the amount of correction needed? And what is the impact of the regional cervical sagittal alignment on outcomes? It's quite impressive. During that preamble talk, I talked about the cervical spine needed for maintenance of horizontal gaze and also the centers of mass, but really also biomechanical stability into three columns. One anterior column involving the vertebral bodies and disc. You guys are familiar with that, and the posterior columns. And also its load sharing compared to the thoracolumbar spine. And why the lordotic cervical spine, because of the compensatory thoracic kyphotic region needed for lung expansion, and it also increases with age. Now, the prevalence of cervical deformity is quite high in patients that have thoracolumbar deformity. It's always something that you have to look at. And you're well aware of the high degree of motion and also in the upper cervical versus the lower cervical spine, and hence any fusion in the, as you saw in the upper cervical spine, may have more consequences if the lower cervical spine or subaxial spine does not have much motion. So there is disability related to cervical spine pathology. There's no question about that. Breathing, swallowing, myelopathy, radiculopathy, and also there are now recognized global compensatory mechanisms in alignment related to what we do in the cervical spine. So there are repercussions in terms of the loss of cervical lordosis and also the other degeneration and the poor chain reaction. Here you see a normal cervical spine. In the hyperkyphotic kyphotic cervical spine, you do have compensatory mechanisms in column B that accentuate the patient's pain and misery, as well as if they're hyperlordotic as well. This impact of cervical deformity is continues to be quite prevalent. It's sort of the added burden of misery to the patients with regard to the daily activities of living. The other issues has to do with the cervical sagittal malalignment that we talked about in the other course, or should I say my other lecture, which increases patients' disability with regard to physical and also with neck pain. So an example would be somebody who shows up routinely in my clinic, 68-year-old female with difficulty with horizontal gaze, severe neck pain. She also has late afternoon back pain. She has no arm pain. She has some left shoulder pain, which she thinks might be a prior tear, a rotator cuff tear, and she quit smoking 7 months ago. Question is whether she's osteopenic or not. So this is the FlexX imaging that I obtained, but then you look at a global alignment, right? That's what I'm trying to stress with deformity. Nothing is segmental. Look at global alignment. Look at how back looks like, the coronal and sagittal deformity, what's contributing, what are the pain drivers, what kind of exams are you going to do? The cervical spine cannot be evaluated as a standalone region for any deformity, no matter how mild. And I stress this because I would like people to have global films when you're dealing with non-focal deformity, right? So if you feel like you're going to do a long construct, it'll behoove you to look at it in totality, right? So one of the things that I'm looking at a lot in my clinic, quietly and sometimes verbally, is the cervical lordosis, T1 slope minus cervical lordosis. It is the PILL mismatch in the thoracolumbar spine equivalent. If you have a small T1 slope, you need very little cervical lordosis to maintain your center of mass and alignment. An example would be iatrogenic in the first column, iatrogenic large T1 slope will require significant alignment to maintain, significant compensatory C2, C7 degrees to maintain the balance that's required versus in a smaller slope where you even have kyphosis in the cervical spine, you need less to maintain alignment. And another issue that I always want to see is if anybody's had a lumbar fusion, thoracolumbar fusion, I want to see how it affects their cervical spine. And you can see the gradual deterioration of a patient after a thoracolumbar long construct surgery. They extended it a little, it makes her cervical alignment worse, and now we have to go all the way to the top. And this is just the natural, now we understand, compensatory reaction to any surgery that we do. And some studies have shown that if we don't get it right the first time, it exacerbates this situation. So are there fully established cervical deformity classification and treatment options? You guys are going to be the bastions of wherever you take a job as the deformity surgeons there. And yes, there are. I personally use a simpler classification, the AIMS ISSG classification. And really, it starts with a deformity descriptor, cervical, cervicothoracic, primary thoracic, and also coronal versus cervical craniovertebral junction deformity. And then you have the modifiers. I do this calculation in my head in clinic. I may write them down. If you're a fellow with me, I expect you to start doing these calculations in clinic, mostly because it's going to guide what we do, and it gives you a plan as to what's really important, how do we negotiate pain drivers, and also an alignment. Several studies have shown how this improves, and there's a strong clinical correlation with that, and a good strategy to have a cervical deformity classification system to help you with. Let me give you an example of a few deformities that you encounter, right? You have a flat neck, either rigid or mobile. Patient may have a focal kyphosis with some Spondylolisthesis, or even a cervical thoracic deformity, or one of my serious concerns with a concomitant coronal deformity. That's the hardest to treat. That's what I always look at and say, we are going to need a co-pilot. When I'm ever doing anybody with a coronal deformity in addition, I'm looking for a co-pilot, co-surgeon to help due to increased dislocation of the spine required. And really, it's very important. I also then go back, if you go back, we only showed you the cervical spine. I want to see how that's in relation to the rest of the spine. And then in clinic, right, we're trying to avoid pitfalls here. We've seen the images, we've examined the patient, taken a history, we've seen the images, but we're going back again to say, how do they look when they stand? What's their burden, right? We want to see, what are we correcting in the actual musculoskeletal jacket and patient's compensatory factors. I also have them lie down in the clinic and say, how are they able to cope? I support the head where the arrow is pointing. I support the head and say, why don't you relax and let me know where your head lies? It lets me know how rigid, etc. things are. You can also have them go downstairs or to the side and get x-rays. But I really want to see for myself to make sure that when they go down to get x-rays, they are not artificially manipulated. So I do want to see, what do I get here myself? So things to know in this day and age. It's not just the clinic, it's not just your exam. You have to think about cervical alignment or stretch, that there are repercussions to what we do, right? You all are residents and fellows, neurological injury, tracheostomy, things that you have to counsel patients with rigid deformities, anterior surgery, swallowing difficulties, and also vascular and soft tissue issues. So in addition to that, you have to also start counseling them about, and also seeing what modifiable factors you can have with bone density, rigid deformity, like I mentioned, 2 surgeons are always better, and also with modifiable things. Now we have all these GLP-1 medications that could help if they're, as opposed to requiring people to quickly undergo bariatric surgery. And really nutritional status. I can't stress how that affects wound healing. So we have a plethora of surgical techniques. Anterior, I reserve that for mostly ACDFs, for focal deformities, corpectomies if I have to extend it, and to do osteotomies in a rigid spine for release, versus posterior where we do laminectomies, osteotomies, and 3-column osteotomies, or even intervertebral pedicle subtraction osteotomies. So we can always start with the progression of what we want to do. You can start from the first column of doing, and this is one of those things that are better explained in the lab. We have a cervical station where we could do facet releases and intralaminar releases for gentle compression as needed, versus total laminectomies, facetectomies, and clear osteotomies if we're going to compress. And then you have an option of doing an open wedge closure through a disc space versus intrabody pedicle subtraction osteotomy. These are techniques that I would implore you to practice. One of my greatest visions we're seeing Dr. Chapman after everybody's left the lab going in to do his own personal dissections. And I said, wow, the learning never stops. So it's quite impressive. There's great opportunities for you to continue to do this today. And there are several techniques that will be enhanced in the lab that I want to go over, but some of the things that when you start your practice, you will be the top person there. Your partners will be sending you all their deformities, right? So I want to mention things like when we're doing posterior osteotomies, I want to see all the nerve roots all the way through. I don't want to leave an opportunity for nerve to be compressed by residual facets if we're going to think about closing on an osteotomy or closing a created deformity. So the second thing I want to talk about is avoiding buckling of the cord. If you have to do this, you have to really peel and skeletonize the scar tissue off and avoid buckling of the cord. Those are two of the main things that require you to come back, sometimes rather late, where patients have prolonged deformity. If you do any compressive maneuvers in any part of the spine, particularly cervical spine, patient wakes up with new radiculopathy, it's best not to say, oh, it's stretched, it won't go away. You got to have multiple modality imaging. This is very important. It won't go away. You have to check. If it's C5 palsy, verify with imaging, okay? So one of the things is secondary, an example that I'm going to quickly end with is mixed rigid flexible deformity that you're going to see. Example, ACDF in the front, wiring in the back. This is an old construct that you have to look at. So if we're going to fix this, patient shows up, severe radiculopathy, even within the construct that's been performed. This is natural order of time. This is an old construct. Degenerative process is not arrested. Then they also have anterior listhesis above the construct, severe neck pain, difficulty with maneuvers, and multi-level radiculopathies. So you know that their extent and effort. From my past lecture, you would talk about the extent and effort required to maintain your horizontal gaze alignment and also just your general sense of well-being. So one of the first things when I see this is I need to do posterior releases. I need to get things removed and to see how much correction I can get. Most often I get lucky. I get able to do laminectomies, facetectomies, complete correction, scrub out, have my co-surgeon in the field manipulate the Levo or Mayfield to see if I can get the correction that matches my preoperative alignment, etc. If not, we'll have to temporize with a temporary rod and then go anteriorly to do osteotomies, disc removal. And one of the things that I want you to take advantage of if there's an anterior cadaver is to really go into the disc space and go as far out in multiple levels. Where do I see the vertebral artery? And one of the things that I caution everybody is never start a cervical spine case thinking, oh, we're just doing 2-level ACDFs. You have to look at your MRI. You have to see whether this is a normal line vascular, what other issues are around the area where I'm going to operate on, because there are so many variants in the normal pathway of the vertebral artery, and it's surgery that, though routine, can end up being an all day with canceled sequela to the patient. So take your time. You're not going to have a preoperative imaging on the cadavers that we are doing today, but use the time to say, I want to see in a posterior spine, where will I encounter in the, between C2, C1 to C7, the vertebral artery? How far do I need to go? Give yourself a frame of reference today. So if you do anterior and posterior releases to take care of radiculopathy, I'll be putting bone graft in and be able to freely close the spine in the third stage. So when you do this, it's a back, front, back procedure. It's an all-day procedure. What am I not doing? What am I preventing myself? I'm a new attending, young attending. These days, all the hospitals say, you just graduated last month. They'll put a date of your graduation. You're going to have all these insecurities. You need your co-pilot, right? But you need to avoid negative persistence. That's if stuff's happening, I have a CSF leak. It doesn't mean that today I must get through all my stages. I am literally making adjustments to my plan intraoperatively as things happen differently, right? Blood loss. If I have a vessel injury, what are we doing today? Are we coming back today, or we're making alternate plans? So you have to also know your co-pilot early. There's a typo. It's like KNOW. And you have to make sure that your co-pilot that you're choosing is up to snuff, right? You have to plan ahead. Know who, if you're doing big deformity, front, back along, who's in the OR with you? You're new hospital. You present the case before the M&M, present it to your senior colleagues, externally to your fellowship directors. I try to do this because this is what sinks in. It's so easy to say, oh, I went to a nice course, cadaver, we were taught this, but then when do you make that phone call back home? When do you call Dr. Chapman and say, hey, I've done this 5 times with you, but I just want to run things by you, right? Don't be on call when you're doing this. This is not a routine ACDF where you want to be paged incessantly or you can get through before. And try not to have overlapping surgeries without a co-pilot when you're doing deformity surgery. Vet your co-pilot before you do your front case. And you really have to be synchronized. You could just see Dr. Chapman and Dr. Sansor today in the cadaver lab. It just seemed like it was a dance, right? It was a 4-3-2-1 dance, as I call it. There's four hands in the wound. You could see when Dr. Chapman said, I need to hold this instrument with 2 hands. Can you tap for me? That's seasoned pro. This is one of his 10 commandments that you'll get familiar with at the end of the course, right? So 4 hands, 3 hearts, 2 surgeons' hearts, all pumping out the same with the patient. And, you're doing manipulating one spine. So it's not a good idea to say, well, I'm in a new place, I'm the new academic person, I'm going to do this with a chief resident or super chief or fellow. If we're talking cervical deformity, front, back, things that I've shown you, you have to have somebody helping you. I truly believe in that, okay? So you have to also prep the patient, right? Bone quality, habits that are modifiable, multiple patient visits before you engage in this. And some of my partners are even having patients undergo neuropsych testing to document. Don't be shy about letting them get a second opinion. Meet your co-pilot, prep them in clinic. And like I said today, get in the lab, go beyond what we're saying in the lab to say, I want to see this. You want to avoid negative persistence. But really, you have to always think about how the patient is compensating in their cone of economy. Thank you. Questions?
That was wonderful, thank you. Of all the things that you showed, there are so many nuggets in there. I really liked your emphasis on the clinical exam. I think we both think alike. It's very annoying for the audience, but so cool to see this kind of a positive independent reinforcement.
Yeah.
I think when I see a crooked patient, I want them to be laid flat on their back. I put my hands under their head, and there's a question coming in a second, and their legs stretched out, check for hip flexion contractures, knee flexion contractures, see whether they can relax the head, see whether the SCM is tight, contracted, whether torticollis can be released or not. The key problem for me is always if they can't get the head, and I use my fingers as a gradient, so maybe we can publish that together, how to assess that. But if a patient does not get a level head or within a couple of finger breaths to their base plate, their base couch or exam table, what does that do to your surgical planning? Do you still go anteriorly if you have a very contracted chin on chest deformity? Do you still go anteriorly somehow, or do you do a posterior shortening osteotomy? What does that do to your surgical planning?
One of the things that I'm always worried about is if they have And if they don't have all of the lower limb issues, is just make sure that they don't have a turtle shell of a thoracic kyphosis when it's lie down. If not, then I'm very keen on doing a posterior shortening surgery to realign them. And unfortunately, a lot of them will need also anterior release as well.
And the second question, I've had struggles, and I'm very careful how I retract anteriorly with contracted necks, and I straighten them out with dysphagia, so swallowing difficulties afterwards. I frequently will give, especially the more emaciated patients, preoperatively peg tubes. Is that something we should consider? What do you do in terms of making sure that they get adequate early nutritional support?
So for those that are really emaciated, I typically want to make sure that if they even have a modicum of swallowing function, is to do aggressive preoperative nutrition. And my concern has to do with post-op with the dysphagia, to start first with a tube, a nasal tube, and then go forward with that. Sometimes we're seeing it less and less due to disease-modifying agents, but people with severe rheumatoid, severe arthritis disease, I think once now, it used to be at least twice a year, but now I'm restricted to maybe once every 3 years to get them a peg tube. Questions at all? All right, I think we have a break. Go refurbish yourself and replenish yourself, and we'll come back. I'll be starting early, so yeah. Thank you.
Ron wants to switch in the afternoons to here. It's the cheap already. Here, she just gave me a text. Is it just what? And then he wants to go at 2. He wants to go at 3. So I'll go at 2:30. Here. This is a new. This was me because of my afternoon. So Rod wants to go at. You were going to go at 3. He wants to go at 2. Sorry, wrong. He wants to. If you went at 2:30, screw go at 3. So it's pretty inconsequential. Hey, how are you? Hi, pleasure. Welcome. I literally will have to do at least to put a graft to expand it so I can use it as a full. Yeah, because you don't, the easiest thing for you to do is strap, but then you use it the direction that you want it. You can, or you can, because at that point you've done laminectomy, so you're free. So sometimes I'll even try to go through a discectomy and pack it with a small amount. So if it's got to be anything no, it's only when you're trying to close it. Yeah.
So one of the things would be persistent nerve irritation, right? So you didn't catch it, right? So if they have it, typically the ones that you, if it's weakness like C5, right? Sometimes you catch it in the hospital, sometimes it'll come. That's different. But if they wake up and it's really painful, I want to get scans because I know I'm going to have to put it back. The buckling is something that it's hard not to catch because they immediately will have deficits, and that's a big problem. So anytime I see buckling, I really, and sometimes, I didn't mention this, but I'll even bring an ultrasound just to be sure. For cervical deformity, it depends, right? So things like, dysphagia, that's greater than 80%. Fall back, cervical deformity, and then a lot has to do with the pre-existing swallowing problems. So if somebody has pre-existing swallowing problems, yeah, they're going to be close to 80%. But if they have no swallowing problems, and that's hard to a younger person, anybody over 60 has some deficient swallowing. That's just natural, and they exacerbate that with surgery, right? But so swallowing, that's an issue. The other ones sort of regress to the single, less than 5%, vessel injury, etc. But if they have previous surgery, particularly extensive surgery, things like CSF leaks, that rises to at least, CSF leak swelling, that's cervical disease issues, and then post-operative wound breakdown, sometimes one of my concerns. Thank you. So I use like Vicro, Polysor, but then I also use Stratafix Stratafix to reinforce. Oh yeah. Front and back, the CDF, front, drain, back, 2 drains minimum. And sometimes I'll do musculoskeletal flaps behind the flap to take the tension off. No. Thank you. Yes, please. No. Yeah, not coming. He's amazing. So we have interlaminar stabilization. When is dinner? Dinner's at 7. So let me know if you feel like what I'll do is happy hours walking. So happy hours from 5 to 6:30. So maybe I'll do whatever. Yeah. All right, I think we're ready for the lab demo. Can you go check? Let's see. What time is that demo? It's at 10:45. 10:45? Yeah.
Gary, you ready? With Dr. How do you pronounce? Oh, the man himself. Welcome. Thank you, Chief. The trick we don't You guys, you know, it's time zones. I hate time zones.
Like I got a call.
I got a call from my residence when you were
It's like, you know, 7 a.m. over there, 4 a.m. over here.
All right, are we ready to lab? Dr. Hamilton started on time again. 1 second, okay.
If everyone wants to grab their seats, we're going to get started here in a minute.
I've done it since the rim came back.
Disposable arms, right? We're going to introduce.
All right, do we have a live feed? Dr. Ye? Dr. Ye, can you hear us? Can you see us? Can you hear us? Give us a verbal feedback.
Yes.
Great, we hear you, we see you. So this is something new and different. Every year we modify this, and we're in this era of MIS, minimally invasive surgery, and I think that this concept of MIS, I just ask you to think about this, is probably a little bit archaic, because doing smaller skin incisions and poking screws through muscles to put some hardware in there is probably not that less invasive if we think about it. It just fills in one definition. What's far more important is maybe, enhancing and supporting the actual physiologic structure of the spine under avoidance of a fusion. Because a fusion, however you do it, with how big your skin incision is or not, is a very invasive procedure by itself. It changes the mechanics of the spine permanently. So if there are ways to not have to do a fusion and achieve the goals of neural decompression while maintaining alignment, a lot would be gained. I think that's a fair premise, right? So this is an example that was a game changer for me, and the person who actually changed my life came here from San Luis Obispo, Dr. David Ye. He's a very accomplished neurosurgeon, and he's going to show us an alternative to conventional fusions, which is so commonly done for grade 1 degenerative spondylolisthesis with stenosis, by stabilizing the spine. And he's a very elegant surgeon. Again, I've done these devices for a long period of time. I didn't like them that well in the beginning because I was worried about hammering stuff into the spine. I actually don't like that very well. And he showed me how to do this. And since that time, I've really expanded my practice a lot to the benefit of my patients. This morning, I was a little bit late, but I did a device of this nature, an interspinous, actually interlaminar spacer. So without much further ado, for me, a truly less invasive surgery is one that does not have to do a fusion, and Dr. David is going to show us how to do this. David, thank you for coming up the coast.
Thank you, Dr. Chapman. So when I was a resident, I was taught to do a laminectomy, and it was basically what we call the CUSA. So you take this rongeur and you basically remove both the spinous processes of L4 and L5 in this case. So you'd remove all of this material here, you'd remove all of this material here, and then with the Midas Rex drill, you would then thin the lamina, and then you would decompress the thecal sac carefully and bite one way and the other, and then that would be the laminectomy. And in general, I thought after the first 1,000 or so cases of those that I did as a attending, I thought people did well from it, but it just bothered me because there was always the risk of coming back and you'd have scar tissue that would be contiguous all the way down to the thecal sac. You would lose this native posterior column. And so I started about 10 years ago just saying, I'm not going to take the posterior column anymore. And then I went really from a unilateral approach, and by tilting the patient and using the microscope was able to get a bilateral decompression. But that was not always perfect either. And so many times you get into the facet joint and you see the synovium and you're like, this patient's just gonna be really unhappy with low back pain. So about really 6 years ago, I was introduced to the Coflex idea, and like Dr. Chapman said, it wasn't like a great day in my life. You know, the Coflex is a fiddly sort of instrument, and you kind of have to do some hammering and drilling. But we started it, and we started experimenting with this really as an outpatient basis. And then I was blessed because my PA, his personal passion was in carpentry. And so he said, well, what if instead of removing the interspinous and interlaminar ligaments in a pattern to decompress the segment, and then as an afterthought, putting in the Coflex, what if we targeted everything about putting in the Coflex, basically replacing the interlaminar and the interspinous joint? And so then it hit me, what if everything we did from the start of the procedure until the end of the procedure was to recreate the posterior tension band and to allow there to be support? Exactly how much we wanted would depend on our assessment of the facet joints, but then at the same time, we must do a very good decompression. And sometimes the decompression, there's a herniated disc or something like this. Sometimes it's ipsilateral, unilateral, sometimes it's contralateral. And so no matter what the patient needs, the decompression has to happen, but always with the forethought of preserving this posterior anatomy so that you can then set up a stable situation on exit. So this is typically about the size incision we make. Like Dr. Chapman says, yeah, it's bigger than if I did it through a tube, but it's not that much bigger. And really the skin is not where the invasiveness comes from. It's how you treat the joints and the resulting function that the patient has that really decides whether you've done something minimally invasive or something really quite invasive. So what I've done is just with the bovie dissected, I typically use the microscope for all of this to preserve my own neck and just to really see in great detail. Also for the observers in the room, it's helpful. So you see how I've dissected the lamina of L4, and you want to see this nicely. Using the bovie, I've dissected nicely the soft tissue off. Here you see the L5 lamina, and the L5 lamina swooping down. With the fluoroscopy, before we started, I localized, so I put a something like this, a hemostat or a coker, to kind of make sure I have the correct angle, because the interspinous and interlaminar space can sometimes be very straight, sometimes be very angled. So you want to follow that. And then with the Midas drill, which I use, typically I like the 6mm drill attachment. The reason why is because the 8mm initial Coflex implant allows for a 2mm lift. So in general, with the Coflex, I like a 2 to 3mm lift. So I'll just show you now as we go further into the decompression. A classic cut I would make in the lamina is like this. Just sort of notching this. And so you could call this a laminoforaminotomy, but this is a rostral, really rostral foraminotomy, and that's going to be a really important thing that we're going to look at. So we're going to take that out bilaterally, and then I'm going to palpate the center, which is just under the spinous process, and I'm going to sort of take the drill under it. Very important to decompress this. You're protected, thankfully, by the ligamentum flavum, but always as you start moving, initially with all this dissection, we move very, very quickly, and then as we start to get closer to the thecal sac, obviously you slow down and you're more thoughtful about your movements. There's something called the landing zone for Coflex, and if you look at where the drill is, this is the critical part. And the landing zone is at the lower part where the Coflex is going to sit. And so I'll thin this with the drill. Again, usually the microscope is really helpful for this, so you could really use the drill and thin it down to almost eggshell consistency so you can crack through it. Sometimes this can be very collapsed, and I was showing Dr. Chapman, there's different things we use to distract. This would be a typical type interlaminar distractor that we would use. You can engage this. Be careful not to use it directly on the spinous processes because you can actually crack it, but we could use it on the side or something like this, and that'll give us some lift. And that helps you as you get that lift to get the drill and make sure you're decompressing what you need bony-wise. And you see we're starting to get basically just ligamentum left. I'm going to continue with the landing portion here. But what if you had a better retractor? And I was just showing Dr. Chapman our proprietary retractor that we've developed. And the concept being that everything is geared towards getting the Coflex in. So this retractor goes in and it mimics where the Coflex tines will be, and then it will open. And then this will give us that really desired 2 millimeters with a low profile. So again, I'm creating the landing zone here. I'm palpating up top. I'm looking at this, the bone that's in my way. And my assistant usually is helping me with suction and things like this. So Spencer's doing a great job here. Then typically this is a Kerrison procedure. So at this point, you're using the Kerrison to come in and actually get down. It seems like we still have a ways to go. So we're just gonna take this out so that for the purposes of you seeing a little better. The official company position on how much of the facet joint you can take is about 1/3. But in reality, we know that especially at the higher levels, L2-3, L1-2, I've done a couple of those, the facets become very peaked, so you don't really have that much facet to work with. And so sometimes in the process of doing this decompression, the facet can basically fall apart. Well, no worry, because you have a powerful Coflex device there to offer stability. And so this is a real typical appearance for as we're getting closer and closer down to the spinal canal. I'll just give you a note that when I was doing traditional decompressions, laminectomies, I had about a 2% spinal fluid leak rate, and I was fairly proud of that. One hates to see spinal fluid. But then once we started doing Coflex, and we just put in, I think, our 800th level this week. And so out of those 800 cases, we've had 6 spinal fluid leaks. And so that's now down to less than 1%. And so we've been talking about why we noticed an improvement in our CSF leak rate from coming from this position. And I believe it's something to do with the midline. The midline allows us to come right down to where we know the fecal sac's going to be, and then we're going to chase the ligamentum out laterally. And that way the dura is tapering away from us. And then if your assistant can really be trained, then they can really help you in terms of retracting the fecal sac so you get a really nice lateral decompression. And so you just keep going like this, and you have now a really kind of a nice decompression here. We can start to size a little bit with the Coflex, and we can see here's the 8, the gray. And you see that probably is not going to be enough lift for us. So then Spencer's handing me the 10, and often I'll just use my hands. Yeah. And you see that lift, and you see how that fits so nicely. So again, we're working on our decompression, but we've already set it up very nicely at the end for the Coflex to come in and give us that stability. And if you watch the facet joint lift, that's about perfect. Now, that doesn't mean we're done, and we're definitely going to use the 10, because let's say in the process of decompression, you realize, hey, I have to take more. Then what you do is always sacrifice a little more bone. Typically rostrally, we'll take another 1.5 millimeters and then go to the next size up. So now as you look, I've now entered into the formal spinal canal here. And then here's the landing zone. So at this point, we just go straight to Kerrison. Usually I use a Kerrison 2 for this first part, sometimes even a Kerrison 1. This Kerrison 4 is a little bulky, but I'm going to take these bites out to the side and see how I'm able to angle that and undercut the facet joint. And that gets you that really nice decompression without sacrificing a lot of the medial structure here. We talked about the landing zone, so now I'm going to come across here and just bite across. So with my assistant, again, I'm really blessed to have a skilled assistant. So pretty much he will take down this side and I'll retract with a nerve hook or something like this. So I'll retract something like this, and then he will take down this side, so that's nice and safe, right? So he'll come, like if Spencer was the assistant, he'd come this way and take down this side and make sure this lateral recess is decompressed. And then same thing, my assistant would retract this way and get the thecal sac, and then I would come this way. So really we're winning, but if you do not decompress completely, you're gonna lose. And so the thing that I've learned is that the most important tool after you get to this point is really the angled curette. And I have one made exactly with a larger cup size. And so what happens here is, again, you've not exposed any of the rostral thecal sac, but we know that the ligamentum inserts all the way up to even the top third of the lamina. So what we do is we take this curette and then you rotate it and you palpate it. And I do this very carefully because obviously you can get into CSF doing this, but you want to palpate out to the foramen of L4 here, and you want to make sure that's free, and you'll just be so surprised by how much ligamentum there really is there. The way you can safely keep yourself out of the dura is because you're watching the dura the whole time and you're talking to it and negotiating with the blunt backside of the curette. So I can watch the thecal sac as I'm going and then kind of spin, and notice I'm able to get this huge midline stuff out. And all of this is what makes you look terrible on your post-op MRI when the patient still has symptoms, and then you never got the rostral foramen cleared. So typically, I'll sweep, get all this junk out like this, and then we'll come back with a Kerrison, some nice bites here, nice bites.
Yeah, we see the dural sac nicely. Can you make sure you keep your head back, because I know you don't have a microscope, sorry about that.
Yes, sir.
But yeah, now we can see the dural sac quite nicely. And can you use a curved ball probe, please, to show us the neuroforamen above and below? And
Yes, do we have that?
Or
A ball probe, Murphy ball probe?
Woodson or something, yeah. We may have some standard pen fields. So again, so you still take off the medial edge of the facet joints on both sides. You take the ligamentum flavum hypertrophy off. You take the zone of confluence off. That's ligamentum flavum and joint capsule convergence zone.
Yeah, so let's just pretend this is your Murphy ball, which, you know, you don't want to use this to do that. But then you can feel, and here's L5. Oh my gosh, this is great. And you can basically see the patient bounding into your clinic happy because you've treated their L5 stenosis. Then you come to your side, make
Watch
sure.
your head, please. Watch your head. Watch your head. Just retract your head. Yeah.
Like that?
Perfect. Yes.
Yeah, so you can seal this, and in my mind, I feel, hey, that may be still a little tight there, so no problem. Let's just do a little bit more foraminotomy here, right? So another
And not to
bite
rush,
or
we have
two.
about 5 minutes left, so everyone wants to see. So 5
Yep.
minutes.
Yep. So we're feeling that. That's nice and free. Here's L4, beautiful. And at this point, we've gotten all of this junk out, right? And again, the curette, I can't say enough, is just the critical part to get all of this junk out. And then, so you felt everything, you're very pleased, maybe a little flow seal, and at this point, we're sailing home because everything we did was anticipating that this cofix or coflex, right, would fit perfectly. And you see that lift is so nice, So we'll take a 10, please, Spencer.
So that was a big learning point for me, because we don't want to hammer here, we don't want to ronge around the spinous process. You taught me that. You don't want to overstuff everything. You want to make sure that you get a lift, as you called it. So it's a term I've adopted from you, by about 2 millimeters. And does your new retractor actually work in the space that you're in right now whilst the device goes in, or would that not work?
No, we take it out at that
Okay.
point. So now we're actually doing these. Dr. Braxton has encouraged me and sort of talked me off the cliff. So we are now doing these awake in patients. And so that part, hammering in, I usually talk to the patients and I say, hey, there's a little tip tapping here. And the patients say, okay, I'm ready for it. And they do remember it. The crimper, not too tight.
How do you know how low to go, and why is this device called, here's a leading question for you, interlaminar spacer?
Yeah, so how do you know how far to go? Coflex is beautifully invented. So in general, if you can take a look right here, on the back, the wing will protect you from going too far. The wing will protect you from going too far. And then you always want to take a nerve hook and check. In this case...
Watch your head, yeah.
In this case, we're perfect. I mean, it's just 1 millimeter from the dura.
Yeah.
So then we'll just shoot a quick fluoro, please.
What are you looking for here? So this looks nice.
Can you can everybody see that? Yes.
Yes. Can you put a probe, pen field or whatever, onto the dural sac? I call it the metal myelogram.
Yes.
To show us the spatial relationships.
I like that term.
Metal myelogram? Yeah. So you're literally 1 millimeter dorsal from it, and that's safe, right?
That's exactly where you want it. So people have talked to me and they said, well, Dr. Ye, this is torture. Every time I go back and revise a Coflex, it's torture. I would argue this is bliss. The scariest part of revision surgery is not knowing where the thecal sac is. Even if there's scar tissue, whatever, I take a 11 blade, cut right to the quick of the U and just retract. I know where the facet joint is that's still virgin, that I haven't removed, and I know exactly where the thecal sac is. Easy to get this out, and you're in good shape.
So what's the reoperation rate of these that you quote patients over, let's say, 5 years or so? What's the overall recovery and reoperation rate?
Right, so we're now up to 800 interlaminar implants between Cofix and Coflex, mostly Coflex. And I've taken out under 20 Coflex and switched some of those to Cofix. So it's a very low reoperative rate. Quite often, I will add an additional Coflex to another adjacent level because the patient had a great experience and they, of course, other levels are symptomatic too.
Well, I have no other questions right now. Any questions from you all? No? Anybody in the audience use it? So show of hands, who's using it?
One quick question.
Yeah, can you use a microphone?
Yeah.
Come up here.
Yeah, what is your experience with Coflex versus Coflex F?
Yes, so I wanted to focus on this particular presentation, the decompression. So once you learn how to do an adequate decompression without removing the lamina, I think then it's up to you. Do you feel like the facet joints are past a point where they can support motion? If so, then I would strongly consider Coflex F, removing the facet joint, in PLIF approach, taking out the disc, instrumenting the disc, and then using the Coflex F or the Cofix.
So for me, one of the key first learning points was, and this is many years ago, not just barbarically ripping off the posterior elements and doing a full laminectomy. I think this is an anachronism, however you want to approach it now. And again, doing midline preservation is actually a very sensible thing. It's like the fourth column of the spine. Wouldn't you agree? So this is a big difference in terms of how we approach this. And I think there'll be a whole new generation of interspinous fixation devices coming out. Now, these are outpatient surgeries nowadays. This lady that I did this morning is an employee here. She's going to go home this afternoon. And I made an incision this big. Is Dr. Chua back there? this big. Too big. Dinosaur. And no robot. I don't know where I was. Just zen. But this is very good, so thank you, David. Oh, wait, question. Dr. Skaggs, our next lecturer, has a question, but we need a microphone.
Yes, I have a microphone.
Oh, great, you're prepared.
Yeah, so, I'm only a pediatrician, so I may be missing something here, but I thought if you distract posteriorly, you cause kyphosis, and we want to maintain lordosis.
That's a really good point. So what I've learned in these implants are if you get the U of the coflex truly anteriorly enough to the lamina, you lift the entire segment, as opposed to the superior vertiflex or the other interspinous devices. The fear is always going too anteriorly, right? Because you've not done a decompression, you don't want to jam something anteriorly. But here, if you look at the X-ray, if we could put that X-ray back on. Yeah, you see how the whole segment has been lifted because the U is so anterior. And so I've not had any problems with segmental kyphosis with this.
I did it myself. Great question, important question, yeah.
When I started doing the co-fix, I was using basically parallel cages, but now I've gone to using a higher lordotic cage, because then it's tricky because you're trying to get lordosis with the cage, but then you don't want to lift too much and unload your cage at the same time. So that's a little bit of a trickier thing, but if you can find me and stop me, I'd love to discuss that with you.
I think that was a really critical question from Dr. Skaggs. Thanks for asking that. So we don't want to kyphose patients. That has not happened in my experience either at all, but we don't want to overstuff this, which was my mistake initially. This is actually a very elegant surgery. And thanks for showing us that and coming up. So the first learning point here is don't just rip off the whole backside. We are way better than that now, whether you use a microscope, an endoscope, or whatever. And secondly, think about preserving, not just fusion, but doing truly less invasive surgery, but not changing the mechanics permanently by doing a fusion on everybody. We can't, or we don't have to do that. Spondies, topic. Can't ask for a better lecture than that. Dr. David Skaggs, professor of orthopedics, neurosurgery, and pediatrics, co-director of spine at the world-famous Cedars-Sinai Hospital in LA. He's also the man who's running wheelless orthopedics and orthobullets, and so this is a must seek for anyone in the orthopedic realm. It's so great to have you here and talk about spondies and young athletes, a common problem. So thanks for coming, Dave.
I'd like to thank everyone here for putting on this course. It's really an honor to be faculty at this course. Any point, just interrupt me. Let's make this interactive. So we're going to talk about spondies in young athletes. So now we know spondylolisthesis is a stress fracture. Now it happens in 6% of the population. Most people probably don't even know they have it, and most people it's probably not a problem. Now it's pretty specific on exam when a spondee is causing a problem. So when a spondee causes a problem, they bend backwards and it hurts right at L5. So if you have this on exam, the spondee could be causing the pain. If it's not that on exam, the spondee probably isn't causing the pain. And we found that when people came to us with spondies, on average, they were misdiagnosed for 6 months after first seeing healthcare professionals. So this is something missed all the time by people. And if we look at that video on the right, you could see that probably what happens is the nutcracker phenomenon. The L5 or the L4 inferior facets hits the pars and physically breaks it as athletes are bending backwards, whether it's a football lineman getting pushed backwards or a gymnast. But we have to make sure that the spondee is what's causing the pain. Oftentimes there's another condition called a facet fracture. Facet fractures are almost always missed on MRIs, they're missed on SPECT scans, they're really only seen on CT scans. And think of a facet fracture as being like a piece of sand in your eye. If you take it out, you instantly feel better. If you leave it in too long, it might cause arthritis and problems. And it could be taken out pretty easily. People here probably know how to do it better than me. Put it in a tube, find the broken bone, pull it out. Don't have to do much more than that. Sometimes it's so small you can take them out in a sucker. So far in my experience, if there's an isolated facet fracture that's painful when someone bends backwards, 100% of the time you pull it out like, wow, thanks doc, that feels a lot better. We did follow up on some kids, and while they all feel better instantly, down the road people do have some back pain, but this certainly allows kids to go back to sports. So let's talk about imaging and spondies. So the lateral radiograph, oftentimes will show a spondy. The MRIs may or may not show it's hot. Well, I don't think I'm going to use that anymore. And the SPECT scans may or may not show it's hot. And it's kind of a question, what do you want to get? We certainly want to get x-rays. It's really quick, really easy. I think an MRI will give you the big picture and help rule out other issues, but the gold standard of seeing if there's a spondy or not, how big is the gap, is there a facet fracture, is the CT. And maybe a good practice is get the MRI first, big picture, it could show you where it's hot, then you can get a CT just of that level, if you're going to want to try to heal it, consider surgery, or make further decisions. And in my practice, at one point, 64% of the kids that came in with a CT-proven spondy first had an MRI that was misread as having no problems. So, whenever you talk to a radiologist, they say, well, if you do an MRI like I do, you can see it here and there. But to this day, MRIs miss spondies constantly. If you have a high clinical suspicion, consider a limited CT right where it hurts when someone bends backwards. So if it hurts around L5, get a CT from L4 through the sacrum, not too much radiation, you're going to get to define the spondy. We do not need oblique x-rays anymore. All this does is give extra radiation. We do not need flexion and extension films. I know in the adult spine world, people do this all the time. I've never once seen it contribute to the care of a young athlete. Instability is not an issue in a young athlete. The only people that want you to get these are the insurance companies. That's a little bit backwards. So again, no pain, no problem. I first saw this girl when she was 8. She became an Olympic gymnast. She had like 5 doctors tell her to quit gymnastics. I said I could fix a broken bone, not a broken spirit, go for it. She had an entire career, and we can see that her spondy did not progress over time. People can play athletics with spondies, no pain, no problems. Some studies have shown that if you take people out of sports for 3 months, 50% of the time the pain goes away. Now, it doesn't always heal. Maybe it just calms down. Maybe there's a fibrous non-union. But if you don't take people out of sports, it doesn't heal quite so often. And what's important is when we're looking at images, it's very clear. If a spondy is not hot, it's not going to heal on its own. Spondies could heal with gaps of 1, 2 millimeters, maybe even 4 or 5 millimeters. If you give it enough time, not too many people want to wait 5 months, but sometimes that's what it takes. And what's also important is bracing of an L5 spondy has not been shown to be helpful. We're all told to brace because you all feel like we're doing something. Biomechanical studies actually show if you put a brace on someone, you cause more stress at L5 because you're immobilizing the vertebrae ahead of that, or on top of that. So in the old days, I do open direct repairs. It works. It's a fair amount of open surgery, but the kids could tend to go back to sports. And if we're considering a direct repair, what we want to have is a lot of bone surface area next to each other, like we see on the left. On the right, where there's very little bone surface area, direct repair might not work so well there. You might want to lean more towards a fusion in that instance. And I want to thank my partners at Cedars-Sinai. Before I went there, I've never seen an O-arm, I've never seen a robot. A lot of these guys taught me MIS surgery, and now we do that for spondylolisthesis all the time. So let's go over a case. Here's a kid, 15 years old, had 18 months of back pain. Think about it. A kid, even in school, had back pain. Doctor after doctor kept saying, oh, put on a brace, go to therapy. You get a certain amount of patient blaming at this point. They must be doing something wrong if they're not getting better. I usually do not do a bone scan, but since those cracks weren't too big, wanted to be sure, yep, hot on bone scan. So we could plan this with the robot. And I'd say one of the best things about the robot is the preoperative planning. You see the red arrows up there? These screws come really close to the joint above and the joint below. I probably spend 20 minutes planning the perfect screw. And if you do it correctly, you could also have the screws come through the skin at the same point. So you could do this through one incision, usually just about a 2-centimeter incision is all you use. And I'm a big believer in using a robot system that has both a surveillance marker and a reference frame. If you only have a reference frame and it gets hit accidentally, a centimeter off, every screw after that is going to be a centimeter off. So you want to have a system that has a surveillance marker and a reference frame, or somehow figure out how to have 2 points on the body so you know you're in the right place. Then once you make your 2-centimeter incision, look up at the screen. Now, ultimately, we don't want to be looking at the screen when we're drilling down there. Hopefully, at some point, we get augmented reality glasses, so we're looking in the same place as we're screwing. That should be the next step. And we want to have a Swiss cheese model of safety. More than once, I look at the screen and the screw is in the perfect place. We check it with fluoro, it's not in the perfect place. So I think we want to check things with fluoro, feel the ball tip probe, get a fluoro machine in to make sure it's in the right place, and I stimulate the screws. Why not? Why not do every level of safety we can? It just takes a little bit more time. So this athlete, I did not tell him to go surfing in 2 weeks, but he felt so good he did. I never thought I'd be doing outpatient pediatric spine surgery, but now we do on a regular basis. And this really changes kids' lives. We constantly get these emails about a year later, he's playing football, lifting weights, going back to normal. And if you think about it, an orthopedic surgeon, you have like bone broke me fix, we put it in a cast and it fixes. It's a little bit harder to fix something in the spine with a brace. It doesn't just work. And maybe as we move less and less invasively, our criteria for fixing these, maybe should be a little bit lower. So this is the first one I did. I took a CT at 5 weeks. I was like, wow, what's going on? There's osteolysis. Is it infected? Is there movement? But it's an HA-coated screw. So the bone had not yet incorporated. By 9 weeks, the bone incorporates into the screw. Generally, by 10 or 12 weeks, they're pretty much completely healed. This is what it looks like at 25 weeks. And now there's some evidence that once one has a spondylolysis, there's abnormal forces at the disc, and it leads to early disc degeneration. I can oftentimes look at an X-ray or CT or MRI and see that someone's a gymnast because they have the spondy and a disc degenerated at the same level. So perhaps fixing the spondy early may save someone from disc degeneration. So here's a professional baseball player, who thought the career was over after fixing this robotically, outpatient surgery, guy's back to his career. So here's a mistake that I made. And what's interesting is you could see how far off that drill bit is and how far off the ball tip probe is. The robot screen said it was perfect, but it didn't feel perfect. The mistake I made here was when I planned with the robot, you could see there on the left where the red arrow is, the robot arm hit existing spinal instrumentation and sent us off by a few millimeters. So in this case, we had to just open it up and put it in the right place. And here's another frequent mistake that's made. When you put in an intralaminar screw, it's kind of this little knife edge. It's really easy to skive the screw off. So one way to fix that is put in a guide wire. Get the guide wire in, feel that it's in place, get a fluoro, know it's in place. And what could go wrong here, right? Even a monkey could do this. Yeah, I'm not that good. I messed up here. I'm sharing this with you so that you don't make this mistake. What I should have done is as soon as the screw was past the fracture site, I should have pulled out the guide wire. I didn't. The guide wire broke. Fortunately, this is stuck in bone in the disc. The kid is 6 months out playing sports. We didn't need to do anything, just left it in place. Don't make the same mistakes I did. So what about if we have a larger gap? Like here we have a 5 millimeter gap. Probably just putting a screw across this won't work. So how do we do it? Step one is just put a screw across it. Step two is plan a phony screw with the robot. Plan a screw that's going to go right to the spondylolysis site. And then we can pass a guide wire right to the spondy site, As we have that incision, we could sneak an Acumed bone graft harvester into the iliac crest if we want to. And if we want to, you go medial to miss the cluneal nerves, as the earlier study showed. Run some tubes over this, put a microscope, and then you see the screw. It's pretty cool. You know you're in the right place. Take out all the fibrous tissue, throw in some bone, and it heals. And here's an example of a kid that heals 3 months later. And I generally tell kids, you will be healed at 3 months. You can go back to sports at 3 months. I don't think I've had anyone that has it yet. And this is what it looks like a year out. You have 2 little incisions, one for the screw and one for the direct repair, or one for the bone grafting. And this is a kid who's a doctor's kid from the East Coast. Look how much bone is there 12 weeks post-op. She went back to volleyball, 10 weeks after surgery, 2-centimeter incision plus another 2-centimeter incision. So spondylolisthesis is way different in the young and the old. In the young, it's virtually always a fracture. Great majority of the time, it's at L5, and you treat it as a fracture. In the old, it tends to be at L4, L5. It's degenerative, it slips over time. There's not always a fracture, and the ligaments are stabilizing L5. So when we think of spondylolisthesis, it's a completely different animal in the young and the old. And, I was fixing the spondylolisthesis from the back with the T-lift. And I noticed I had a lot of failures, like 4 years out. These kids are going back to sports. And as I was speaking at different medical centers around the country, a lot of people are having these failures. We put together 5 busy pediatric spine centers. We had a 40% reoperation rate of fixing spondylolisthesis from the back. Even if you used a T-lift, it didn't help at all. A lot of nerve root irritation. And for some reason, while a posterior fusion instrumentation and T-lift may work in adults, it doesn't in teenage athletes. I think they're just too active. So in teenage athletes, if there's not too big of a slip, we now do a ALIF and posterior instrumentation. I have had one case that's now a month out, I think, of a retrograde ejaculation. If anyone could teach me about that, I'm open to it. It made me a little bit shy to do an ALIF in a young athlete. So let's talk about high-grade spondylolisthesis. And I think I'm going to make some of my adult colleagues cringe here with what we do. So this is a 15-year-old level 10 gymnast, dreams of a college scholarship. Her back pain has gotten so bad she can't even sit up in school anymore. If it hurts when you play sports, it's up to you, if you want to get it fixed or not. But once it hurts when you're in school, you probably need to get it fixed. So this is how I fix it. I like just leaving it in place. In the SRS database, the only surgery where the complication rate is increasing over time is high-grade spondies. And that's because whoever's on stage says, oh, if you reduce L5 my way, you won't get a nerve root injury. But the guy who's not on stage does get nerve root injuries. And we know statistically, there's a lot of L5 nerve root injuries when you reduce L5, even if you're doing it partially. So if you're working with a robot, it is unbelievably easy to put in the L5 pedicle screw. When you're doing that open, it looks like it's 10 miles down there, you can't see anything. Right now, I'd let the PGY2 resident put in the L5 pedicle screw through a robot. It makes your life much, much easier. And also, that home run S1 transdiscal L5 screw, it just becomes much easier as well. Technical tip is you want to put in the screws at L5 and 4 first, and the pelvis, and put a rod across it, because otherwise, if you're drilling across S1, L5, you may separate it a little bit, and that causes basically a reference frame shift, and the screws after that could be off. So here's what this kid looks like post-operatively. Effectively, this S1 L5 screw is anterior support. I've done this surgery now for 28 years. I've never seen one fail. I've had a lot of people go on and do D1 athletics. Here's a typical kid. This is our level 10 gymnast. 3 months out, pretty good motion. And even though you look at the x-rays and cringe, it doesn't look perfect, the patient's bodies look perfect. I think as long as you get the L4 S1 to about 45 degrees of lordosis, I should have done better here. I think that we could have good long-term success. And here's the patient, did a full career as a level 1 gymnast, NCAA, after that surgery without any problems. So that's it. Open to questions.
That was simply fabulous. And again, just starting with the workup and the assessment towards the surgical fixation strategies, that's a really big deal. So let's start with flexion extension films. Did I hear you right? We don't have to do those anymore?
Not in the young athlete. Now, I think it plays a decision-making role in adult spondies, but it doesn't in young athletes. Like if, the indication to fix a spondy in a young athlete is pain, and I think I'm going to fix it the same way, whether there's a little bit of motion demonstrated or not. And I think we effectively get a lot of information from the MRI or the CT. When the patient lays down, you see how much it reduces without gravity.
Rapid fire question number 2, stress fractures. So we know, and you know way better than I do, that stress fractures, let's say in the extremities, are actually a very pathologic process. It's a devascularization and a sclerosing of cortical bone. So it's actually a dead zone. There's nothing living in there. So how do you get around resecting that and supplanting that? When I do pars repairs, I actually cut out all that dead stuff, put a corticocancellous graft in there, and then put a very archaic dinosaur fixation on there. But I'm very comfortable with that. But how can you get away with just a far less invasive surgery and then get the bone to transgress?
Yeah, I share your concern, and I was very nervous doing these for the first few. And I think if you only have a 1 millimeter crack, it seems that putting in an HA-coated screw and having such rigid fixation on both sides is enough. All I could say is it works. But I too believe that if you have a gap and if the MRI is not hot or the bone scan's not hot, it's dead bone, you probably want to take away more bone than you leave. In those cases, I'll use iliac crest bone graft and bone morphogenic protein. And using both of those things, it seems to work.
So the heat assessment, meaning the activity, the osteoblastic activity assessment still plays a role in your surgical grafting.
Absolutely. And these techniques may not work in 60-year-olds. If you're not a good technical surgeon, do peds. You have better protoplasm. The kids heal better.
Now, final question from me. And this is just spectacular. It's such a rich and a wealth of information that you gave us in a short time. Female high-grade spondies and internal fixation. Do we have to worry about S1 screw prominence? Do we have to worry about, in these dysplastic pelvi, to actually put screws that go into the pelvis, meaning sacropelvic fixation, like what you showed in that one case? Is that a problem for the natural birthing act?
Maybe. I've had enough people express concern that if we put in great big pelvic screws and someone's pregnant, will the pelvis be able to open up or not? So what I've started to move to is using 2 S1 screws and 2 long sacral alar screws that are HA coated. I'll give you more feedback after I have a few years of follow-up with that. Yes, sir.
Quick question. This is from Linda regarding somebody in the chat box. Pars repair is an inpatient code only. Do you do this in outpatient and an ASC?
I do this outpatient all the time, but I guess I do it in Cedars Medical Center. Maybe that's not an ASC. Maybe that's the way around it.
Sounds good.
Yeah. Anything else? Thank you. Oh, yes, sir.
I guess the microphone is not functioning, but I just had a question about.
One second, here, take this. Sorry, what's your glass? So tell us who you are, where you're from.
Awesome. PGY4, UC Irvine. Question about the grade 5 spondylolistheses, the spondyloptosis. Do you also not reduce those at all, or what is your
I do not reduce those. Now, if the patient has significant nerve root pain, do a huge decompression, big enough to drive a truck through. But I found as long as you put 2 big pedicle screws across the disc, it seems to hold and it fuses over time. I've been lucky enough to get some CTs, years out, and they just start to fuse, get them in place. Yeah, thanks.
All right, we're going to transition before lunch to Dr. Sansor in the lab, talking about sacropelvic techniques.
Very much. I have the privilege of working with Dr. Gersmeyer, Julius Gersmeyer. We're going to do this together. So we're going to go over sacral and pelvic fixation techniques. And I'm going to point out a few things on this dissected specimen here. So if we can have the camera. So you can see this is the PSIS right here. So we've done a lateral exposure to help us see our important reference points. And we're going to go over standard iliac screw placement, where the entry point would be right here, where the PSIS is. It's this bone right here. We're going to go over the S2AI trajectory, which would basically be right here. And so the sacral foramen is right here. You can put your instrument into the sacral foramen. That's the sacral foramen. This serves as an important reference point because the bottom of the sacral foramen is the top of the S2 region. And so the S2AI is therefore caudal to the sacral foramen. And then our S1 pedicle screw is going to be right here. This is the mammillary process right here, and our entry point is going to be right there. So we'll go ahead and get started. First thing we're going to show is the iliac screw. I usually start this out with a talar retractor. The tooth of the talar retractor would be right here, and we would be exposing it like this. So you can see how that ends up being a useful tool to get the soft tissue out of your way. And so an important step in the iliac screw, a lot of people say the iliac screw is compromised in terms of screw prominence, but that may be due to the fact that maybe some people skip this step right here. And so what you can do is take an osteotome and just cut through the PSIS and make a little box. Sorry, my hand is probably in the way. And so usually I make this little box. And you get a little piece of bone. Some good autograft. And so what is exposed right here is the cancellous bone of the ilium. So you can see that nice cancellous bone right there if you look down. And so the next step is to basically follow the trajectory of the iliac wing. So you can see if you look at my hand right here, you can feel for the greater trochanter. And you're going to basically point towards my hand right there. And so let's go ahead and grab the probe. So we have the advantage of navigation. But I'll just go ahead and put it where I would think I should put it, and then maybe we'll check the navigation afterwards. So the traditional trajectory is going to follow the cancellous bone, and you're going to probe down and let the path of least resistance guide you. And see, is the navigation catching it? Yeah, so you can see I'm skirting the outer margin, so I can change my trajectory slightly. And you can get a fairly lengthy screw. I'm not sure how deep I am, but it seems to be pretty deep. So that's a standard iliac trajectory. You're guided by the cortical surfaces, and so that trajectory, we can now, Julius, you want to go ahead and tap that right there? Let's go ahead and tap it to 80. Do we have a feeler ball? Do we have a feeler ball anywhere? Oh, okay. Great. So we're just doing our due diligence, making sure that there's no breaching, there's a good bottom everywhere, has a lateral, medial, caudal, and cephalad wall, and we can go straight to the screw. Let's go ahead, and that's a 8580 screw that we're putting in.
Hey, Charlie, this is Rick. Wondering if you ever employ power to either drill your pilot hole or place the tap or place the screw, just thinking about all these young surgeons in the room and try to avoid their carpal tunnel.
Yeah, it's a good point. You know, I probably should use power, but sometimes I have easy access to it. But yeah, I agree with you. I think especially when you hear the sound of this bone, that cortical interface, it is a lot of effort on our bodies. So this would be a very good indication for power. So yeah, if you push this button, yep. So the cortical interface is quite strong over here. And so this is basically, that's the standard iliac screw. We probably could recess that a little bit deeper, but we could do that later. Now we'll go ahead and go over the S2AI trajectory. So again, I'm going to use this navigation wand. It's going to show us the sacral foramen. So that's the sacral foramen. You can see that I'm putting it inside the foramen. So our entry point is going to be below the sacral foramen, and that serves as kind of like the top of the S2 pedicle. So you can see this is the S2 ala right here. That's going to serve as our entry point. I'm going to drill a little bit. So again, sacral foramen, the top of the S2 pedicle is going to be right around here, and my entry point for the S2AI is going to be below this ridge right here. That's going to be our entry point. Typically what happens with the S2AI is you're going to engage about 30 millimeters of bone of the ala before you start encountering the sclerotic bone of the SI joint. So I'm going to advance this about 30 millimeters. I'm starting to feel the sclerotic bone of the sacrum. We can check ourselves with the navigation. Yeah, so pretty much right on the dot. I felt it. You know, that was the sclerotic bone of the SI joint that I was expecting to see. And so now you can pass the SI joint and continue into the ilium. These screws typically are a little shorter than the iliac screws because the trajectory is more steep. Now let's go ahead and I usually probably around 70 is what I would expect this to be before it starts to violate the lateral wall of the ilium. So let's check with the navigation to see. Yeah, so you can see we're starting to get close to the lateral wall of the ilium. Is that 70 over there? Yeah, so you can see it's just about what I would expect. You know, right around 70 is when the tulip head is going to be hitting the floor of, or the top of the sacrum. So that's pretty much the trajectory. And so we can take a feeler ball and feel it real quick. Here's the feeler ball. Feels good. Okay, so let's go ahead and tap it. It's important to tap, I think, the S2AI, because if you don't, sometimes you'll start stripping the sacral ala. And it will make the insertion more difficult. So I think tapping it is a good idea. I would go ahead and tap it. Let's go ahead and tap, make sure. Did you tap it all the way? Yep. Okay. So let's feeler ball one more time.
Still have resistance.
Okay, great. And so now we'll go ahead and put this screw. You can see this is the double iliac fixation here. Caudally we have our standard iliac screw, and a little bit more cephalad we have the S2AI screw. Let's check the navigation and see how that looks there. Yep, there we go. Okay, and now I think the next thing we should do would be good just to show an S1 screw. And so this is going to be our entry point for S1. You can see the sacral ala is here. Here's the lateral aspect of the L5-S1 facet joint. So we're going to drill, whoops. Okay, that's our entry point for S1. And so there's our entry point right there. And then, so we'll just go ahead and for S1, it's going to be something like that. Let's check the navigation there. That looks pretty good. A little bit of hand towards head, I think. Yep. Yeah, the bone is actually sclerotic. Maybe we'll get a 6.5/45 screw if you have one. Okay, great. Okay, a little deeper. Do you want me to drill for you?
Yeah, I think it's
Okay.
just Robotic.
Okay, that looks pretty good. So now we'll go ahead and tap that. We'll get a feeler ball just to verify that there's no breaching. Yeah, feels perfect. The navigation was nice and very accurate. That's, yeah, okay, we'll just go straight to the screw. This screw has serrated tips, so you don't really need to tap. This is right there. Okay, perfect. So yeah, you can see how we used navigation sort of in conjunction with the freehand technique. You know, we used our visual cues to guide us and the navigation to confirm what we knew. And it's sort of how you can use the two systems in conjunction without necessarily relying on one versus the other. I want to point out a couple things with regard to fluoroscopy. So I'm going to take this off real quick just so that we can look at some of the fluoroscopic views to just go over a couple things in case you don't have navigation. So what we should do is let's rainbow towards me a little bit because we're actually doing the other side. So we're just going to get a standard teardrop view. I want to show the teardrop view to everyone. Yeah, this side. Let's rainbow towards me a little bit more. Oh, got it. Okay. All right, let's see what we can see over there. Yeah, so you can see that you can pretty much see the teardrop in that X-ray. The iliac screw is engaged in the teardrop, and the S2AI screw is engaged in the teardrop, and you can appreciate that they both respect the cortical walls of the teardrop, so they're both appropriately placed. Now let's go and do the pelvic inlet view. I think the pelvic inlet view is also a nice view to look at both the iliac hardware as well as the sacral hardware, because the pelvic inlet view, whoops. I think we need to go a little bit more south and then tilt it all the way until it hits the table right there. So you can see we respect that pelvic ring. You can appreciate that the S1 screw, we could have inserted it deeper. If you want to check to what degree you're bicortical, the amount that screw violates the pelvic ring will tell you to what degree you're bicortical. So I like to do this at the end of a sacral instrumentation to get the pelvic inlet view so that I can see exactly where my S1 screw is. We talked earlier during our SI joint anatomy that the L5 nerve root is at risk when you violate the sacrum. If the sacrum is violated closer to the midline, the L5 is safe. If the S1 screw violates the sacrum and it's pretty lateral in position, the S1 screw might not be safe. And so the pelvic inlet view, I think, is a good way to check to what degree you're bicortical and to what degree you are too lateral. So this is a good tool, I think, to use for those individuals who don't have navigation. So yeah, that's it. S2AI, iliac, and sacrum. Looking at the teardrop view, looking at pelvic inlet view, and utilizing both freehand as well as navigation all together. Yeah, you can pull out.
Charlie, that was really great.
This is all for my own edification. What do you do when you're facing a long construct that needs a pelvic support with somebody who has sacroiliac bone plugs? Who has an SI fusion from prior?
Yeah. So in that situation, what I need to do is open up the lateral approach where the SI fixation devices have been placed, and actually extract usually one of the 3 implants. If I take one of them out, I can usually create a corridor of entry for my pelvic fixation screw. And what I'll do after I extract one of those implants, I'll put in either autograft or allograft into the place where the implant used to be, and that serves as a conduit for bone growth. And then that will give me the real estate I need to put in my pedicle or my pelvic fixation screw from the dorsal approach.
And you do that by looking at your pre-operative CT to see which one you want to?
Yeah, so I'm going to choose usually the most caudal one, because I can plan which one based on looking at the pre-op CT, and I'll use usually either fluoro or navigation to help guide me to that area. If it's a triangular implant that's in place, I strongly advocate to get the guide that was used, that can be used to really carefully direct an osteotome along the surface of the triangle. There's a specific apparatus that is made by SI bone to help extract those devices when necessary. And so without it, I think it's risky. So you really need to have the guide that will create the trajectory to guide the osteotome to cut along all 3 of the triangular surfaces.
Thank you. Any further questions? Yes, Dr. Chapman.
Should we routinely do an SI joint fusion since you're there already? To burr out the joints is not that big of a deal and stuff bone graft in to kind of get a bony foundation of the hardware? Because you gave a great Tuesday evening conference one on pelvic fixation failures, and it was shocking to see how often they actually fall apart. So why not put bone graft in there? Is that something we should routinely do?
Yeah, I think if the patient presents with preoperative SI joint pain, in addition to their spinal deformity, I would advocate to decorticate the SI joint simultaneously. However, if they don't have preoperative SI joint pain, I'm not sure if the standard of care would dictate that we fuse it all together. So I would say it depends. If the bone quality is poor, it may make sense to decorticate the SI joint to just add early arthrodesis of the SI joint, maybe in the hopes that the biology would take over before the bone around the hardware fails. But I think in my practice, I currently just fuse the SI joint when the patient has SI joint pain.
I tend to see less of that with pelvic bolts if I put 2 pelvic bolts. And currently I'm getting to the interesting phenomenon where I put 2 on one side and 1 on the other, and the patient has some irritation on the side that was just 1 pelvic bolt was
Yes,
placed.
I've seen that too.
Yeah.
Often the side that lacks the fixation and the asymmetry, that side is going to be the painful side. I agree.
All right, unless anybody else has any further questions, I think we can adjourn for lunch, and also while you're in line, take a good look at our great sponsors next door. But how many more minutes do we need? 5 more minutes. All right, time to stretch and look outside. But we'll be starting on time, if not 10 minutes early. Okay.
Great job. I like that.
I'm sorry. I didn't know. Everybody know you got your food.
This will be your first one? Are you supposed to go in and localize it and actually resect it? Or can you just firmly ablate it? Or what's your... You can't just... It's like the Japanese resection versus
I think you just like it. Charlie wants to get this.
No, one of our
You're a neurosurgeon.
That's the argument I've heard of them not being able to maintain that compression kind of. But you're saying if you go to midline, it's almost good enough where you can still reach your status. You can see in the CT too. I mean, Hannah's going into like nothing.
This seems like you're so old. Sign the contract, big boy. Go down to California. I know, right?
Fantastic. You saw the light?
Yeah. It's only a year ahead. It's only a year
You a ball girl? I thought that was gonna be me because I did first team.
Lunch is ready if you want to hop in line and grab some lunch.
You're gonna be in for it now. This is kind of the toughest age, like 12, 15. I feel like around 16 or 17.
When's the baby coming? Oh my God, I can't believe she let you out. So good. Second World War.
Super old fashioned. Super old fashioned. Have a third one. This is such a specious talk.
But it's good.
Huh? It's different, right? I mean, you know, it's different. I'm definitely a lot more mellow than I was.
I go to her house all the time. I like to keep down.
Oh, hey,
yes.
good to see you. Nice to see you. I sit back here and think about how great this course is. I can't believe you guys have been doing this for this long. It's just such a great course. But I have one suggestion that what you guys think. LAS and CNS have competition for residents. So maybe put together a competition, like a question for each structure, and then they have to go out and answer just something that kind of engage them and that, either if it's those electronic polling things, paper at the end of the competition. Yeah, like a little test. Yeah, like a little test or something. Yeah, but then the LAS and the CNS, with all this that they have,
You guys just started a residency too.
no, we've had one now for, it's not been that long. Yeah, in Arizona, Phoenix. Phoenix just got it.
That's where.
Yes, they're brand new. Yeah, so they just got approval, I think maybe we'll have them have it for this year or two. I'm not sure they're officially about for the match yet for another year or two.
Oh, wow. Handout. It's a true how to excellent suggestion.
Just something that.
I thought you should hear from the horse.
Okay.
It's bound to skills.
I'm old, man. I'm just calculating like when I can like fucking get the insurance money out there. Looking through like all those things like
How are your older girls doing?
Start school, one starting school this year, and one finishing college.
Do they all both go to same? Wow, they all just about this.
Yeah. Not bad for you.
I'm surprised, like, how much children even like could actually. It's like the last place out there. Yeah. I'm not ready for that.
I start over.
Go to it. Pleasure. Oh, wow. Excellent. Excellent. Strong. Very nice.
Yeah, of course.
So you're at Banner. My name's Navi.
Yeah.
Nice to meet you. I'm a resident.
Oh, perfect.
I see Dr. Bosch posting on LinkedIn all the time. He's neurosurgeon, right?
Yeah, he's a
You're
neurosurgeon.
ortho?
Yeah, no, I'm neurosurgeon.
Oh, you're okay. So you're in the same department.
He's in Phoenix.
Oh,
So
got
in
it.
Arizona, we have two University of Arizona.
Okay. Okay.
Yeah. Yeah, he's a
Very big on LinkedIn. Yeah.
they just got approval for neurosurgery residency, which they have not yet started. But we've had a residency for 15 years, 20 years maybe.
Okay.
I've met, not in person, but two of the UCI neurosurgery residents. And they went to Nepal on one of our trips in April.
Do you guys go over there routinely for like?
Yeah, I go over there once or twice a year. Yeah, mission type trip. I go in there for about 5 or 6 years, 8 years.
That's amazing. So how does that work in terms of following these patients up after surgery? Is it a sustainable?
Yeah, so we work with the neurosurgery department there, and so the point of the mission trip is to teach them techniques and technologies so that they can sustain it, not just go in and do a big
Parachute in,
parachute in.
Yeah.
And we just start kind of simple, so we just taught them MIS tubular surgery.
Yeah.
We've got some companies who donate equipment so they can keep doing MIS tubular surgery. They're a low-income country, so, hardware and instrumentation is tough for them to get.
Do the patients have to provide the hardware?
So So what's interesting is in a lot of these countries, the surgeon will say, you need a anterior cervical fusion, and then they say, you need to go negotiate your implants with these 3 implant companies. So the patient does the negotiation with the implant company, and once they've signed the contract, paid the implants, then the surgeon does the surgery to those implants.
That's incredible.
Which is kind of weird. Or
Kind of upside down.
Yeah, kind of upside down.
Is there a big need in Nepal? I'm sure.
Yeah, the Structurally though, like, they don't present with lumbar spine problems until they're in a wheelchair or foot drop for 2 years. It's cultural pain is not, like, they don't come to see spine care because of pain. They're just very hard workers and they put up with pain. So sometimes, yeah. So sometimes we'll see people who are, in a bad way. The first case we did there was a 45-year-old lady with COTS disease. COTS success were treated with antibiotics or whatever. And then she developed a type of scoliosis, and then she can't walk. Replaced with electric halter because of pain. And so we did a kind of a weird deformity type surgery to stabilize her, and then she was able to walk about 2 months later. Her husband was having to pick her up from the bed in the toilet. She had power, but she just couldn't tolerate pain. So
I feel like that's the sort of thing I'd love to get involved in. Are you doing this through a 501(c)(3) or?
Yeah, we actually formed our own.
Okay, so
yep.
it's
Called, yep. No, not through the university. Me and 2 neurosurgeons from Seattle put it together. So it's called the Nepal Spine Foundation. Okay. You can look it up. Sorry? Who in Seattle? Richard Bones, he's a private practice neurosurgeon here. He's actually the one that started going about 12 years ago through neurosurgery has an international education foundation that he worked through and did went on his first mission trip, and then he just went on his own, funded it himself. And then he took me and our other buddy, Faroki, he's at Virginia Mesa, he's a neurosurgeon, used to do a lot of surgery. And so
hi, everyone. I don't want to interrupt anybody's lunches, so please just keep going. I just wanted to quickly and briefly introduce myself. I'm Lindsay Wheeler. I'm the Neuroscience Fellowship Program Manager here at Swedish Neuroscience Institute. We are very lucky to have several subspecialties within our fellowship program, cerebrovascular, endovascular, neurosurgery, skull-based pituitary and neuro-oncology, as well as complex spine, interventional spine, and then neurosurgery and spine research. So we have a pretty extensive program, 10 to 12 fellows per academic year. But I just want to welcome everybody to Seattle Science Foundation, welcome you to Seattle in Swedish, and just say hello. So welcome.
Hey, I'm doing well. How are you?
Nice to see you.
Nice to see you too.
Is he going over the? I thought it was Ethiopia. You're gonna do a lot of videos. So is he going out there soon? No, he goes. Oh, that's he's next week. You'll pick it up. Yeah.
Hi, Dr. Mendel.
I have COVID, so now I'm stuck at home.
Oh, no.
Yeah, I just found out 2 days ago, so it was good that I actually did not come.
How are you doing?
I'm taking Implant. Yeah.
I will.
Corey, can you see this?
I can. Do you want to put it into full screen mode?
Yeah, once I do that, I cannot see you. It covers the whole screen, but I'll do
Okay.
that. Let me just...
But let's just practice.
How's that?
That's perfect. That's
Okay.
perfect.
All right. Actually, I do see you. I still see you,
Do
so that's
you?
perfect. Yeah.
Okay, good.
So I can just leave it like that and just take it from here.
Yes, you can. How are you doing? I
I'm
heard you
doing...
had COVID.
Yeah, I just found out 2 days ago.
Oh, you still look fantastic.
Thanks. I don't feel as good, but I'm
I'm
good.
so sorry.
No worries. How's it going over there? Lots of people I can see.
So much fun. We've got such a large crowd in the house. It's really nice.
How many do you have registered?
We had, I think, 47 in person. There was a few last minute cancellations. But 47 residents and fellows here in person, which is really great.
Okay.
Where's everybody?
Excellent. And it's going today, Saturday and Sunday? I'm doing fantastic.
Wonderful. So,
well, considering, yeah.
The crowd together and start off with a wonderful presentation by one of my dearest friends, Dr. Mendel, on multidisciplinary management options for patients with spine tumors. He needs no introduction. Take it away, Dr. Mendel.
Thank you, Kojo. So again, huge pleasure to participate in this course again every year. I was asked to give a talk about my passion, which is management of patients with spine tumors. So Kojo, please keep me on time if I'm getting close or if I'm going over or whatever. So just quickly to make a point, even though it's a surgical talk, anytime you're dealing with patient with spine tumors, it's a multidisciplinary component, right? So it's the neurosurgeon, orthopedic surgeons, the medical oncologist, radiation oncologist, other surgical specialty, radiology. All of those other services are super critical for management of patient with spine tumors. So I want to emphasize that as you go to wherever it is that you go, don't approach it like you're approaching a cervical disc or a deformity case. These are cases where you really want to identify upfront who's your colleagues in the oncology world, because a lot of these cases are personalized treatment plans for each patient. And so you can't just approach a T12 burst fracture from a renal med the same way you approach a T12 burst fracture from trauma. So if you go and you're dealing with this, if you are interested in this particular topic, we actually have a fellowship that focused on spine oncology. It's always going to be cancer-centric. We have a dedicated spine tumor multidisciplinary weekly conference where we presented these cases. And you want to make sure that when you're dealing with these type of patients, you have the ability to accommodate elective, urgent, or emergent cases at any time. So I wanted to start with some cases to give you a feel a little bit about what are the things that I deal with. And I started with this case. This is a 23-year-old female. She comes in with 1 month history of back pain. On the day of presentation, she stood up from her desk, developed immediate onset of acute back pain, subjective weakness, could not get up. She brought to the emergency room where she has mild hip flexion weakness, a sensory level at T9, neurologically intact otherwise. Again, just mild, maybe pain-limited weakness, but about 4 out of 5 hip flexion. This is the MRI, and you can see on the MRI there is something going on. There's a mild fracture at T9. There is a severe spinal cord compression. There's no cancer diagnosis. This is a patient who just showed up in the ER, and as you guys are going to go into your practices, you're going to see this type of patient show up to the emergency room, and you have to know and figure out where you're going to go from here. So if I was there, which this year I could not make it to this conference, I would ask you guys to think about which one of you, looking at this MRI on a patient who has mild hip flexion weakness, would take this patient to the operating room to do a decompression. Which one of you will not take the patient to the operating room because there is no diagnosis? Maybe it's not cancer. We don't know what kind of cancer it is. There's a lot of unknown. Do you need to embolize it? Could it be a renal met? Could it be a vascular tumor that you need to embolize prior to take this patient emergently to surgery? So you just don't know. And when you don't know, you're already in fog. So is it somebody that with mild hip weakness? Should you still take the patient to surgery because the cord is pretty much smashed? There is some more imaging. This is with contrast. Again, the tumor is not just in the canal, it's surrounding the vertebral body, is encased in tumor. A little bit more imaging here. This patient ultimately was seen by the emergency room, coverage by neurosurgery. The neurosurgeon, there was a neurosurgeon in Florida, saw the patient in the emergency room, got a CAT scan which saw a lytic lesion at T9, mild pathologic fracture at T9. And at that point, he made a decision to take the patient to surgery, decompress the cord. He was not he did not feel that he would be willing to sit on somebody like that, admitting him to the hospital for a workup, considering the amount of cord compression. He did a laminectomy, no instrumentation. That's another question by itself. I'm not going to get into that. Here's what the MRI looked like after the laminectomy. And what you can see, indeed, there's less pressure on the spinal cord, but there's a lot of stuff left behind. I would say that maybe 10% of the tumor was removed. I mean, 90% of the tumor is still there. The patient got better. The hip flexion got better. The pain got better. The patient did better immediately right after the surgery. The intraoperative pathology came back as a lymphoma. And lymphoma, as some of you may know or not, is really a tumor that can respond extremely well with non-surgical intervention. It's in many ways what I call it a medical entity disease, not a surgical entity disease. So the question that I have to you guys, now that you see this case, is if you would have known that this is a lymphoma, would you have taken this patient to surgery? The big question here was that, again, you did not have a diagnosis, right? How much of a weakness were you willing to accept taking this patient to surgery or not taking this patient to surgery? So when I give these talks, clearly by not taking the patient to surgery, there's more work to be done. You need to admit them. You need to do vitals. You need to do frequent neurological exam. You need to order a biopsy. You need to order multiple myeloma panel, PSA panel, on and on and on. And when I give these talks, this is some of the comments that I got from guys like you. They said, hey, I listened to your talk. I tried it with one patient, which means not taking the patient to surgery. Let's figure out first what it is we're dealing with. But when you admit them and you don't operate on them, there's a lot of work that you need to do when it comes to figuring out what it is. It was more work. It was less fun. I got paid less. I am a surgeon. I can get into legal trouble by admitting this patient and not taking him to surgery. So from now on, I'm going to operate on them all. That's quotes that I've received from surgeons like you who said, I'm not going to sit on this. I'm just going to take him to surgery. I'm not going to admit them and wait for the biopsy and all those things. Now, all I would say is that out of all of these comments, there is no reference to the patient itself, right? If you look at actually the comments that I've got presenting this case. So let's take the same case now. Exactly the same case. You still don't know what it is, but it's not mild hip flexion weakness. It's severe weakness in the lower extremities. So same patient, severe cord compression with a 2 out of 5 strengths in both legs. Would at that point you take this patient to surgery, right? So how much of a neurological deficits are you willing to accept? How much of a neurological deficit are you not willing to accept? Is 2 out of 5 in both legs now making you more the opinion of taking this patient emergently to surgery or not? You still admit the patient and do the biopsy. So that is the common situation where when you don't have a diagnosis and a patient comes to the emergency room and they have some deficits, each one of you going to be in that situation, you're going to have to make a call. Am I taking the patient to surgery immediately? Am I going to wait to figure out what it is? Because ultimately, one of the things that I want to deliver through my talk here is that if there's one point that you all should take from my entire talk, is that it's always better to know what kind of tumor you operate on. Always. If you have the luxury of waiting, wait, get the diagnosis, find out what it is you're operating on. Here is another patient, 65-year-old cervical radiculopathy, neurologically intact, no myelopathic symptomatology, and he presents with this. This was sent to me read as a meningioma, intradural meningioma. There's a dural tail there for some of you some of the neurosurgeons in the audience. It looks, walks, talks like a meningioma. And it's not an easy tumor to take out because the cord is draped right over it. It read as a meningioma. The patient is neurologically intact. No deficits other than radiculopathy. How are you going to do this? Are you going to do surgery? You're not going to do surgery. The reason why I'm telling you this is because this patient ended up not operated on by me immediately. We went through a workup, which ultimately included some abnormality on the smear of his blood, had a bone marrow aspiration, and it turned out that he had what we call a chloroma, suspicious for a chloroma, which is some sort of a myeloid deposit, which we thought that's what it is. Now, we did not have a diagnosis, but these are super sensitive tumors to radiation. What clued us to it? The PET scan. The PET scan was super active, lighting up like a Christmas tree. Meningiomas don't do that. It appears to be something extremely active, led to further workup. There was multiple myeloblastic cells on the bone marrow aspiration. And the thought was that this is actually consistent with chloroma. Now, what it means is that these are, with one small dose of radiation, it goes away. Is it worth doing not really biopsying this lesion? And we decided to do that. And with a small dose of radiation, look at this lesion. It just melted away. So I'm showing you cases where you may be rushed to do something, but that's why that multidisciplinary aspect is very critical. Here is another patient, 51-year-old, 1 week of foot weakness and bowel bladder dysfunction with back pain and bilateral severe lower extremity leg pains. Here is the MRI. And the MRI shows a huge sacral lesion filling up the entire sacral canal, explaining the bowel bladder incontinence, explaining the weakness, explaining the pain. All of that is explained by this lesion. The S1 nerve roots are completely engulfed with this thing. No other lesions anywhere else. CT, abdomen, chest, pelvis, everything else is negative. You do not know what this is. Are you ready to do a sacral laminectomy to decompress the nerve roots? Because the patient presents with bowel bladder incontinence, presenting with weakness, presenting with pain, in order to decompress the roots. And I think that if you'll do it, the symptoms will get better because you can easily decompress those nerve roots. And that's what was done here. The patient was taken emergently to surgery that night by the spine surgeon on call. There's some more imaging here. And intralesionally, through the debulking and lumbar pelvic fixation, they found out that this was a chondrosarcoma, which is a primary bone tumor. And this was an intralesional resection for a patient with a primary bone tumor. It was the wrong surgery for this patient because now this tumor has spread everywhere and he needed an en-bloc resection for this. So when they found out it was chondrosarcoma, the patient ended up getting stereotactic radiosurgery. And guess what? Surgery was great. All of his symptoms resolved, his bowel bladder resolved, his weakness resolved, his pain got better. He was very happy for about a year. And then he came to my clinic showing me this. And he says, Dr. Mendel, I think one of my screws is backing up. I'm worried that the screw is backing up. That's what it looked like. When you look at the MRI, what do you see? You see a massive recurrence at the operative site, tumor in the canal, and that bump that you see there is actually chondrosarcoma getting ready to pop through the back of his skin. And the rod is broken. The patient did not ended up being fused. So beyond recurrence, beyond now you cannot cure this thing. In essence, you cannot do anything about this. The rod is broken. We ended up removing that bump, revise his construct. I did an en-bloc for the tumor that was kind of coming up into the soft tissues. There's nothing more you can do. It was really a surgery that was help initially, but then the long-term effect is that this is an uncurable disease. Here is another patient with a breast carcinoma, 2 vertebral bodies that are broken at the cervical-thoracic junction. This patient was seen by a surgeon. The patient just had some neck pain, and because it was breast cancer, somewhat radio-sensitive tumor, the patient ended up sent for radiation. And that's what it looks like after the radiation. The tumor shrunk, but the 2 vertebrae collapsed one on top of the other. And this was more of a mechanical instability that had progressed after the radiation. And so now you take maybe a straightforward case that you can deal with here where the neck is somewhat straight, and you're dealing up with something like this where now you got severe kyphosis, severe cord compression, and a much bigger problem. That's it. That's what I ended up doing on this. Just reconstructing the whole thing front back. Here is a patient with metastatic melanoma, and the patient had an lytic lesion in one of the vertebrae. Highly should consider this for a vertebrectomy. Instead, the patient ended up getting vertebroplasty into this vertebral body. Not only that, there was cement that was extruded into the canal during the cement injection. And you can see it right here with further collapse, cement in the canal. Patient ended up going through a corpectomy with the reconstruction in the front. And so I'm showing you all these cases just to give you a little taste about that it's not straightforward, right? A lot of these cases, you have to make very critical decisions. And I call it the triple W, the wrong operation on the wrong patient by the wrong surgeon, right? And I'm going to take it, and this would be extreme example. This is a 50-year-old who had unresected giant cell tumor who presented with this. And what you see here is pretty much an unoperable, huge giant cell tumor that involves the sciatic notch bilaterally, the femoral heads, the entire pelvis is all chewed up. There is no pelvis. The patient is presenting with massive amount of pain, minimal movement, already incontinent of bowel bladder. If there is any movement, it's mostly some sort of a reflex, but that's about it. How you get to that point, that's another story. That's the presentation. You can see, again, the entire pelvis is in essence a huge giant cell tumor that's filling up the entire pelvis, displacing the bladder, the rectum, and everything else. What do you do for this? The patient's in the hospital, a massive amount of pain medication. And, this is now become, from an unblock option, not really there's no good unblock options here to resect something like that. You can see the MRI right here. The canal is full. The pelvis is full of tumor.
So
and look at,
just we've got four minutes.
Yeah. Okay. So I'm going to end with this case. You can see the amount of pain medications that the patient is on. Massive amount of fentanyl boluses and ketamine infusion at 30 milligrams per hour. Surgical option? Well, the surgical option for pain would be what sometimes we go even further to do what we call a hemicorporectomy, right? None of you have seen it probably, but this is something that can be done on some of these big cases, and there's a lot of literature about how to do these. This is one of some of those intraoperative cases where you can see how many surgeons, it's not just neurosurgery, orthopedic, a lot of surgeons are involved with these kind of cases. There's flaps, and ultimately you perform this hemicorporectomy. But the key for our point of view was pain control for the patient. The patient did not want to go through a hemicorporectomy, but we wanted to try and get her off the ketamine infusion. And that's where the multidisciplinary becomes very valuable, because cordotomy is an option to help with the pain control, right? I know you guys have not seen it, but this is something that can be considered. And what we ended up doing is a procedure called cingulotomy, where we have very good functional program with pain management for patients with pain, and a cingulotomy is an amazing procedure, and you can see the actual procedure that was done here on this patient. And 2 weeks followed the cingulotomy, the patient was discharged on fentanyl 300 microgram patch to the skin. So I took you to 5-6 cases just to kind of give you a little bit of a taste. Clearly, it's very difficult to cover. I know I have 4 minutes, or add 4 minutes, but I kind of wanted to. I'm not going to keep going here for the sake of time, but I kind of wanted to give you a little bit of a feel for some of the cases that we deal with and some of the thought process that we go through. And again, without going into a lot of details about this, I would just stress that whenever you have the options of knowing what it is you're operating on, it's always beneficial, because then everything will fall into place as to prognosis, as to adjuvant options prior to surgery. Those kind of options definitely would exist. Otherwise, when you don't have that option, if you have to take somebody emergently to the operating room, you're going to have to make that call. If you have the luxury of wait, get the diagnosis via biopsy. If you don't have the luxury to wait, then you don't. If somebody comes in and they are weak in their legs, then you got to take him to decompress it. On the first case that I showed with the lymphoma, I would say with a 4 out of 5 strengths, I would write it out and not operate and get the diagnosis through a biopsy. On the patient who comes in with a 2 out of 5 strengths in the legs, very weak, even if it could be lymphoma, I think it's reasonable to take the patient to surgery. The patient is very weak, and the priority is to decompress the spinal cord. So by that, I'm going to end up right here, just for the sake of time.
Thanks so much, Udi. It's good to see you. Any questions for Dr. Mendel? Go ahead.
Hey, Dr. Mendel, this is Hussein from Toronto. I was just wondering if you have any tips or tools that you use in situations where the patient has neurologic deficits and you want to buy some time until the biopsy is back. Do you ever use steroids, or some people talk about like a focal decompression, staying outside of the pathologic tumor and just focusing on like the healthy bone? Do you use stuff like that?
So steroids, absolutely. If you feel if you have somebody with some mild deficits, steroids will be very helpful to give you some time. And that patient will be admitted to the floor with a frequent neurological exam. And as long as they are not getting worse, and sometimes they're getting better on the steroids, I would say absolutely use the steroids. Now, steroids have side effects, especially on patients with cancer. So if they are neurologically intact, I would not put them on steroids. But if there's any ounce of deficit or something going on and I'm deciding not to take them and I'm going to sit on it, then I would put them on steroids. I'm not a big fan of just kind of staying out of the tumor, or I'm not sure exactly what you were referring to. But if you go to surgery to do the surgery. To do a little bit and then close and then come back to do the big surgery, I'm not a big fan of that.
Okay, thank you very much. So, thanks. I appreciate it, Udi.
No problem.
So our next speaker is Dr. Luis Pimenta. The PTP is not prone lateral. Do we have Dr. Pimenta on?
Yeah, I'm here. Not with you, but maybe you can see me now. Video.
Do you want to turn your camera on?
Cannot start video. Oh. Can they hear you?
We can hear you.
Can you hear me?
Yes, we can hear you. Just want your camera on, if you can put that on.
Yeah, I have somebody smarter than me. Colton from the company is here to help me.
Great.
Not
There we go. That almost had it.
What's happening with EJ?
Yeah, it's not showing. It wasn't here. One moment. Sorry.
That's okay.
Take it back again.
Yeah. May we try exit and come back?
Sure.
Picture of you. I didn't know if you knew it or not.
I just got on to try to help Dr. Pimenta. Oh, am I seeing a picture of me? I can see.
You can try on phone.
Yeah. Doing the phone. Yeah, probably the phone. If the problem is
Should we?
We can start without video if that's okay.
Sure.
yeah. Do you mind if I start without video for now?
Yeah, that's perfect.
How
You
about
want to
your
just start sharing your slides so then you can just speak to them?
Yeah, exactly. So I will start with the slides and
Great.
probably I will not be able to show the technique, but you will have the cadaver lab for that.
And then
So,
there just want to, right in the middle, if you look at the top left, there's display settings. And if you click on the caret, one more over, up, one more over.
There's
display settings, and
Yep.
there's a little caret. Click on that, and then swap present. There you go. Perfect. That looks great.
okay. Yeah, these are my disclosures. My name is Luis Pimenta. I have the honor to have with me a good friend, Akbarnia. He is watching. He is one of the first surgeons in this country to have done lateral procedures, beside being the smartest deformity surgeon in the world. Anyway, a little bit of quick history. People ask me how I came with the idea. So I was a typical neurosurgeon, and I was invited to see endoscopic surgery to the spine. I never trust on that. I thought wouldn't be possible, but in the thoracic, I kind of understood that's possible. So I went, I stayed 6 months in Germany. When I came from Germany, I decided to do everything endoscopic in spine. I thought I could change all the spine world. What really happened is what you can see here, using endoscopes in the retroperitoneal space, until suddenly I used one tube, and I was able down in Brazil to do titanium cages in the disc. You see, when you do a rectangle cage, subsidence was 100%. Fusion was very good, but subsidence was terribly bad. So the first, we launched the XLIF studies around the lateral procedure very fast, has grown. The first study was in 2006 by a surgeon from UCSD that was the fellow, and he became the kind of inventor, the first to describe XLIF, but was just the fellow from Bill Taylor. So we know that lateral procedure works well. We have done this. In the beginning, it was very hard to convince people that lateral surgery would be good, especially talking about indirect compression, etc. But 6 years ago, thinking how we could change the lateral procedure, we thought, well, only 20% adopts lateral, and there is a reason, and most of the reason is lateral decubitus makes everything more difficult. You have not very good lordosis. You have no access in this position to posterior column, unless for percutaneous pedicle screws, 1 or 2 levels, but not for osteotomies, decompression, etc. So also the limitation of reduction of spondy was not as good as it is now. Anyway, and the need of flipping the patient, we think that probably was one of the factors that many surgeons were not interested in learning lateral. So in 2019, we launched what we call PTP. And why PTP is not only prone lateral. And that's what we will be showing here, is the amount of studies that we did to prove that prone is better procedure, more functional for the spine. One of the first studies is the study of the retroperitoneal space. You can see here the amount of space between the quadratus and the peritoneum is 3 times bigger than in the lateral position. So the gravity brings the bowel, the content very down and open space in the retroperitoneum much better. And this was done with guide wires. We did in cadaver labs before doing anything in prone and in lateral. And the amount of violation in lateral, violation of the bowel, violation of peritoneum and the kidney was huge in lateral, not so important in prone, unless in L2-3, the kidney itself. So, what is this? Play review. I clicked the wrong one.
Oh, you're good. Yeah.
Another study is the anatomy of the psoas muscle. What happens to the psoas muscle in lateral versus prone? Remember that in lateral procedure, we flex the legs. In the prone position, because we extend the legs, we traction the psoas muscle while we create lordosis in between the bone itself. So brings the psoas muscle more posterior and brings also the plexus more posterior, helping to make the procedure easier, especially in L4-5 where the plexus is more anterior. This is another study from HSS that shows the same thing. In the prone position, you can see that the femoral nerve is more posterior, again, repeating the same results. And next finding that we learn is that amount of lordosis created by the position is very different from lateral. So we studied this and we found that the lordosis in PTP was 3 times more than in lateral. So the position itself, which is something known by posterior surgeons for years, so it wouldn't be different. But this is another advantage. So because of that, we don't do ACRs anymore with this position. We more effective to do a posterior small osteotomy is taking the facets and gaining maybe 10 degrees more. So that is what is happening. We don't do ACRs. And some examples here, very collapsed adjacent level disease, position in the prone position, you see how much open the lordosis in the table, and then the surgeon was able to implant a cage, a lordotic cage, with a good gain of lordosis in that high level. Another point is, what about the spondy reduction, right? Most of the cases, they reduce in the table, the spongy, and in adjacent level is amazing that beside the reduction, it gains and opens the lordosis. You can see from pre-op to post-op, the amount of lordosis created just by the position. It's another reason that we don't do ACRs anymore. So you also can start from posterior, reduce from posterior, and then do your anterior fusion. So this is much more elegant and complete spine surgery. I keep saying that PTP is not only better lateral procedure, it's a better procedure. Is much more efficient and works in different ways for deformity, for revisions, etc. So what is really the specific things that PTP has and is different from prone lateral? So first, we learned that a 3-blade retractor was heavy because of the position in prone, we had to change this retractor. We made a retractor with 2 blades without having to change blades. So the retractor is more efficient, is much specific for this procedure. Second, we have a much better, this is the 2-blade retractor. You can see how it works. We actually target, especially when we go to 4-5, you see the movement there. We target more anterior in 4-5. We open first the anterior blade, place an anterior shim, and then we move backwards the posterior shim until the amount of clicks that correspond to the size of the cage we want to implant. So it's 6 clicks for 80-millimeter cage, 8 clicks for 22-millimeter cage. And this is, again, another specific solution that we found. We learned that with this position, the crest would be in front of L4-5 all the time. We didn't have the table to break the table to take the crest from 4-5 level. We constructed a specific position, transparent carbon fiber that does 25 degrees in the pelvis and in the thoracic. So that's another thing that's specific for the procedure that makes PTP different. You can see here studies showing how efficient the position is, stronger than the table rotation itself.
So Dr. Pimenta,
third important.
We're running a little short on time, maybe another 3 or 4 minutes.
Okay, that's fine. I'm finishing here. So the last one is the neuromonitoring that is specific for that, has SSEPs. So we monitor the health of the femoral nerve once the retractor is opening. So it's very different from before that we had only the EMG for finding where the nerve is. And with this, I probably can finish here. We have a bunch of studies. If somebody has questions about complications, we did several studies showing the amount of complication is not different from what we found in the studies from Juan with XLIF in the lateral position. Thank you very much. I think this is all. I had a video, but because of the sake of time, we will not present the video. Any questions?
Any questions for Dr. Pimenta? So I guess maybe one of the nice things also to mention is the tilting of the table, perhaps. Maybe you can comment on that, Dr. Pimenta?
Yeah, that's a very good point. So we can raise the table as much as, depending on the height of the surgeon, you can raise the table enough for the height of the surgeon. But there are many surgeons that do the procedure in a sitting position. But because you have the patient in prone, you will have the hand in front of your, in your procedure. And one thing that makes more comfortable, you turn the table just a little bit, and a little bit is exactly the measurement. There is no X amount of degrees that we turn, because when we turn the table, we follow the blades, and we will be always having the implantation, the discectomy, etc., guided by the position of the blades of the retractor.
Sounds good. Thank you so much. So we will continue with Dr. Jay Turner with the lab demonstration. Prone transpsoas is not the prone lateral.
All right. Well, thanks, Charlie. Appreciate the introduction, and it's a true pleasure to be here. I'm Jay Turner from the Barrow. I'm here with Rob Rudy, one of our sixth-year residents who's doing an enfolded fellowship this year, and we're just going to demonstrate the PTP technique. So we've got, just for orientation here, we've got the patient cadaver in a prone position. Cranial is to my left, caudal is to the right. We've placed some marks on the patient here. We're essentially working at the window between the iliac crest and the 12th rib. This is the disc space we've been working at. We are kind of navigating between a prior Coflex implant here, so we went a level up. We're at L2-3. We've started the approach here, made our skin incision, and did our retroperitoneal dissection here. Rob, if you want to come in. Essentially, the access, the key piece is ensuring safe access to the spine. Dr. Pimenta promotes a 2-incision technique. This is when we showed this through a single incision, which is also safe for the appropriately selected patient. The importance for me is being able to actually tactilely feel the psoas muscle. If I can't touch the psoas muscle, I'll want to have another finger in there. And for larger obese patients, that could be necessary. As long as I can reach the depth and have good tactile feel throughout the retroperitoneum, I'm comfortable with a single incision. So here we've made our skin incision. You bluntly dissect through the abdominal muscular layers so that we don't have any inadvertent thermal injury to the nerves that run through the abdominal musculature. And what I like to do is palpate posteriorly to feel that quadratus laborum. You come down in a transverse process, palpate the psoas muscle, and then we'll dilate right over your finger. And by kind of maintaining contact with the abdominal wall down to the psoas, we know all of our retroperitoneal contacts will be anterior and will be safe, especially with the single incision technique. That's important. So we'll have Rob come in here and do that. And in general, with this dissection, you want to feel all the usual landmarks. You want to feel your transverse process deep, psoas muscle. You want to feel the inner surface of your rib, inner surface, the kind of a smooth surface of your iliac crest, and that way you know you're in the right space there. And once you feel all that, once you have your peritoneum free, we can begin with dissecting and start the dilation across the psoas muscle. So Rob's going to come in and do that dissection across the psoas muscle. And so he went in, maintained that contact with the abdominal wall. Now he's positioning it over what's the L2-3 disc space here. Shot. And there's different philosophies of where to dilate through the psoas muscle. I generally try to target it right at the 30-yard line and open anteriorly, unless I end up encountering some of the muscle fibers of the nerve where I need to dock more anteriorly. So it looks like he's in a good position there. And he's going to dock that with the K-wire. And these dilators have integrated triggered EMG, so you can map out your lumbosacral plexus, particularly the motor fibers, which allow this to be done safely, especially as you go lower in the spine, like at the L4-5 level. And so we want to see lower threshold posteriorly, higher threshold ventrally. At L2-3, you're not always close enough to motor fibers to get a low signal, especially at L3-4 and L4-5. And here I like to stick my finger in and make sure as anything passes in, kind of protecting yourself ventrally, make sure nothing gets trapped. And we're dilating up, dilating through that muscle. After the third dilator, the retractor is inserted.
Have that
Just attaching the A-arms to the retractor here. Somebody hold this up for me. Thanks. Okay, once that's locked in, now we can optimize positioning of the retractor, and we're essentially going to be looking at the dilators. We're using to get, you can hold that, Rob, trying to get parallel to the floor. And if you have a good lateral x-ray, you're getting in line with your C-arm, and that should get you pretty close. You shot there? Shot? 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 It's getting pretty close. Shot? 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 There we go. We'll commit to it there just for sake of efficiency here. Okay, you can remove that. So now with our retractor locked to the table, we're going to remove those dilators. And the key with it, what's different with prone compared to lateral decubitus is you're essentially working 90 degrees to your normal working angle. So you're working 90 degrees to gravity, and everything likes to drop. And so everything has to be with that in mind as you're doing this procedure. So why don't you sit down, Rob, and you can look through there. And do we have lights? Mm-hmm. Can we swing this to an AP, please? Please. Okay, bring the lights about halfway down so they don't get obstructed. You can just do the one for now. Okay, do a shot there. Okay, can you rotate the bed a bit, please? So on the AP, you want to make sure your spinous process is midline. And we essentially, for the transpsoas approach, want to be working exactly orthogonal. And we rely heavily on good x-ray. Do a shot, opposite way. You go the other way. Shot. Yeah, a little bit more. A little bit more. Okay, that's great. And essentially during the procedure, you want to be checking to make sure this orientation is not changing. The spine can rotate, and that's going to change your direction. All right, so we now have a retractor in. K-wire is still in place, which I like to use kind of as my North Star in there to make sure the retractor is not moved, especially in the prone position where things can drop. So you able to see in there, Rob? Where's that? Okay, good. Perfect. So then we'll come back to a lateral and confirm placement of our retractor. And we have a shim. Mm-hmm. Go posterior there. Okay. Okay. So at this stage, we want to, with our dilators, we stimulated, ensuring the motor fibers are posterior. Here, before we insert anything in there like the shim, we want to make sure that there aren't any motor fibers in our field. So there's a ball tip stimulator that we like to use, which we will pretend we're using. We want to ensure there's nothing in our field that could be damaged with the placement of the shim. And if we're satisfied.
So Jay, can you comment on the relevance of those triangles of the retractor?
Yeah, absolutely. Yeah, so that helps to maintain your orientation of your retractor. So ensure you have perfect lateral X-ray that helps keep you oriented. And so these are ways of ensuring the right retractor placement. We moved the table a bit after we had the retractor down, so they're not perfectly in view here. We could fiddle around with it to make those perfect for this shot, but we're gonna just leave it where it is for now, but that's a good point. The retractor has kind of built-in checks to make sure you're where you wanna be. Okay, so assuming, can we come back to a AP, please? So assuming we didn't have any positive signals in our field, I also like to visually inspect, make sure you don't see anything that looks like a nerve, and you have a good, clear view of your lateral annulus. We'll take a shot there, an AP. No, yeah, once this comes out, you may be able to see a little bit better. Okay, we have a mallet. Good. AP? And can you pull back toward yourself? Shot. And pull back a touch more. Okay. So now that we have that posterior blade secured to the disc space, we can move the anterior blade. As Dr. Pimenta mentioned in his talk, we'll do 6 for an 18 or 8 for a 22. Yeah, we'll do 8. Okay. So 22 is the typical size I like to use. So at this point, we can pull that K-wire. There you go. And do you have like a Penfield 4 or some sort of dissector? Sit for a second, Rob. Just sit for a second. All right. And you have a couple different options with this retractor. You can also secure the anterior blade. Here we're just going to move on to our annulotomy. And so let me get the knife, please. Just want to leave a little cuff anterior to the posterior blade. And here the amount of retraction of the muscle and the lumbosacral plexus is really dependent on the efficiency, and so you want an efficient disc prep, and that doesn't mean your hands have to move quickly. It just means you need to have kind of consistent and efficient steps. So now we'll go to the cob. You want to make those annulotomy cuts nice and deep. And so after you make your annulotomy cuts, we'll mallet.
So Jay, what percent of your laterals are done in the prone position?
Yeah, it's become more and more as I become more comfortable with the prone position. I've been doing these in the prone position for 4 or 5 years, and I would say 80% of them I'm doing prone now. Let's get a shot, please. Okay, so you want to come back out a little bit. So, yeah. There you go. And so you just want to get this started in there, and then what I like to do is just kind of walk it down the end plate, shot. Yeah, we get a little bit of an end plate there. Shot. There you go. Why don't you walk that down now? Yeah, so essentially it's the same steps and the same comfort level as you get used to the difference in ergonomics. So I've become more and more comfortable with it and kind of slowly transitioned to do most of them this way.
And what I found is not wearing your loops is advantageous.
I agree, yeah. You're often having to tilt your head a bit. And once you get to that contralateral annulus, you want to mallet, so you want to support your hand there. Once you feel a little bit of loss of resistance, you know you're through, not quite yet. A little bit more, a little bit more. There you go, loss of resistance, give it a little twist. And now do the other. Now you're getting hung up on the shim. The slap hammer. Yeah, come off a little bit. Yeah, really protecting your end plates is critical for these procedures, especially if you're going to be relying on indirect decompression. So you really want to respect that interface between the disc and the bone. Yep, that's good. And this patient's got an enormous disc, usually a little bit more degenerated and collapsed than a real patient. We'll go right to the box cutter from this point. And same thing, make sure you leave a little bit of cuff. Downward pressure. As you're malleting here, the retractor does want to push out, so the assistant should be kind of pushing the retractor in. Get a shot there before you go. Shot. Shot. Let's take it to lateral annulus on the contralateral side. That's good. That's good. Slap hammer. Downward pressure on the retractor. Good. And we'll get a pituitary. You have a larger one? Thank you. And where I think people lose a lot of efficiency is with the pituitary, trying to pick every fiber out. If it's stuck to the end plate, this is not going to come out very easily. So just a few swipes with the pituitary. Yeah, I think without getting much disc out, we'll probably want to pull a little more out. You have a like a ring curette. Perfect. Just see if you can pull some disc out with that. And there's still a big plump disc in there. Your trial or your implant are going to really bounce. So we're going to pull some of that disc out. You can check your depth as well and get an AP shot when you're the other side. X-ray. Not good form to pull the contralateral plexus into your field. That looks good. All right. Pituitary. And often you can use your box cutter as your trial, especially for collapsed discs. You can get a sense even before you really start your procedure what the implant is going to be that you're going to be using. Here we'll go through the motions and use the trial here. X-ray. Good. And really push down with your supporting hand. Avoid the bounce. Shot. Yep. Shot. Yep. And most of these implants have a little bit of a taper at the nose. To really get full support across the apophyseal ring, you want to pass that taper. A little bit more. Good. Then come to a lateral. Okay, looks pretty good. Come back to an AP. All right, with a slap hammer. Good. And so at this point, we select our implant. I'm not sure what our options are back here. That's what we're going to use. Okay, so at this point, we're now going to prepare our end plate. So we don't want to go right from there. We haven't done any real end plate prep, so you can use a combination of curettes. I typically like this kind of ring curette stirrup, and then to get under the concavity of the inferior end plate of the level above, I'll get a up-angled curette. You have an up-angled version of that? Yeah, that's good. Often you have that concavity, and straight curette can be difficult to really clean all the cartilage off. And so now while they're kind of as part of the efficiency, while they're preparing the inner body, packing graft, because these are all peel packs, so that takes a moment to prepare the inner body. This is when we're cleaning inner body device, or the disc space there, so that we can place the inner body device. Okay, good. I typically stick a pituitary in there to clean anything else out. And then you want to make sure your graft is oriented properly, taller in the anterior aspect. Yep. Shot. Shot. Another shot. Okay, that's pretty good. And so you see that taper sticking out the contralateral side. I actually like that. I like the mid portion of the implant being a little bit past midline, so you get that full support. And push that gold tab, turn it counterclockwise, pull out, another AP, and a lateral.
Any questions for Dr. Turner?
I have a
Yeah, go ahead.
Yes. Is it practical to do it in obese patients?
It's a good question.
Can you repeat the question? Sorry.
What is your experience in doing the prone transpsoas in obese patients?
Yeah, challenging initially. I think I've become more comfortable with it. I think there are a couple different challenges, particularly prone. One is you often get retroperitoneal creep with that retractor open. And so there's ways to mitigate that where you can wrap the retractor in a thin layer of ioband, it kind of stretches and protects your corridor a bit, which is very helpful. The other is the depth and be able to actually feel what you need to feel. I think to do this procedure safely, you can't be doing it blindly. You're not just sticking things in blindly onto the psoas. I want to feel the psoas. I want to protect everything. And if they're too deep and you can't get your finger down to the psoas, you have to figure out a way to make that happen or change procedures. So Dr. Pimenta talks about a second incision more posteriorly, which is similar to what we do for the lateral decubitus approach, where you actually get a finger that's deeper, starting more posterior, that you can use kind of to palpate things more easily. So I think with experience and some modifications, you can still do the obese patients safely, but I agree that it's more challenging, especially starting out.
Perfect.
Get a lateral. Yeah, a little on the anterior side, but pretty good.
Looks nice. All right, well, thanks very much. I think we're catching up. We're running a little behind earlier, but we're almost back on schedule. Our next speaker is Dr. Pham, who's going to be discussing anterior psoas and lateral ALIF approaches. Dr. Pham, are you online?
Yes, I am. Oh, sorry, went far too quickly. All right, let me go back here. As I get this set up again, my name is Martin Pham. I'm a neurosurgeon at UC San Diego. Thanks to Dr. Sanser, Hamilton, Askuyan, and Chapman for the invitation to speak on this topic. And let me get started again right about here. There we go. All right, so my topic again is anterior to psoas and lateral ALIF. So as some of you may have seen, in honor of the Olympics here, we've all seen kind of this meme already, And I know naturally I'm following Dr. Pimenta and of course Dr. Turner already. And so if this is me doing lateral surgery, this is Dr. Pimenta doing lateral surgery, right? He helped to essentially invent the entire field. But that being said, hopefully after this talk, many of the residents and fellows in the audience will get a sense that this is very, very doable. Now, interbody fusion, you know, there's ALIF and then there's posterior and there's all these things in the middle. And I always like to say that, you know, if ALIF is like your St. Bernards and your posteriors are like your cute pugs, everything in the lateral are like your pit bulls and your bully breeds, right? They come across with a lot of names, transpsoas, anteropsoas, OLIF, XF, DLIF, PTP, laterals, and they may look a little bit different, but they're essentially the same, right? So that's why, you know, I feel a kinship to anyone who does XLIFs or PTPs because we approach it a little bit differently, but it's essentially kind of the same thing, right? And so what I'll be talking today is lateral access. So there's a lot of ways to get to the spine, right? As you can see here with all the LIF monikers. And today I'll be going over anterior to psoas, which is also known as OLIF, trademarked by Medtronic, and then lateral ALIF. So you take this diagram, turn it on its side, and this is what we'll be going over, right? So as an overview, why do I do it? What is it exactly? And then naturally, as a resident and fellows course, how do you do it? And that's what I'm going to be focusing on. So why do I do it? The surgical goals regarding what you do are always going to be the same, right? Decompress, stabilize, and realign. And really, the tools in my toolbox that I like the most, anterior to psoas and lateral ALIF, simply, they help me do this, the surgical goals, which essentially help people, they help me do it better. And, you know, for these applications, you're able to do lateral access from L1 to S1 with very large footprint cages. So what this means is that first, why I do it, I have consistent dependable access to L4-5 and L5-S1 essentially in every single patient. This also allows me to do single position surgery, lateral decubitus, minimally invasively. And this includes both 4-5 and 5-1, right? So I can do 5-1 in single position. And then this opens up the corridor and the possibilities of MIS deformity surgery. So for these three reasons, we know that for reason one, L4 to S1 is essentially your most important biomechanical level. Over and over, it's been shown that if you don't restore lordosis here, then people fail. In degen, they have adjacent segment, need revisions. And in deformity, I mean, this forms your strong foundation and corrects your fractional curve. So this is a very important level. Single position surgery, right? So here at UCSD, we do single position and it's near simultaneous. Because I stand in the front of the patient with ATP and lateral ALIF, I can have an assistant put in screws at the same time. So with this, it is very, very efficient for the degenerative surgeries that I do, whether at 4-5, 5-1, or higher. And then lastly, for my third reason, deformity surgery, right? Because I've access from L1 down to S1, then I can put in all these cages in the same stage setting and then bring them back and do their posterior minimally invasively, right? So ATP and lateral ALIF open up these possibilities. So that's why I do it. Now, what is it exactly? If these are the three reasons why I do it, let me show you what it is with a few case examples. So number 1, 2, and 3, for the first one, a 4-5 anterior to psoas. So here's a patient coming in, very standard degen patient, 4-5 degen spondy. You can also see, though, that they reduce on supine imaging, right? There's that vacuum disc phenomenon that tells you it's mobile. And here is the x-ray, right? So intraoperative x-ray, you see I'm anterior to the psoas, so the retractor blade is coming in slightly oblique than what you would expect from a direct lateral. You get great restoration of that disc space, reduction of the spondy. This is the incision. So my incisions are about like 4 centimeters, which is just over 2 inches. You can see I'm anterior to the crest. So no matter the crest, I'm doing every single 4-5 level that I do. I don't have to break the bed. These patients are on flat Jacksons. You get an image like this, right? So good reduction of that spondy just with the cage, right? So, you know, I'm not doing any posterior reduction here. Another case looks very similar, right? 4-5 spondy, except this is in a guy who's 6'1", 300 pounds, right? He's got a BMI of like 41, really terrible. I told him to lose weight for a year. He still couldn't do it. I'm a bleeding heart in my clinic, and so I get suckered into doing the surgery anyway. But here you can see same outcome. 4-5 spondy in a very big patient. This is not, I'm going to go back. This is going to be a very miserable day for an open case, an MIST lift, whatever you want to do. It's a pretty miserable case. But for an ATP, the belly falls out of the way, so still very doable. You see, get good radiographic correction of his spondy. So that's first reason for 4-5. Now 5-1. So for 5-1 lateral A-lift, another case, 5-1 disc height collapse. You got pars defects here. Here's the MRI, terrible disc herniation. And the thing is, for 5-1 lateral A-lift, when you take a look at this, I always like showing the fluoro shots. You see the bones move, right? You forget that really you're realigning the spine. And for lateral A-lift to be able to do this, you get in a large cage at 5-1, because your only other option really is a T-lift or a supine A-lift, but you get an incision like this. So because I do my own exposures are within my control. I don't get those large incisions that some vascular surgeons do if they're complex vascular surgeons like we have here. You get a 2 to 3 inch incision. Another case, right? 5-1 collapsed disc space. You get a terrible disc herniation here. So you want to do something where you put an interbody cage from the front. And again, you see this is the realignment that we're talking about at 5-1, arguably the most important biomechanical level, and you get that movement, right? So with the lateral A-lift, you get the beautiful movement and restoration of 5-1. And again, you get a large cage down at that bottom, small incision, right? This was in a lady who gets a, like a 6 to 7 centimeter incision. That's very cosmetic and a good outcome, right? Now, single position surgery, both at 4-5 and 5-1. Again, I'll show you something you've seen already, right? Very common, 4-5 spondy, MRI like this. Here's the robot plan. I know later on there's going to be cadaver demonstrations for robot assistant. This is my first fluoroscopy shot, right? So I navigate all of my inner bodies now at 4-5 and above. So this is my fluoroscopy shot. It's already been navigated in, excellent positioning of the cage, final x-ray, right? You get a 4-5 cage at this level. And you get, reduction of the spondy, restoration of height. You can see actually the improvement in the lordosis there as well, which I didn't measure here. But for single position surgery, this is the time. So procedure start, incision is at 8:49. Procedure end, drapes down 11:08. So for single position surgery at 4-5, I'm doing this in like a little over 2 hours. Now, this also applies to 5-1, right? So you have a 5-1 case here, pars defects causing that spondy. I have my robot plan. And again, you see here as a lateral A-lift, cage goes in, restores the height, posterior height, and lordosis. Here's the incision, right? So again, you have a 2.5 to 3 inch incision. You have a large cage in the front. You have correction of the spondy. You have restoration of lordosis, additional 11 degrees there. But for this case, that ordinarily would be a supine A-lift, flip perk screws, doing it in single position lateral, incision is 330, drapes down 542, right? So exceptionally efficient in being able to do something like this in single position. Last case I'll show for single position surgery. This can even apply to larger cases, right? So you have a gentleman like this who's got a very mild, scoliosis, really coming in due to pain on that main curve and the fractional curve. So here's the foraminal stenosis on his right side, foraminal stenosis on his left side of the fractional curve. So in restoring this, he gets a single position surgery. So here's 5-1, here's 4-5, and then here's 3-4 and 2-3. I'm working from the left side on the convexity, right? So he has several small incisions, and then he gets L2 to ilium in single position, right? So this construct is done in single position, right? So that certainly increases a lot of the efficiencies and not having to then flip or stage it. And he gets correction of the concavity of his main curve, correction of his fractional curve, and you can see here on CT, right, good straightening of the spine. But most importantly, as we know with interbody cages, it restores that indirectly. So you get the foraminal height restored on the main curve, and then the foraminal height restored on the fractional curve. Now, for the third reason why I do these, for MIS deformity, now you're opening up the case to being able to solve problems minimally invasively. So here's a 74-year-old coming in with a 52-degree curve. She's got a mild sagittal malalignment, right? Whatever parameters you want to look at, whether it's mismatch, PT, 4:1, LPA, TPA, you can see here a 52-degree curve as well. So the thought here is, well, can I just do this minimally invasively with cages and then correction? And based off of the predictive values that I get, the answer is yes. So I navigate in L1 to S1, right? So with this navigation, all the cages go in. Then I do 5-1 down at the bottom. And you can see 5-1 as a lateral A-lift, you get that restoration there, right? So that's really the beauty of being able to access 5-1 from the front, put in that bullet cage. She gets an incision here, 3 inches for 4 cages, 2.5 inches at 5-1. Robot plan, here's the percutaneous robot plan. And again, you see a really bloodless surgery in the placement of screws with robot assistance. That's my PGY2, right? Putting down a T10 to pelvis rod. But the thing is because everything lines up quite well, the rod goes in quite quickly. We do our reduction maneuvers to do a little bit more of derotation. And you get a case like this. She gets cages from L1 to S1 staged, second stage T10 to pelvis. This is circumferential, right? So it's minimally invasive circumferentially, and you get correction of all of her sagittal parameters, which we know helps a lot more in terms of patient outcome, and then restoration of her compensatory maneuvers. Last case on MIS deformity, 73-year-old, quite sick, cardiac stents, he's got ischemic change on his heart, aspirin, Plavix. So for a case like this, I think many people would be able to do this as an open case, right? You just open them up, do whatever you want, osteotomies, whatever cages you want, posterior, anterior, but he's not the healthiest guy. And so the question is, well, with my skill set in lateral access, can this be done minimally invasively with lateral cages? So in this case, he's positioned lateral decubitus, and he ends up getting ACRs at 3.4 and 4.5. So you see here the ACR at L4.5. Once the ALL is released, you see really restoration of that level at 4.5. I go up to 3.4, right? Second ACR cage at 3.4. And the reason why ATP is so intuitive for me is you can see the psoas muscle being reflected back. ALL is released in the front. So for ACRs, this is the retractor system. I'm looking at the ALL, right? So as opposed to how it was originally described, which was a really great way to do it, with the oblique approach, I can see it and then section it. And then, of course, the cage still goes in directly lateral to contralateral, which you can see here. ALL is being released. The psoas muscle is right there, right? So still preserved. And you get great restoration for this skill set. Again, I go down to 5-1 and I give him an A-lift cage. So as opposed to a disc angle that's slightly kyphotic, I break in with the trials, restore that, and you give him a more normal type of 5-1 area. 2-inch incisions kind of across all those levels. Here's the stage X-ray. He gets a minimally invasive plan from L1 down to S2, L1 being up in his prior fusion mass. And this becomes, essentially a circumferential case as well. So he gets a robust construct there, 4 rods. You see all the towers, everything is passed. But for someone who's on aspirin and Plavix and cardiac history, it's a bloodless surgery, right? So you get his AP, right? So he gets a robust construct for all his ACRs, 4 rods, 4 pelvic screws, and really nice realignment of his sagittal parameters, right? So again, no matter what you look at, whether it's mismatch PT, L4 to S1 is now 39 degrees, LPA, TP are all good, SVA is good, and again, release of his compensatory maneuver. So those are the examples. Now, for my last section, of course, is how do you do it? I'm very cognizant that this is a resident and fellows course, right? So, it's not just about telling you what it is, but how do you do this? So in this last section is the technique guide. Now, the SSF is excellent is because they record all these. So in case this is going too quickly, you can just, check on YouTube later. They'll have a beautiful video. You can go over it as slowly as you want. The first part is positioning. And in positioning, patient's positioning lateral, you can see here a few things. The blue arrows show where the taping job is, and then you'll see it's very low. The top leg is straight, my tape is at the trochanter, so I can see everything down to the inguinal line, especially if you're doing the lateral A-lift at the same time. For a single position surgery, the patient's positioned all the way to the edge of the bed. Here's another view that's closer up. Here's a top view. You can see the abdomen falls out of the way. So even in big people, the distance to the spine is actually quite short. I don't always use a sticky roll if they're big, because I want that abdomen to fall out of the way. If you're doing single position surgery, this is how my OR is set up. You have the robotic system, the workstation of the robotic system, and then the eyes of that. You have the C-arm fluoro for the registration. You have me standing in the front of the spine. All right, I have a Mayo stand. My assistant has their own Mayo. My tech has their bigger Mayo. And then here's the back table, right? So it's a very busy OR, right? It requires a really big OR. but you're using a lot of technology to essentially do simultaneous surgery. And this is what it looks like again, right? So I'm standing in the front, assistant sitting in the back, and you can see the reasons why I still like lateral decubitus surgery. This is a very comfortable position, right? I'm looking down, very comfortable for my neck. This is for 4-5, and here's for 5-1. I'm sitting for the lateral ALIF, and again, I'm looking straight in front of me, right? So it's a very comfortable seated position to do the lateral ALIF. Now for the anterior to psoas approach, you have the exposure, discectomy, and closure, right? So what that exposure looks like, you have the patient's body like this. I mark out the iliac crest and the rib, so I have my bearings. If you were to look through the skin, what you know is you have the external obliques, you have the internal obliques and the transversalis. Underneath all that, you have the retroperitoneal fat and the peritoneum. If you were to sweep that in front, just like any other surgery you do, then you have the psoas and the spine, right? As you get closer, there's the psoas muscle. You see a little bit of the disc space in front. And of course, we know hiding behind the psoas is going to be your lumbar plexus and your nerve roots. So what does this look like if you're doing the ATP approach? You have your markings. Say here's your incision for like a, this would be like a 2-3 or 3-4 level. You make your incision. The first thing you see is the external oblique. You dissect through that until you get through your internals and transversalis. You're in the retroperitoneal space. Sweep that all in front, right? You can put like a little patty or a retractor if you like. After that, just as Dr. Turner mentioned in his PTP, you should feel the psoas and the spine. Here, we're going slightly anterior to the psoas, so you're going right at the anterior border. You drop down your dilators, you dilate it open, you put in your retractor system, and then anterior border of the psoas, you can then sweep that back, and you have your disc space, right? So if you were to take a look at that, what that looks like in vivo in a live patient, again, this is marking out the L4-5 disc space. So, I use navigation or the robotic system to confirm that, to save on fluoroscopy. You can see my incision is in front of the crest, right? That's okay. That's what this technique was designed for. So the first thing you do once you make your incision, you go through all the abdominal muscles, sweep in front of the psoas. The arrow is to a retractor blade. Earlier on, if you're doing this, if you can't really see, you can set that so that you can visualize. I don't really do it anymore, but this was certainly helpful in the beginning as I'm starting to do this technique. So that's helpful. You dissect it down, feel the belly of the psoas, sweep everything in front, and then you put down your first dilators. In our case, this is navigated. You put down your retractors, dilators, and you set down your retractor. You see this dilator is at the front border of the psoas. It's coming in at an oblique angle, which is okay. Once you set that down, you put down the retractors, you open up, and you begin your dissection as so. Again, for the oblique approach, the reason why it's not as intuitive is you're coming in at an angle, right? Once you come in at that angle, you can sweep the psoas back to whatever you need. So you still put in, like I still put in 22 and 23 with cages, but they come in directly ceiling to floor once you can see that, right? So the psoas is reflected back. Once you have your exposure, you do your discectomy and graft. You'll notice how all of these retractor systems have an opening posterior to you. The idea is that even though you're coming obliquely, you do what's called the orthogonal maneuver. You push your tool straight ceiling to floor so that the cage still goes in as a direct lateral cage. So that's what that looks like. You put that cage down, orthogonal maneuver, and then you have an incision that looks like this, right? Here's a short video that just puts together all those screenshots all in one like 10-second video. You can see here navigated identification of the disc space. The dilators go down, right? Once the dilators go down, then the retractor system goes on top of that. You can see I'm in front of the iliac crest. I will do every single 4-5 level. I haven't done like a 4-5 TLIF in a very long time because I can do every 4-5 level since the crest doesn't matter. I work in front of the crest. Now, again, one of the things I used to think about is, well, if this is the psoas and they're talking about an anterior to psoas approach, like, am I here? That seems very far away from the spine and very close to the blood vessels, right? In reality, you're at the anterior border of the psoas. So if this is a 4-5 level, you can see the psoas is there. If you take a look at that diagram, this is the retractor system. So you don't have to be in front of the psoas. You can be at the anterior border of the psoas, and that's okay because you're still further away from the lumbar plexus than, say, a direct lateral. I don't stimulate the psoas. I don't do this under neuromonitoring because I'm that far away. I really have no worry about the lumbar plexus. You do your discectomy. You can see the retractor system as it comes on out. That is the anterior border of the psoas, and you leave it all very healthily intact. And then here's your incision. Keeping track of time, in my last few minutes, this is the lateral ALIF at 5-1, right? The first thing is patient selection. So there's a lot of things to look at in terms of patient selection, the same thing that the vascular surgeons look at. The most important thing is to make sure that the iliac veins are split. So you all take your boards, you all know that the left common iliac vein is what bleeds. So you take a look, this is what you're looking at, right? You have to make sure that this is split so that you can put in your cage. What you don't want is something that looks like this. On axial imaging, you would see the vein then in front of the spine, and that tells you that you have a low bifurcation. And that's what you want to avoid because then you can't put in your cage. Plus, you're in lateral position. This is a very disorienting orientation. So if you want to do lateral ALIFs, set yourself up. This is the MRI here, and you can see here, I'm going to put my laser pointer. This is the left common, right? You have a very wide split here for your cage, very wide split in another MRI, a very wide split here. What you don't want is something like this, right? The vein is coming right at the front of the spine. This is going to take a lot more dissection. I still did lateral ALIFs in these cases, but this was like my 20th or 25th case because it requires a lot more dissection. This is something where you can't even do, right? The bifurcation is too low at 5-1. So again, you can see the positioning is the same, right? You can see down here, I've exposed down to the inguinal line so that you can be sure that you have the surgical field that you need. Once everything is draped, these are the things that you mark. L5-S1 disc space, that's your sacral slope, perpendicular line. You want to make your incision somewhere in between there in front of the ASIS. You open up the skin, the first thing you see is the external oblique. We know that anatomically, right? You take a look in the lower left-hand corner. Once you pass through the abdominal wall, the first thing you see is retroperitoneal fat. When you see that fat, go upwards, find the psoas, right? This is why the lateral ALIF approach is so intuitive for the anterior to psoas, right? Because we see the psoas all the time. Once you find that psoas, the next thing that's on the landmark is left common iliac artery, left common iliac vein. It's exactly like an ACDF. When you do your ACDFs, the first thing you feel is the carotid, and then you go medial to the carotid. This is what it looks like. Now, naturally, for any spine surgeon, seeing something pulsating in your wound is not necessarily something that we look forward to or kind of plan our day around. But this is what it looks like. And again, similar to the carotid, we go by the carotid every single day for an ACDF. For lateral ALIF, it's the same. This helps to keep you on track. Because if you know that this is what you're seeing, when you go medial to that, you find the disc space. This is what it looks like in your field. There's the anterior 5-1 disc space, all exposed, right? A really nice exposure from the front. You find your S1 promontory, it's a 6-centimeter incision. You do your discectomy, put in your cage, remove the retractors, close your fascia, and you have your final incision that's what, like 3 inches. Okay. Yes, sorry, I heard something, but in conclusion.
Yeah, I think we've lost the, we're not seeing you right now or your slides, but that's okay. I think we're pretty much close to the conclusion, right, Martin?
Yeah, we're right at the conclusion here. So, for the procedural applications, there are, these are the benefits on kind of why I do them, but there are downsides, right? Naturally, there's a learning curve. There's lateral positioning, which is not as intuitive as you're prone. And then there's the complication profile, right? You have to deal with all the complications in lateral or anterior surgery that you wouldn't if you're just doing posterior surgery. So there are pros and cons to all approaches. I'd challenge anyone to say that there's like a perfect, inner body approach. And so in this way, right, you're all residents and fellows in there. You were born, you're a toddler, you're a teenager, now you're a resident fellow, and you have the opportunity to pick what you want to do. I know how to do all of these, right? I know how to do direct laterals for lateral corpectomies and PTP and TLIF, but you can choose to spend your time learning one thing that you really want to be good at. Ultimately, the goals are the same, right? So whether whatever inner body you want to do, it's going to be your outcomes and how you accomplish them. So in this case, the world's your oyster, and you can do whatever inner body fusion you want. This is, of course, how I do mine, anterior to psoas and lateral ALIF. So thank you for that whirlwind through this.
All right, great. some nice cases. We're a little bit behind schedule, but maybe one question if somebody has one question. Okay, go ahead. Yeah.
I'm Felicia. I'm a 3.5 at Brown Neurosurgery. I was curious if, I assume you're no longer limited now by the position of the synthesis axis 5.1.
Sorry, can you say it again? One second, I'll wait. Let me start from a new, here, get your microphone.
Thank you. I'm Felicia. I'm a PGY5 at Brown Neurosurgery. I was curious, I presume you are now no longer limited by the pubic symphysis for your 5.1 access, and if therefore you're able to address high-grade spondies at 5.1 using the lateral technique.
Yeah, so for 5.1 in the lateral technique, the pubic symphysis, sacral slope, and pelvic incidence will still apply. So that means that, for a pelvic incidence of 65 to 70, it's still going to be challenging. You'll just have to position the patient, as you saw in some of the positioning diagrams, you just have to be able to free this space right here, right? Because if you're doing a PI, and I've done PIs of up to 85, which is very, very high, I'm way down in the groin, right? So I mark out their inguinal line, and my incision is very close to the abdomen ends there, but you still will need special instruments. So it's still going to be difficult. It's really no different than if you do it supine, except if you do it supine, it's your vascular surgeon who will struggle. If you do this, it'll be you who struggles. So kind of your choice of poison. But it doesn't change, right? So if you have a PI of 65 to 70 or higher, you really have to plan your exposure. And what ends up happening is this tape ends up being even lower so that I can see upwards as best I can.
Great, thank you so much.
Great. Okay, our next speaker is Dr. Pat Johnson from Cedars. Going to do single position surgery with navigation of the inner body with the robot. Thanks, Martin.
All right, thanks so much.
Oh, sorry.
There we go. Y'all hear me?
Yes.
Okay, we live in the lecture room?
Yep, we're all good.
Okay, well, I'd like to bring up both our screens here. It's just like the operating room, hurry up and wait, so I think we're ready to go. I know we're a little bit behind, so I'm going to speed us up, I think, or at least I hope I am. Mark Kramer, new fellow. Mark, get in the camera here. University of Wisconsin-Madison, just finished your neurosurgery residency. Welcome. He knows a whole bunch of my old fellows that are in Wisconsin. That's great. That's great. Full circle. Enjoy it. So we're going to do a single position lateral because actually way back when, about 10 or 15 years ago, we started doing people in a lateral position and we would fire screws in a lateral position. Now, the only real disadvantage of that operation, because once you get comfortable putting screws in from a lateral position, it's really easy. You can't do a decompression easily from the backside in a lateral position, but I mean, I've done surgery in a lateral position in patients that had to have it done in a lateral position. So it can be done, but usually not. So we're going to do and in keeping with my navigation kind of penchant for everything, and I don't have this in my lecture that you'll hear tomorrow, but we're going to do some navigated lateral stuff, which is totally new concept, probably to most people. So this patient's in a lateral position. I've already picked out an incision place that I want. Everything's been positioned here. We actually have some straps, bungee straps that look like they should be in the back of my pickup truck that are holding this cadaver in a perfect position. So we've already got trajectories here. I can go and show you, this is all the way at L23. We're doing this on the convexity side, which is, I think, more for the ease of the demonstration purposes here, but otherwise I usually do these from the concavity side, usually, because you can get to all of these levels. Let me, I don't know why we're not showing everything here. Where's our tech? Let's put this in the middle of the screen here. There we go. Okay, so we'll go back here, but we can see that this patient has a degenerative scoliosis. This would actually be a great case to do some laterals. I would probably do them from the other side, as I said, and these have already been kind of pre-trajectoried for not only the screws, but for the lateral implants. And these lateral implants, they're pretty cool stuff. Obviously, you heard world-renowned guy, Luis Pimenta, talk here just recently. And this whole technology kind of came from his brilliance. I had the opportunity to go visit him back in the late 90s in Brazil, which was a cool experience. So anyway, without going too far ahead, we're going to open the patient up. Mark is here holding the patient open, and I don't need a Bowie here, fortunately. And just kind of how quick I like to do them is that put a retractor in. Are we seeing any of this from? Okay, I guess we are. Okay. We are. It's all muscle splitting. Doesn't bleed in this patient. Get into the retroperitoneum pretty quickly. This patient cadaver is a fairly small specimen, which is always nice. We're going to use our navigation here. A little bit anterior. Now that we have all this navigation stuff already in place, we can simply go right to where we need to go. Going a little bit more caudal. There's the disc. Then come anterior a little bit. How we doing, Mark? We need to put a K-wire in there. So truth be known, I do a lot of these. I think you have your hand in the way there. I do a lot of these. Hang on just a second. Let me get this thing perfect. This is where I kind of slow down, quiet a little bit, a little quiet time, and just say, everything needs to be perfect here. Because if you're going straight trans-psoas, you want to be dead center, 50-yard line, front to back, in the disc space, and that's a good trajectory. Okay, tap that in a little bit. Keep going. Keep going. So that's in the disc space. There's no resistance, right? Okay, we did our neuromonitoring a long time ago. You missed that part of the story. Okay, but we're going to leave this in. Not following you. Okay, thank you. All right, and we're going to leave that. Gotcha. Okay, so we're in the disc space, and we're actually ready to do an operation here pretty quick. I wish I could do it that fast in the operating room. Okay, so our measurement, we've already done pre-measurement of this also, of the patient in a lateral position, and we chose 80, but you know what? We probably are better off. We'll do an 80. That's right. Let's do it. Let's do it. Take our retractor out. Mark, hold on to that. Okay, so we always hold on to everything so nothing jumps out. We don't have multiple dilators. This retractor actually starts with, I don't know how big this dilator is, but it certainly is a very ergonomically favorable device here. And since we had the patient in a perfectly true lateral position, okay. All right, we're going to open from here, close our retractor. And that's one of the things that I skipped over because the patient was positioned, as I said, is that the patient has to be in at least for my brain, the way it works, I work in right angles. Everything's got to be at a right angle when I do these operations. And starting with each disc we can change as we go, but putting your retractor in, everything's here basically at right angles to space, the floor, the ceiling, the walls, everything. So we should be in good position here, and we can open from there. We have our open. Okay, and that opens. Are we seeing all this? Okay, yeah, we have a great camera. We're opening north and south. We have a shim we're going to put in. We should be. Now, since we were so meticulous, but I went through it very, very quickly, you're going to make me point again with this? This is looking right down. Yeah. So we were so meticulous about getting this thing perfectly positioned is that everything depends on that K-wire having been put in the exact position. Okay? We're good there? And we're just going to recheck here and see where we're lining up. Are we happy with that? Yeah, we are. We are. I'm happy. There's a little bit of adjustment. You can see me move that. You can see it move on the screen, on the computer screen. That's dead center down the middle. Now, if we want to place this thing a little bit anteriorly for reasons, I don't like to position things too much after having all this set up and ready, unless I know I'm going to change something position for some reason. And it usually has to do with neuromonitoring. That's the main reason why. Okay, so we're going to take this off. We're going to put our shim in. Whacker. Keep going. How deep? Okay. Here we go. Okay, so that should lock us in position to do the operation, okay? With lights. I like to leave the K-wire in until I'm opening the annulus. Very superstitious about things moving. You wouldn't have a coker, would you? If you don't have a coker, I'll use this just to put something on the K-wire. Putting lights in, we're going to see down there. I don't know what I need that for. Okay. I see some muscle, which we can retract back a little bit. This is a wonderful operation. It doesn't bleed. Okay, I see a nice big bulging annulus. The K-wire here is almost dead center in the middle. That's where I want it to be when I look down inside. I'm going to open up the lower blade a little bit. Mark, you want to put a hole in the annulus? You want to cut it? You get to do the honors. You ready? Can you see in there okay? Pressing you into service here. You ready?
Yep.
So we can take this out. We're going to make a big box annulus. That's what I say. With each one of these instruments, like a knife, don't put it down too soon. Cut, 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 make the box as big as you want it. I don't use many instruments here. How do you rotate this thing around? Ah, okay. Need a pituitary. So as we can see, the navigated portion of this operation allows us to skip a lot of steps that we do with fluoro, and I've done for years with fluoro. Here's my favorite tool. I need this thing rotated. Okay, can we see this? Big cob, okay? Don't ever use a small cob, use a big one, because where we're gonna put this thing in is all the way across the other side. That's my hammer. We're navigating, where are we? And that's usually how much force it takes. I don't really need a hammer. That's out the other side. We're just loosening it up. We're going to take disc out, then we're going to scrape the end plates. Go ahead, Mark. Have a bigger pituitary? We need a bigger pituitary. I think you have one on your other table. There you go. Okay, so once you have yourself in position, the navigation part that was at the beginning and then at the end is when you use it again. Is that the biggest, or you have one in between? Okay. Now, one of the questions that should arise for everybody is, where are you when it comes to cleaning out the other side, right? We're off on our nav a little bit here. That's okay, we're gonna work with it because we're certainly in the disc space. But being across the other side, going out the other side, that's not the right tool to use, but that pops out the other side. Give me the periosteal again. This is scraping your end plates, which I'm very big on scraping the cartilage with this instrument. I have different ones that I use in my shop that have been custom bent by me with a French bender, so I can work around the corner of the concavity of the end plate. And we're off a little bit here in our navigation, if that's all right. Here's the other end plate, which I can feel scraping the cartilaginous end plate.
So, Pat, do you do your screws first and then the cage?
I do the lateral first, because if I'm doing a spondylo, I want it to be reduced by putting the lateral implant in. And that's probably the most common situation and scenario for me in my practice, is that I do laterals for patients with a significant spondylo. I mean, I'm not a big T-lift guy. I do a lot of laterals. If I can do them with perk screws from the back, or if they need very little decompression, I do them from the backside, but I do the screws afterward.
Do you respin after you put in your cage?
Yes. Yes, I will. It really depends on each individual case. I mean, if you have a big reduction, you have a big spondylo, you reduce it, because when this technology, as we know, will reduce spondylos tremendously, right? And so, and here's your implant template. We already measured this. As I said, we're off on our coronal a little bit here. I would probably do a respin right here, just because if we're off like that, I'm sure it's going to be fine, but I would respin it. It's not a big deal to do that. And our final implant, do we have one? There we go. I can feel bone on the end plates. It's very flat end plates, so I don't have to have my custom bent periosteals. I have 3 different periosteals, a straight, a little curve, and a big curve that I can do the concavity each side. Where are we here? There you go. That way. we had an X-ray here, we could actually do it. Okay, and this is an expandable. We don't have to go through all those steps. So there you go. It's a navigated procedure. I mean, I would respin just because when I found out that I was phase shifted off like that a little bit, I don't accept that. I'll just respin or I'll reshoot. So we're good. You don't need to. We're good. Okay, these are expandable cages. After you're done here, we go put screws in the back, but we don't need to put screws in the back here. I mean, the exercise here was the navigated lateral. Are we good? Do we have any questions?
Yeah, and any questions for Dr. Johnson?
Beautiful.
Great, thank you. Thank you so much. Yeah, it's definitely a powerful tool to be able to access the disc space. And the amount of fluoroscopy reduction with navigation, I think, is probably quite useful. So I think on the schedule we have Dr. Askuyan for advanced lateral approaches to the spine, but I think he might be occupied right now, so I'll go ahead and do my talk on cervical motion preservation. To replace or not to replace, that is the question. So I wanted to discuss motion preservation because I feel we often focus a lot on fusions, and preservation of motion should always be the first line of reasoning when feasible in any patient that we treat, something that we often might forget. These are my disclosures. So I want to thank Josh Alexa. He's my PGY7 in the audience right now. Some of these slides are his. He actually gave a talk on motion preservation last year. It was an excellent talk, and some of these slides are quite relevant to this topic. So we start out with our normal anatomy of the cervical spine. It's a very dynamic part of our anatomy, very responsible for our day-to-day life and activities. And so you can see when you sacrifice some of these motion segments, it has a severe impact on the rest of our body. So you can see the extent to which we have motion. You just look at that lateral radiograph and see how much extension is feasible. This is a table showing the normal ranges of motion of the cervical spine. So it's a substantial part of our body that's when we start fusing and sacrificing these motion segments, it really creates a stress on everything else. So the anterior approach for the cervical spine has been well established and pioneered by Cloward and Robinson, Smith and Robinson. In 1958, there were two papers that were published, and Ralph Cloward was in the Journal of Neurosurgery, and Smith and Robinson was the Journal of Bone and Joint Surgery, and both in the same year discussing anterior cervical discectomies and fusions. So you can see the anterior approach is well established. So while ACDF is the gold standard to treat anterior disc pathology, arthroplasty has become increasingly popular, and we're going to go through various different pieces of the literature. But first, we'll look historically where arthroplasty first came into our thought process. The Fernstrom ball, described in 1966, was an early attempt at trying to maintain motion. And, we can see we still maintain some of that concept, the ball and the ability to rotate and flex and extend that geometry still is maintained in our arthroplasty options today. You can see right here, that's essentially a ball and socket joint for a lot of these devices. So not too dissimilar from the Furstrom ball. So not everyone is a candidate for arthroplasty. You can really only consider arthroplasty for patients with 1 or 2 level disease, patients that still have maintenance of motion, patients who have relatively preserved disc heights, patients who have relatively normal sagittal alignment, and so arthroplasty candidates traditionally are patients who have less disease than fusion candidates. In the setting of tumor, trauma, instability, infection, kyphosis, deformity, severe ankylosis, or severe disease of the facet joints, fusion becomes more of the choice. However, with time, there may be some opportunities to push the limits of arthroplasty, and I'll go through a couple cases to describe that. So with arthroplasty, it's important to have very good fluoroscopy. You want to be able to see your anatomy very well, because the positioning of the implant becomes more relevant than a fusion, because you really want to make sure things are centered and things that the axis of rotation is appropriate for the level that you're treating. Going through some of the clinical trial results comparing arthroplasty to fusion, you can appreciate that arthroplasty often shows favorable neck disability indices and favorable reoperation rates. So these are various clinical trials with 2-level and 1-level results. This one happens to be the MOBC. This is a 48-month follow-up. Reoperation rate was 4% versus 15%, and higher patient outcome scores. Another study, 5-year follow-up, similar reoperation rates, 4% in the arthroplasty group versus 16%. It's again, further evidence to support that arthroplasty had a reduced rate of secondary surgeries when compared to fusion within a certain time period. This is 10-year data published in 2019. The reoperation rate was 4.7% in the arthroplasty group versus 17% in the ACDF group. So there have been quite a few studies that demonstrate this difference between fusion and arthroplasty. And these studies happen to be industry-funded studies, so that's often a critique of the arthroplasty literature. But it does make intuitive sense that maintenance of motion, when feasible, can have a positive impact on the adjacent segments, and that's exactly what the papers show. Looking at it from a different perspective in terms of cost utility, there is a incremental cost effectiveness ratio that shows that arthroplasty is more cost effective than fusion. This primarily has to do with the reduced reoperation rate. Another evaluation of cost effectiveness from a retrospective analysis of the cost of the Blue Health database, just showing that there's a reduced cost in arthroplasty when compared to ACDF. Even in the case of 2-level arthroplasties, where arthroplasties are more costly from an implant perspective when compared to ACDF, it still has a acceptable and reduced cost effectiveness status. So
So the incremental cost effectiveness ratio is still palatable, even in the setting of 2-level arthroplasty. This is a JAMA study. When looking at the workers' comp population, this is evidence to suggest that the return to work is different in the arthroplasty group, and the neck disability index is improved in the arthroplasty group. So there was a trend towards, even in this difficult to treat population, of enhanced results in arthroplasty. So going through a couple cases here, this is a patient with both C5 and C6 radiculopathies. As you can see, there's maintenance of motion at 4-5. However, 5-6 is somewhat ankylosed. So in some settings, this might be a patient that would be a 2-level ACDF, and certainly there's nothing wrong with that. But with her young age, I thought she could potentially benefit from arthroplasty. She ended up getting a 2-level arthroplasty, and this is, I actually have 10-year follow-up on her. She still continues to have normal motion at those levels. She developed an adjacent segment problem about 8 years later, which required a fusion. Since once you have 2 levels of arthroplasty, you can't do a 3rd level. The insurance often won't cover a 3rd level. That's her. Despite the fact that the 5-6 disc space was more ankylosed, I was still able to reintroduce motion there, and she had some resolution of symptoms. This is a 31-year-old male with C6 radiculopathy and some element of hyperreflexia. You can see a little bit of cord signal within the cord, but again, he's a 31-year-old. So I toyed and thought arthroplasty versus ACDF, and given the youth, I erred on the side of arthroplasty, even though this may be controversial. He ended up having this implant. This is the ProDisc. This implant has the greatest amount of stability in comparison to all of the arthroplasties. There's the least amount of lateral and forward translation. So I thought in someone who has myelopathy, if I'm going to do an arthroplasty, it should be the most stable implant. And so that's why I chose this for this gentleman. And he's about 12 years out. He's doing well, never needed any adjacent segment procedures. This is a gentleman, a 46-year-old, with pretty severely collapsed disc spaces, and but very much desirous of motion preservation. And so I had a tough time with this one. And it was the patient that kind of swayed me into the arthroplasty direction, but this classically would be a fusion patient. He did have a significant amount of arthritic disease. The facet joints were not terrible, but very severe disc space collapse, almost complete ankylosis of the disc spaces there. So this was kind of different in terms of this patient being an arthroplasty candidate, but we still tried it and managed to get implants into him, and he has the ability to flex and extend. We improved his range of motion by doing the arthroplasty and had resolution of his radicular symptoms. However, he did require an additional posterior foraminotomy because around 6 months post-op, he ended up redeveloping his radiculopathy. I think the original distraction from the arthroplasty was lost with a slight amount of subsidence. And that slight loss of the distraction resulted in redevelopment of the foraminal stenosis.
After foraminotomies, he's back to square one and is quite happy and has maintenance of his motion. So arthroplasty is not without its set of complications. You can have instability that can develop. I think instability often develops as a result of over-distraction. You can have heterotopic bone formation causing cord compression. You can have spontaneous fusion. You can have subsidence if you don't maintain the intactness of the end plates during the preparation of the interbody space. So arthroplasty is definitely is not without complications. So other potential options in terms of the world of motion preservation. This is not common, but the anterior foraminotomy is described in the literature. I think the main risk with the anterior foraminotomy is the proximity to the vertebral artery and the risk of injury. This is not a common procedure and should really be carefully explored in the hands of experienced surgeons. It's possible perhaps with the endoscope, maybe this could get revisited, but I think it should be reserved for the hands of people with great experience. There's a high reoperation rate in this series, so I don't think it's necessarily the way to go. So we must not forget about the gold standard from the past, a foraminotomy. Foraminotomies, a very powerful procedure, especially for patients with severe disc space collapse, where they have not so much neck pain, but mostly radicular pain. We should not forget about the fact that a foraminotomy can help these patients quite substantially. In addition, you can also gain access to lateral disc herniations through this approach. And so Dr. Jain had a large series of these, and the success rate was very high. Just going through the procedure, you make a small window overlying the lamina and the medial aspect of the facet joint. Often these patients who, if they have unilateral disease, I favor foraminotomy, where they have, or unilateral symptoms. Sometimes you can trim a part of the pedicle in order to improve the space for the foramen. So that's not an unusual thing to do in the setting of a foraminotomy. The results can be very, very substantial and elegant without the sacrifice of motion. So this is a small video here, a short video just showing the technique, drilling through the medial facet as well as the lamina. You can appreciate getting in, exposing the thecal sac, getting through the ligamentum flavum. And as soon as you get through the ligamentum flavum, you start to see the epidural venous plexus pop out at you. The goal is to really control that epidural venous plexus early before it starts bleeding a lot. As you can see, there is a good amount of bleeding, but you really want to get through that epidural venous plexus in order to adequately decompress that nerve root. You can appreciate the nerve root is basically at 12 o'clock right there. I'm breaking through the epidural venous plexus with this nerve hook and just coagulating as needed. And ultimately, the goal is to be able to put a Woodson into the foramen to verify satisfactory patency of that foramen. And that's basically a foraminotomy. It can be a very quick and efficient procedure for a patient with unilateral radiculopathy, but with enough degenerative changes that you can't do an arthroplasty. So this one is a video that looks at a patient who had a foraminotomy for a posterior disc herniation. So you can see you can manage to get a very substantial disc fragment out. You see how large that is. This was a case that my partner, Dr. Crandall, did with Josh not too long ago. I think this is about a month ago. And Ken did me the favor and took a video of the microscope while Josh did the surgery. So bottom line is motion preservation should always be something that we should think about. The final couple slides are going to be on laminoplasty for patients with multi-level disease with some degree of myelopathy. Laminoplasty is a motion-preserving surgery that can often treat myelopathy if the patient has preservation of lordosis and has minimal neck pain and mostly myelopathy. Laminoplasty is an option. I've even found patients who have some degree of radiculopathy may still benefit from laminoplasty if they have both radiculopathy and myelopathy. Even if you don't do foraminotomies, often the radiculopathy goes away. I look at laminoplasty as a tool to address multi-level disease. And let's say even if they have one area of persistent radiculopathy afterwards, you can then do an ACDF on that one level, but you've preserved motion at multiple levels, and you save that patient from getting like a 4-level ACDF to maybe a 1-level ACDF with a posterior laminoplasty. So that's how I look at laminoplasty. It's an opportunity to save that patient from getting a 4-level ACDF, which ultimately will result in a C2 to T2. So there are a couple of different ways to do laminoplasties, but I'm running out of time here. But bottom line is, I think there are a variety of ways. There are a variety of ways to preserve motion, and you can be creative about it and potentially save the patients from having a multitude of fusion surgeries, down the road in their life. Any questions? Yeah, go ahead.
Dave McCarthy from PGY5 at UPMC. 2 questions. Do you ever consider doing an adjacent level, someone who had a prior ACDF with an arthroplasty?
Yeah, I've certainly done that before. Arthroplasty adjacent to a fusion. My preference is to do the arthroplasty above the fusion and not below, because I feel like if the fusion is above it, it may overburden the arthroplasty. That's just my overall interpretation. I've done that before where the patient has had a fusion and I've done an arthroplasty above it. But I would choose the most stable version of the arthroplasty, which in my opinion is the ProDisc.
And then the second question is, do you have an experience with like MIS laminectomy in the cervical spine at all?
I'm sorry, say that again.
Have you done any MIS laminectomies in the cervical spine?
Yes. Yeah, through a tube. Yeah, just like foraminotomies can be done through a tube without a doubt. Definitely.
Let me ask a question. Who here in their programs, by show of hands, routinely does ADRs in the cervical spine? Just show of hands, routinely. Who has not done an ADR in the cervical spine so far? Couple, wow. Who's done lumbar ADRs, just out of curiosity? Anybody? 1 or 2, wow. Yes, it's actually, so you're a leader in neurosurgery. What's going on? I mean, this is, I honestly, and I'm gonna ask a follow-up question, superior surgery, all things being equal to fusion. I stay with my concept of true minimally invasive surgery is not the amount of skin or soft tissue dissection, it's motion preservation if feasible, mechanically, physiologically, neurologically. So who, if you had a 5-6 disc herniation, there's no bias here, would prefer an ACDF over a disc replacement? Who would have a fusion? Anybody? Who'd go for a disc replacement? Show of hands in reverse, right? It's not even a question anymore. Where's this mismatch coming from? Is it financial incentive? Because we do get paid a heck of a lot more. Industry gets paid royally more for fusion. And why don't we do more? Let me ask the same question for laminoplasties. Who's done routinely laminoplasties? It's actually, that makes me happy. easily half. Again, an example for a vastly under-reimbursed surgery. Is that the problem, or is it too technically difficult?
Yeah, I think it's a combination of things, but like everything in life, it's multifactorial. You know, certainly one consideration is the finances, but I think the second consideration is the speed, you know, of the surgery. And arthroplasty is a more demanding procedure. It requires very good precision to be perfectly midline, very good fluoroscopy. You're making these keel cuts very often. There are a few extra steps there. There's a risk of residual pain in the setting of radiculopathy for patients who have foraminal disease. I think it's just very common to not be a perfect candidate for arthroplasty and therefore just be thrown into the realm of fusion just because it's just, you just don't have to think about it as much. Fusion is more forgiving. You can be off center and still have a fine outcome. You can do an inadequate decompression and still have resolution of symptoms. So I think fusion is easier on the surgeon. Unfortunately, it's not easier on the patient. So you know, it's one of those dilemmas that we have. It's more of a guarantee in terms of good outcome, but you really have to be, you know, I think, very careful with your arthroplasty patients to do a very thorough decompression if you're going to have success. And I think, again, foraminotomy, I put those videos of the foraminotomy because I think it's an underutilized procedure. And if the patient has unilateral symptoms, one should consider a foraminotomy.
Charlie, that's a great talk, and I appreciate everything that you said. I'll go right to the one case that you showed of the guy with bone-on-bone discs and some of the little caveats from things. I've been doing these things. I was a big foraminotomy guy, laminoplasty guy. Been doing artificial discs this year for 20 years. We ran the first trial. I think you were involved in that trial also, started in 2004. I've tried to convert all of my practice into artificial discs, and it's about 50%. And I do 2, 3, 4 level cases with frequency. We battle to get them approved, but cases that I think need them the most are like that one guy that you showed without the bone-on-bone discs.
Right.
And we spend a lot of time loosening up the oncovertebral joints. We will go around and I'll take a curette around next to the vertebral artery. I'll loosen those up. And it's restoring motion in those, because if you just go put an arthroplasty into a partially arthrodeced segment, it will go on an arthrodeced. It'll fail. And so that's something just over the past 10 years that I've been doing that, is that we mobilize people. In fact, there are some people we operate on purely for mobility problems. Okay, my PA's husband, okay, he said it in public so many places, but he's a hand surgeon. And he said he couldn't see his TV because he's a big sports guy and he loves to watch, he has a floor-to-ceiling TV. He couldn't see the top of the TV, and he came to me, he says, my neck's going stiff, I can't do anything. He had one fused segment that I couldn't do anything about. I put prestige in people, I call it the old guy disc. And I think it has even less mobility when it comes to a hard stop from that ball and trough. But it's the mobilization, it's the decompression, and you're absolutely right. You have to be a better decompression surgeon, because if you don't go clean out those foramen all the way out, the patient won't be happy. In fact, you might even make them worse. Mm-hmm. And I've done foraminotomies in those. I do fewer foraminotomies, and sometimes we do them from the front too. We will go through around the oncovertebral joint and drill it down with the old Joe procedure, which I did and published on. But it's not the future, it's here now, is what I think. In my practice, it is. I mean, in 3 patients, I put in 9 cervical artificial discs this week.
I think for the younger generation, you want to market yourself, you want to be successful in your local markets. MIS is obviously a patented tool, and having a robot in your office is cool. But tell them you're doing motion preservation, way better, truly minimally invasive, truly physiologically less invasive. And people like that. And they now know that they're wisening up to that. They don't want fusions, right?
A couple more points, a couple other things. The patients go home the next day. You don't have to wait for a fusion. You don't have to put a collar on them. And I tell them, what do they do with their neck? I say, just use it in whatever way you want. And when can you go back to work? Next week.
Yeah, I agree. I mean, I think it's a liberating surgery. You know, it makes a big difference in the patient. I feel like they get better faster. And yeah, it just should always cross your mind, can this patient be an arthroplasty candidate? And I would err on the side of saying yes.
And yet we have a quarterly arthroplasty forum. Dr. Johnson is one of the early adopters of the technology and again, a frequent contributor. And it's really cool to have this kind of a national network of people who somehow really know that this is actually better. And talking about myself, I actually think that made me a better ACDF surgeon when I have to do it, because I apply the same principles: a nice release, a nice foraminal decompression, preserve the end plates, realign the spine, not just fusing, stuffing a bone graft in. So I've learned a lot from the necessity to release the anterior segment. Question to the both of you maybe, Foraminotomy. So another overlooked procedure. We had Tim Adamson here several times, one of the neurosurgical godfathers of scientific publications. Why is this not done more? And is there a problem with doing it at multiple levels or bilaterally? What's wrong with doing a microforaminotomy?
Yeah, and that's why I wanted to give this talk, is just to remind people that a foraminotomy is an option. You know, it's for patients that are not maybe candidates for arthroplasty, you can do a foraminotomy. I think one of the reasons why not to do it is, you know, the prone setup is a pain, you know, to get the patient positioned, and, you know, the recovery is more difficult than an ACDF for the patient. So, you know, that posterior muscle dissection can sometimes be more painful. But I still think it's an underappreciated surgery, and I'm hoping for a sort of reincarnation of that surgery.
Can I make a comment on that?
Yeah.
Let me get at the mic. So I actually had unrelenting arm pain for about a year. One night I couldn't pick my wrist up anymore. Next morning, Pat Johnson emergently did a posterior foraminotomy, 2 levels. I was in the gym 2 weeks later. So I'm a huge fan of that procedure. And I'm a huge fan of Pat.
Can I have a last comment? Not about Dave, I'm happy. Well, there was a big herniated disc with it too, but I hope that's not violating anything, but you already did you told the world already. I used to be a big foraminotomy surgeon for years and years, 20 years plus. And because we couldn't do artificial discs during the first 10 years of our experience with the whole arthroplasty thing, the last 10 years has changed. And what's interesting is all of my foraminotomy patients are coming back now and having artificial disc put in because that disc finally wore out. Dave, I think your disc is going to last a long time. It looked okay. But, you know, so I've moved away from it. I used to do tons of, anybody that had cervical radiculopathy, regardless of whether they had, unless it was overwhelming pain, and then I do a fusion. But I do a lot of decompressions, and they did well for lots of years. But nowadays, I think that I have replaced most of those patients with arthroplasties.
Mm-hmm. Okay. So, yeah, I think we kind of missed our break a little bit. Yeah, we have Dr. Skaggs, who's going to do a lab demonstration. Yeah, I think he's just heading over to the lab right now. We might as well, we're going to get back on time now as a result of our loss of the break, but he's going to be doing a robotic assisted MIS fixation of spondylolisthesis.
Charlie, I don't know. Okay, ready to go? There's another topic. Okay, this is my most excellent assistant, Nick. We just met. You're going to watch him do this case wonderfully. So what we have here is a Globus robot we're going to pretend like we have a L5 spondylolisthesis. So half the case is planning. And planning for the spondylolisthesis is kind of humbling. We could see right here, you could almost hit the joint below, you could almost hit the joint above. And you could do really cool things with the planning software. You can rotate it 360 degrees, make certain that you're not hitting a joint. You can follow the screw trajectory from entering the bone, missing the joint, staying in the bone, missing the joint, and staying in the bone. And we can also plan so that the skin incision will be one rather than two separate incisions. And pretty importantly, this kind of subtle, we have to make sure that we're not going to hit the spinous process on the way in. And there have been cases where the spinous process is in the way, you see it ahead of time, you plan to pop it out with a rongeur, or just break it, push it out of the way, put it back in at the end of the case. So now we've done all the planning, and now we'll do the surgery. So we step on the pedal. Is it ready? Oh. Okay, you step on a pedal, and this will bring us to the trajectory, we hope, of the right L5 screw. So there is still more fiddle factor here than we want. There we go. And the truth is, when I do a robot spondy case, it takes me about 1 hour and 20 minutes. When I do a 13-level fusion with 20 screws, it takes 2 hours and 10 minutes. So robots slow you down, there's no question. But for things like this, I think the patients benefit. Okay, so this is the trajectory of the L5 right screw. I look down the tube, I draw a dot right on the skin. Now, we're going to set it up for the left screw. So again, we look down the tube, we make a dot, and now we can make a 2-centimeter incision in general. We're going to push this out of the way. Knife, please, thank you. Make about a 2-centimeter incision. We might do it a little bit bigger here. Knife is back, and he's pulled over just a little bit. We're going to go for the right screw first. And what I love about this robot in particular is at any moment you step on it and it recenters. Make sure you're in the right place. Okay, so we're green. We take the instrument I hate the most. We have to figure out something better than this. It's called the machete. We take the machete down, pop it right to the bone. There's a little bit of trust here. We're going to feel it on bone, turn it the other way, feel it on bone. Machete is back, and frequently, if we know there's going to be 2 separate fascial incisions, we'll cut through the skin, move the skin over, and make a separate fascial incision. In this particular time, I think it's going to be okay this way. So now, I'm going to recenter again. So every time we might move something, recenter, it just takes a second. Take the burr, this is a round tip burr. People have talked a lot in the past about skiving. The idea if you push it too hard, it just skives right off. The way around that is you just go back and forth like you're tapping. This is a side cutting burr. If you're finding you're having a whole bunch of problems skiving, maybe you should find a different profession. We should be able to fix that at this point. So now we very carefully come down and feel bone. So right now I feel bone. I didn't even look up yet. I'm feeling bone. When you look at it, you can't see anything. What went wrong? You could blame me. Say I was in the way. Okay, we'll hide it again. Click the array towards me. Okay, so we did it again. And this is real life. If it's not perfect, we don't proceed. So now I feel that I'm on bone. So we have a fair amount of area for improvement. It actually is not this bad in real life. You ready? Okay, so now I feel that I'm on bone, and we see that we're on bone. We always want to say that what we're feeling is what we're seeing. So just carefully go up and down, only about 3-4 millimeters. We don't need more than that. We're done. Now I'm going to reset it again, make sure we're in the right place, just in case there's been any movement of soft tissue. Well, I don't think you're in skin. There we go. I'm going to reset it one more time. Next, we have a sharp drill. This could go too far, so we make sure it doesn't. Pop this into place. And again, we're going to feel, are we on bone? It feels like we're on bone. And do you see how the drill has gone in the bone about 5 millimeters, just like we want it to, because we burred in about 5 millimeters. Now we're going to tap up and down gently. We feel bone the whole time. Oftentimes, as we go to the spondylolytic area, it's very hard because there's been attempts at healing over time. And we feel bone, we feel bone, we feel bone, and it looks just like it does on the screen. I hope at some point I'm wearing glasses where I'm looking where I'm working instead of looking at the screen. And right now I could feel that I'm really hard bone right there, right where it should be. Sometimes I'll go through a little bit. I think it's a stronger screw, sometimes not. So we're now done with the drill. Next thing we're going to do is put in the guide wire. Again, here I think it's absolutely key that we feel that we're in bone. And let's take an image, could we? So what we're going to do here to take an image is we pop off the end effector. We may have to raise the table. And it feels like this is probably in bone. Let's make certain. Whenever we're ready, we're going to get a lateral image. Wow, that's a pretty tough image to see. I think we're okay. Great. Now we're going to go back to robotics. Now in real life, I wouldn't accept that poor quality image, but being that I'm one of the things between you and cocktails, we will accept that poor quality image. And let's bring the robot back to place. Yep. You know what I often do here? If we've taken an image and we know that the guide wire is in place, we can just put the screw in. There's no reason to spend extra time here. And again, we want to feel, does it feel like it's on bone? Yes, it does. And we could either do this, can we pull this out with something, the guide wire? You do it by hand if you can. And we go down and feel that the screw has hit the end point, and there we have a really strong bite, surprisingly strong bite, and that's it. We have placed a screw. The next thing I would do in real life is take a neuromonitoring probe, poke it in and into the screw and make sure that it is less than 6 milliamps, which is the same thing I do for a pedicle screw, and reach in my pinky finger right there, and I feel the head of the screw right on the lamina, so we know we're in the right place by feel. And lastly, let's get a fluoro. So. Looks good. Do you want to get a AP? Would that be too hard? Actually, we'll just do an AP next. Now, so that was easy enough. Now let's have Nick, who's never done this, do the same thing. You ready, Nick?
Yes, sir.
So Nick is going to put in the left screw. I'm going to be his assistant. That incision is probably about 1.5 centimeters. And what we're going to do first is we're going to step on it. You're going to hide those balls. Is this being recorded? I can't make jokes then. So we're going to the left L5 screw. I'm holding soft tissue out of the way. I don't move at all. Now he's going to go in with this small knife called the machete. And I'm holding the skin out of the way. He's going to go through fascia, and he's going to feel it go right down to bone. Pull it out, turn it around 180 degrees, go right down to bone. And this is what we do in real life. Typically, I do one side, the resident or fellow does the other side. Next, he's going to take, I'm going to reset, so we hide the balls, reset, make sure you're in the right place, put down the burr. Now you're going to go down with the burr until you feel bone. Okay, trust your hands. You feel bone? Mm-hmm. Now that doesn't look like we're on bone. Let me just cop a feel here. Oh, so you see how it's skiving? Okay, so what I want you to do is go back and forth, just like 0.5 millimeter at a time, full speed. That's how you're gonna not skive. Up and down, 0.5 millimeter at a time. We're coming in at a very, very steep angle right there. In real life, I would not accept that steep angle, but we're gonna give Nick an extra challenge. We're gonna see if he could do it anyways. Yeah. So in real life, we would just change your trajectory so it was hitting the bone more end on. Keep going, Doc, you can do it. Back and forth, back and forth. You feel that you're on bone? Yep, we could hear it. Okay, you pull that out, let's put in the drill. So pull that out, hide the balls, and I'm gonna get this and go for the drill now. You ready? And just let's be satisfied that you feel that you're on bone.
On bone?
Okay, go for it. And again, so here we're a little bit dorsal to it. I would not accept this in a patient. I would, make it come down a little bit further here so we engage more bone, but we're not gonna worry about that too much in this cadaver.
Feels like cortex A.
Yeah, that does not look good. I'm gonna recenter. And let's put in a guide wire and just kind of feel it here for a second. It feels like we're on bone. Okay, should we redo this? Just keep doing what you're doing. Go ahead and put the drill down, or put the drill back in. I'm gonna recenter first. Hold on, let's hide the balls, recenter. Go for it. Okay, do you feel like you're on bone?
Yes.
Okay, go ahead, a little bit more. You're right at the end, you might feel some hard bone, just bounce up and down a little bit. You don't want to plunge into anything. Up and down, a little bit more. Great, and pull out, and then we're gonna put in the guide wire with the 2 tubes. Yep, tube 1, tube 2, and the guide wire. All the way down to bone, right? Feel like you're on bone?
There we go, now we are.
There you go. Okay, take this, pop it in. Good. Feel like you're on bone? Yep. So what we're going to do is we're going to pop off the end effector here. We're going to take an image, make sure the image looks like we're on bone, that we're not off. Okay. Whenever you're ready to image. And then we just put a screw in by hand. The alternative is you put a screw in under. Yeah, that doesn't look good. We're not in the right place. So there's alternatives here. You can just open it up a little bit more. You can do it by hand. Or we can go back in. Now, for the purposes of this demonstration, I'm not sure it's worth doing more. But what we could quickly do is just open it up a little bit more, get my finger in there. Okay, we'll try it one more time. So sometimes if it goes in the wrong place, it's because we haven't cut enough fascia out of the way. It's really important that fascia is not limiting us. We want to make sure that all the fascia is out of the way, or else what we see on the robot could look perfect and what we see in real life is not perfect. So this is actually a great demonstration of showing where something looked okay on the robot, but it didn't look okay in real life. So let's set it up one more time. You know, let's change this. Let's make the plan a little bit steeper, or so we capture more bone. So we now changed our plan. You want register, or what do we want to hit? Navigate. Okay, you ready, Doc?
Yes.
Let's step on it. We're going to try a new path. Okay, so this is better. I set you up for failure. My apologies. That was too steep of an approach. Okay, go for it. So you're going to just stick that in there. Let me open this up just a little bit more, make this work for you. In real life, we would not do this. Okay, go for it. Perfect. And again, there's certainly a lot more fiddling here. One more. Okay, so if anything, you want to be pushing down a bit. That's interesting how much that's skiving. This seems loose. I think we're going to give up on this side. There's too much jiggle in there. This is not precise. The first screw is the way that things do generally work. It's, you know, smooth as silk after you do a few of them. But when you do hit certain situations where it's so steep that it keeps skiving, you know, the bailout is open up a little bit more and just do it under direct visualization if you need to. Any questions?
Any questions, anybody? Dr. Chapman.
That was actually quite nice, and I appreciate that the honesty about the robot and the C-arm and clinical judgment discrepancy. So the question is, do you need a compression effect or across one of those fracture sites, or is it just enough to get that threaded screw material across? And do you aim for the largest possible screw, like a 4.0 or 4.5, or is a 3.5 okay?
So the size of the screw is measured preoperatively. And, you know, I tried to show up front is the screw is very, very much constrained by the size of the, by how close the facet joints are. So the typical screw is 4.5 by 35 millimeters. Rarely you can go 5 millimeters. Often you can go 40 millimeters. But the screw is chosen preoperatively. And I'm sorry, what was your second question, Jens?
Do you need a compression effect across?
Yeah, so that's the number one question. You know, it seems intuitive that it would be nice to have a compressive effect. Most of the time when you're looking at a spondy, you know, it's not just a straight gap. And I always do worry if you do close down that gap, you're going to be changing geometry. So far I have not done any type of compressive screw. I've instead chosen to use HA-coated screws with the theory that having a lot of bony ingrowth on each side of the fracture will immobilize it, and if needed, put bone graft in. I could imagine the day when we design compressive screws for this, you know, similar to a Herbert screw.
David, it's Pat Johnson. You just answered the question because I was going to ask about a Herbert screw. And I was also going to ask about a lag screw, but is there any way you can go back to that image? Because I was really kind of taken by the distal end of the screw. Could you put that thing in a few more millimeters and create another cortical?
Yes.
I mean, on your navigation picture, it showed that if you went through the back of that bone where you said it gets hard, I said, that looks like a perfect place to put a lag screw in.
Yes,
purchase the other side.
Yes, I have intentionally put screws through that cortical area. You know, it should be safe. You shouldn't be touching the nerve. And as a second backup, I will stimulate the screw. So yeah, I think you get absolutely great fixation through that cortex there. I'm a little bit hesitant to teach that because I think that you could get in trouble there. But I think you're right on, Pat.
Well, it's all about precision, is that you've already chosen the exact length of the screw. You know exactly where you're going to put it. And so anyway, you're right about safety. It's always safety first, but that might give you that little bit of compression that Jens was talking about.
Yep.
Okay, well, that was great. Thanks very much.
Thanks, Dick.
So our next speaker is going to be Dr. Rod Askuyan, Chief of Spine here at Swedish. We're going to be discussing difficult lateral cases.
I think then it's the other one. Oh yeah, great. Yep, that's it. Awesome, thank you. So Charlie always assigns the talks, and he always makes me give the lateral talk every year. I try to get out of it. You saw he took the artificial disc one. So it's great to see everyone, and great to I can't believe we've been doing this for 15 years. So I'm going to talk about lateral, and I'm a little conflicted, especially now that I had my knee done from a lateral approach. So I think most of the orthopedic surgeons can see this. I had a tibial plateau fracture on my left leg, and so fortunately this all healed nicely, and I'm almost about 85%, so not 100% yet, but I'm doing well. And you know, it's interesting, you know, we talk about artificial disc, we talk about robotic surgery. You know, there's so many cool approaches, and there's so many different ways to tackle the spine. And I always think, you know, these newer approaches, it's kind of fun, right? Here you have, you know, I've learned a lot from these courses. I've learned a lot from other surgeons. And, you know, for me, lateral was always like, how can you do something that's like minimally invasive? And how can you, you know, get access into disc space? And there's so many different things that lateral can do for you. As Dr. Chapman said earlier, you know, when you're building your practice, you want to get good at doing something. So when I was finishing my residency in Virginia, I knew I had to come back to Seattle and compete with Jens Chapman, who was the big fish in town, and he was at Harborview. And I remember when I was a med student, I rotated with Pat Johnson and Jens. And Jens had this awesome service where it was ortho and neuro combined. And it was actually one of the only ones around the country where it was truly combined. And I remember all the neurosurgery residents at Harborview, they loved their year with Jens because they just, you know, they just never had that orthopedic influence. And I've learned a lot from working with orthopedic surgeons and working with Jens, Amir Abdul-Jabbar, you know, and, you know, getting to know a lot of the faculty here, David Skaggs, you know, you surround yourself with smarter people and then you'll become a better surgeon. It's like osmosis. And so for me, lateral was that, you know, how can I do something that's cool, it's minimally invasive, and patients can have a quicker recovery. The only problem was, you know, it was a new procedure. They didn't even have codes. And then here, we're supposed to access the retroperitoneal space, which again, as a neurosurgery resident or orthopedic resident, you're like, what the hell is that? You know? I mean, who goes, the only time that I got in a retroperitoneal space is when I screwed up a distal end of a shunt. You're like, you see it all, you know, tangled, and then, you realize, okay, that's where the retroperitoneal space is. But the urologists know it, right? I mean, they do Da Vinci robot, they do all these cool procedures, and I just, you know, I thought this was a great image, but I mean, nobody gets into the space. And sure enough, as a resident, we have all these, this is an old Grey's Anatomy textbook. Like, that's not what the retroperitoneal space really looks like. And a lot of the textbooks that we have are older, and they really didn't, I was like, God, there's nothing to read about this procedure that people keep talking about. It's so cool. And I've learned by doing, but also by spending time here at SSF, and we have great fellows. In fact, one of our fellows, Cliff, you'll see just sitting there. This picture of him and Sven, they're eating dumplings. This is a very famous dumpling place in the city. But the point of this is that, what you're taught in residency, med school, a lot of the textbooks, they don't talk about there's nothing in any of these textbooks, right? So I learned with the fellows, doing dissections, doing what you guys are doing coursework. And, when we're in med school, they teach you all this stuff. You memorize it, like the brachial plexus, there's the trunks, the roots, and all the, for the lumbar plexus, there really wasn't much, and so our fellows here, both are, have done a lot of work in this, and this has been a passion of mine for the last 15 years. And what's amazing is that there's very little published about the plexus, and but here we're doing all these lateral surgeries. You go to every meeting, everybody's prone, they're upside down, they're doing, prone lateral, lateral prone. I mean, everybody wants to do it. But here, they don't even have nobody knows the anatomy that well. And what I found out about the plexus, so this is Jens's cousin. This is a great picture. Everybody, these two guys are related. You can see Jens has a little bit more hair than his cousin. But they look similar, but they're different. The plexus is the same way. No one has the same plexus. And then this is actually one of the figures from one of our books that we ended up publishing. And it was really 15 years of surgery, spending time in the lab, dissections, having every single complication you can think of. Hopefully you guys will not have these complications because you're spending the weekend here to learn about all these great procedures. And again, whenever you're doing lateral surgery, it's really based on fluoro, right? You don't see the whole retroperitoneum. You don't even see the lumbar plexus. So we have very sophisticated neuromonitoring. But again, if I can emphasize one thing, is just surround yourself with very smart people that are experienced. Don't go do crazy surgeries when you're first starting out as an attending. And it's going to courses like this where you learn, you go, hey, what is you can dissect out, go check, after we're done tomorrow, let's dissect out the plexus. I love doing stuff like that. That's how you learn. And again, like I said, I was very fortunate. I'm surrounded by super smart people. This is a great picture. There's Cliff. You have Jens Chapman, Keith Mayo, Alex von Glinsky, and Thomas Schildhauer. And Thomas was one of Jens's fellows, and Keith is one of the godfathers of hip and pelvis. And then Alex did this whole, when he was here, we did all these dissections. And again, all these, there's so much knowledge about this area that I, as a neurosurgeon, I just never was exposed to it. And so we did a lot of dissections. And then this is actually how complicated the plexus looks like. That's a 3D reconstruction. And you can see, here's another picture. We put guide wires in to kind of see, this is actually what it looks like. If you were to light up the plexus, that's what it looks like when you're doing lateral. Raise your hand, who wants to do lateral now, seeing the plexus like that? No one, right? I mean, who on earth? It's like going to see Pat Johnson. This is the LA freeway, Santa Monica, during rush hour. Forget it. You just stay right in Venice Beach. You wouldn't want to go on that. And then, but you surround yourself with super smart people like Julius Gerstmeyer, who's here. He's one of our research fellows, who does a lot of stuff. And again, this is another scary picture. You guys will not want to do lateral after this talk. Okay? But this is what the plexus looks like. It doesn't freaking move. Like people talk about, oh, if you position this way, that way, it's going to move like maybe 0.1 millimeters. I mean, this is not going to move. you have to hit the sweet spot, which is the disc, and not injure the nerve, okay? So you can talk about doing all these different positions, but this is what matters. Doesn't matter if you're prone, doesn't matter if you're lateral, prone lateral, sideways. The plexus is what, you have to understand the anatomy. And again, even more scarier pictures, right? Nobody wants to do lateral anymore. But you can do it. You got to have a good team. This is the team at SSF, right? You got to have a good team in the OR. You have to understand, let's say if your nerve monitorings go off, maybe you don't do that level that one day. You bail because you can have serious complications. And again, it looks even scarier, right? I mean, look at all these nerves. And these are just some, just learning points that I had. And usually when I do lateral, I'll get a CT, I'll get a lumbar MRI. I mean, you look at all this, you can get a lot of information about, what things look like, and before you start doing it. And again, I wouldn't start, doing these surgeries where you start doing corpectomies. I wouldn't start at L4-5 when you do your first lateral. I wouldn't start doing these more. I'm going to show you guys some cool cases. Once you feel comfortable, and again, for me, honestly, it's probably like 50 cases. I would not start doing corpectomies. I wouldn't start doing crazy. I'm going to show you guys some crazy cases, but that's 15 years worth of, 20 years worth of doing these, right? And like I told you, I've had plexus injury, I've had femoral nerve injury, I've, ureter, bowel, colon, hemothorax, pneumothorax, kidney. I mean, it's all there. And you can, trust me, you can injure. And I've had every single complication you can think of. But again, the key to it is you got to have a good team and you got to understand what you're doing. This is, I thought I would show you, this was a cool picture of me at Harborview. After my surgery, all my buddies came and visited me. Jens came over, had great care over there by the trauma surgeons. And, it's humbling when you actually have to have surgery. You realize it really takes a team. Again, just like I was telling you earlier, this is not the case you want to tackle the first time you do lateral, right? This is a case that you want to do later on. It's thoracolumbar junction. Patient came in paraplegic. You can do this posteriorly. Do what you're comfortable doing. Don't take risks the first few years in practice. Do what you're comfortable doing, which is you go posterior, you put in the pedicle screws. You don't have to do a lateral corpectomy, but after you get experience and you feel like you can do it, these are the kind of cases that you can do. This is a picture of one of my old partners, Dave Hanscom, who used to practice here. This was at his retirement party. Instead of working out, he decided to get a suit, and we had a lot of fun with Dave. And Dave was here. This is actually one of his patients that I did a lateral on, and then went posterior. This was like a 2-stage procedure, but this is the kind of stuff that you can do once you feel comfortable. And again, like most things in lateral, these are more advanced procedures, right? I'm not showing you the L4-5, L3-4, L2-3. Those are kind of the bread and butter. But the most important thing is understanding the anatomy and understanding what the plexus is, right? So this is an L4 corpectomy I did for a tumor case. You're not going to be doing this in your first 2 years in practice, okay? It's just not going to happen. And, but, if you understand the anatomy, you understand, where the plexus is, you can map it, you can put in, look how big that cage is. This is true, not to bag on the endoscopic guys like Jay and some of the other people here. But, this is real minimally invasive surgery. This patient went home like 2 days after having this procedure. And again, I've got some pictures that I'm going to show you that, they're tiny little incisions. And I got a picture. This is one of Kojo's cases from about a month ago. You can see, I mean, who wants to have Kojo operate on you? I wouldn't. Look at that incision. She's gonna have, it's called a shark bite incision. She'll have a hernia afterwards. She'll have, intercostal neuralgia. She's a chronic pain patient. And then look at my incision. What would you rather have? The left or the right? So I think, again, another corpectomy I did, actually that was that one patient that I just showed. And I like it for tumor cases, okay? I like it for infections. I don't like doing these, corpectomies for deformity. I don't like it doing, I like it, it works really well for infections and tumor. Like this is a great tumor case that we did. And you can get, I mean, look at how much, look at the cages nowadays, and they're getting better and better. You can get a tiny little cage that can expand to like 40, 50 millimeters. And you look at the end plates, the end plates, they're much better than the cages that you can put in posteriorly, right? They're cylindrical and they can subside, they can go through the end plate. And here's another L3 case that I did. You can see, you get very, you can pretty much take out the entire vertebral body. This is a 2-level corpectomy that we ended up doing. This was an infection case. And again, just like you do posteriorly, you got to take out the back wall. So actually, what this shows you is the retractor placement is key. So typically what I do is I start posterior, work my way anterior, and then decompress the central canal. And then here's, that was the infection case. You can see how much subsidence there was and bone collapse. Here's another tumor case. You can see, the amount of, and again, you can see it there. This is a very challenging case. This is an L4 corpectomy. So, the risk of having a femoral palsy, femoral nerve injury is super high. So you can't take forever. Here's another case that I did that we ended up doing. It was a tumor case. And again, with a lot of the new instrumentation, they have fenestrated screws. So you can put cement and then put your screw in. You can go one level above, one level below. But you also have to be careful. I mean, we've been burned, Jens, right? You can get bad subsidence, fractures. I mean, these can be highly unstable. You definitely, you can definitely have problems. And again, it's one of these things where you really, patient selection is important, and then technique, right? So even though this is L3, you can still have, a femoral nerve injury. And, you have to monitor, and retractor placement, retractor time itself, all these things are important. And I don't know if you guys know this, but Dr. Chapman, when he was a resident, actually was in a band. I think this is during one of their concerts backstage that I was able to get this picture. And we've had some fellows come through from his old residency. So I have a treasure trove now of where Jens had long blonde hair. Yeah, I will send it to you. I have a good one too of when he was a resident. It's still up in it. One of my good friends is the chair at UT Southwestern in neurosurgery, Nader Parati, and so I've got all this treasure trove of photos. And again, this is another excellent case. This is Jens looking more serious. He's got his more serious look, a little bit less hair. And we do a lot of these cases together. He'll do the posterior, clean everything out, so I don't have to take the back wall off. I can just go in, drop the cage in, and this is one case that we did together. And you can see, it makes it funner, and the patients do great. And I hope one of the things you guys get from this weekend is we're so privileged to do what we do, right? I mean, it's such a great profession. And part of our fellowship, we spend a lot of time, because you guys come in, everyone's kind of burned out. they're tired of like taking call. I mean, it's like, I kind of sometimes feel like we have to do 6 months of therapy, and the fellows get so whiny, and like today, I mean, I was on call and I did clinic. Where's Nick? And Cameron, where did Cameron go? So Cameron and Nick are up here, I saw them like, yeah, we're having fun, And then I went to the ER, I saw a consult, I was on the phone, I had to go to the ER, clinic, everything. But just remember, this is a great year. You get to learn a lot, you get to have a lot of fun. And you get to, come to cool courses like this. So you can see Gary, who's our lab guy. I mean, you just have to remember, like, you have to have the long-term perspective. This is a great profession, and you guys are all going to have great careers. And part of hopefully what you get from this weekend is, just have fun too. It's not all. You don't have to be stressed out, you're done with residency, you guys made it, yes, and fellowship is just one other thing. We always deal with this in our fellowship. It's almost like everybody's trained for delayed gratification, right? You're like, okay, I can't quite celebrate yet because I have to do fellowship. And then you're like, oh, but I don't have like the perfect job yet, so I'm still job hunting. And then you just keep, it's like, don't have the perfect house. I'm like, guys, listen, what you have now, like when you look back, having the big house with a huge mortgage, lawyers chasing you, journalists chasing you, like things get more complicated. Trust me, I've been there. And just enjoy it. Like every day, like it's a new challenge. You learn new stuff, like even this weekend, you get to do a lot of cool stuff in the lab. We have super smart people here. And again, you get to, eventually you can do something like this, where you do a complete corpectomy, you can see the vertebral body's gone, right? And you get great lordosis. I mean, look at that. These are obviously cases that are more advanced, but I just want you guys to see what's possible. But you got to spend a lot of time. You got to go to courses. I encourage you to, I'm happy to talk to you. You guys can make connections with the people here this weekend. What I've learned, I've learned the hard way. Like I said, there was no textbooks. I remember I learned from Luis. I remember I ran into him like 2001, and I love him. He's a great guy, but it's like he lives in Brazil. You see him once a year, and then that's it. And then so you have to learn on your own, and you don't want to make a lot of mistakes, and don't want to have to learn the hard way. So learn the lab. Come to courses like this. Talk to people. Talk to Woody Cross. Pat Johnson. I mean, there's so many people that have been doing this for a long time. Trust me, whatever you guys think is possible, we've had those complications and we've dealt with these patients, And again, these are more complicated cases. A case Jens and I did of a patient who had, had a basically burst fracture. It pseudoed, the cage was going posteriorly. And I was able to take this out. We cut the cage out.
I do want to point out, we did not do this case. This was done elsewhere.
No. We
revised it.
Yeah,
we revised it. Just want to make sure.
Exactly.
Just want to make sure to avoid.
Yeah.
We live in questioning times, and so this was not done here.
And this was a difficult case, actually, Jens, because you remember she had the Kojo Hamilton incision. So she had this huge. Honest to God, this is what happens, right? You have an access surgeon. This isn't what they do. You're not in the room, whatever. The guy goes, marks the incision like from here to here, and then, but what do you need access to? Posteriorly. Her incision was way anterior. So here you do this massive incision, and then all you need is that little access. And I remember Jens and I were talking about this case. Jens is like, are you gonna be able to do it? Because I go, absolutely, I'll just go behind it. And we made a tiny little incision. and we're able to drill that cage out. You can see it there. I used a metal cutting burr. The only thing that was crazy is like sparks were flying. Everybody was going crazy because, you can't really, it's in the chest. And so the fellows were like dumping irrigation into the wound. But again, the key to doing, lateral, again, it's basic anatomy, and there's not a lot of stuff out there. But now there are some, there's lots of papers. And this is I'm putting a plug in for my own book. Go buy this book. This is a great book. There's not that much on, and this is 15 years worth of work that we did because there wasn't anything that was out there, and it ended up being, and again, I learned from all you guys, the fellows. This is a team effort, have fun, enjoy this weekend, talk to the faculty here, and I think we could probably have one more demo. And then, enjoy fellowship because it goes fast and there's lots to learn. And like I said earlier, you guys have a great career and a great platform, and all this stuff, technology, AI, robotics, it's only going to get better and better. So thanks again.
Thanks, Rod. Any questions for Rod?
So first of all, disclosure, Rod does all the far laterals because I just do the posterior part, and then he comes in and saves the day. Rod, for but I'm going to challenge you on that. Isn't it smarter to actually just say go into the upper lumbar spine or even the thoracic spine rather than diving around in L4-5 or below, because that's where the real plexus problems happen. That's where the ureter floats around or the colon wafts in.
Yeah.
So stay away from the major deformities and go into the upper lumbar spine. And actually corpectomies, we showed a paper, this is under peer review right now, T12 corpectomies done in a cadaver in a simulated OR environment by fellows who are adequately trained are perfectly safe.
Yeah, I think, again, so in terms of thoracolumbar junction can be tricky though, Jens. I think when I was talking about just understanding the lumbar plexus, definitely, L1, L2, but it's still hard. If you've never done one, to start at L1 and then try to do corpectomy, that's not an easy operation. But in terms of the plexus, I think, understanding how, to interpret neuromonitoring, positioning, where do you dilate. When I first started doing lateral, we actually didn't have neuromonitoring. On every single case, I would go down, I had a microscope, I would go fiber by fiber by fiber, and I actually would find the femoral nerve and place my dilator in front of it and retractor in front of it. So the neuromonitoring came later, right? These things, it sort of evolved. And again, all the companies now have, good monitoring, but I think Jens, your point's a good one, where I think for me, being a neurosurgeon, the most devastating injury is the femoral nerve, because you knock that guy out, you just basically incapacitated the person. It's multiple nerve roots, multiple muscles. So I think starting up higher is probably the way to go.
All right, those are valuable lessons from lots of experience. So our next lab demonstration is going to be Dr. Chua, who's going to be discussing the robotic placement of pedicle screws.
All right, great. Can everyone hear me in there?
Yes.
Okay, thanks for hanging in there. Last session of the day before we head off to cocktails and dinner. Echo Rod's comments, learn as much as you can, be a sponge, ask all the questions you can of your faculty, and enjoy this career that you're embarking on. I do want to thank Rachel and Judd and Medtronic for sponsoring this demo, and all of you will get a chance to work with the Medtronic Mazor robot tomorrow and place some screws, but I'm just going to give a quick demo. Briefly before that, I just want to take that panned out shot to show the equipment that's involved. So the workstation is here in the back. The Mazor workstation, there's a 12-foot cable, so it doesn't have to be parked right here by the operating room table. It has HDMI output, so you can go to every monitor in your operating room or the one on the ceiling, so everyone can see what you're doing. In addition to that, the robotic arm is actually attached to the table. So it's table-mounted robotic arm. This entire assembly is stored in this workstation. So from the standpoint of the OR personnel, it's very easy to move it in and out of the room and storage. So this arm gets attached to the operating room table. It's then affixed to the patient. And because that's the case, we only need one point of fixation. It's usually just a PSIS pin that looks like a Caspar pin you might use for an ACDF. There's an attachment from the patient PSIS pin to the robotic arm. There's an end effector through which all the instruments go. And then there's the reference array. And since this is table mounted and patient mounted, there's really only one reference array. It's very difficult to inadvertently bump the reference array. You can ultimately get a shift of the shoulder or a shift of the patient. We have to be aware of that. So during the technique, we're very, very careful about placing our instruments down. I never like to see anyone gripping the instruments with their fist. I'm a neurosurgeon, so we like to teetotal our instruments, so it's 2 or 3 finger technique. And then the optical array camera is usually at the head of the bed over anesthesia. Generally, we set that up at the beginning so we see the reference array and all the instruments, and so we usually don't have any line of sight issues. I'm going to go back to the back though, and I want you to switch over and look at the software, because that's really where the money meets the road. Here is a software for CT to fluoro. So this patient already had a preoperative CT scan. Judd has been kind enough to already plan screws from L3 down to S2. He's also planned some decortication sites for a facet fusion and decortication sites for bone resection, so facetectomy and laminectomy. And I'm going to show you how easy it is for planning. So I'm going to add screws at L2. So I'm going to go to the L2 level. I'm going to add a screw. It's going to give me the same pair of screws that were last placed in diameter, trajectory, and length. And all I'm going to do with my mouse is just make some fine adjustments of these pedicle screws. And again, I can individualize each pedicle screw for the angle and the facet. I can make these screws larger, but either by diameter here on the left or in length. And very quickly make adjustments to add screws. I can look at the simulation on the AP view or in the lateral view, and I can start to imagine how I'm going to place the percutaneous rod or a mini open technique for the rod placement. And then I can actually plan inner bodies. I can go down to L5 and plan an inner body for L4-5 by adding this. Here's a simulated cage. I can take this cage and I can rotate it. I can place it as if you would do a T-lift technique for a right-sided approach. Here on the sagittal, you can see the simulation of the segmental anatomy. I can add height to the implant. I can add length to the implant, and then I can ultimately simulate what the correction will be at that segment simply by hitting this button on the left. So again, from even a 1-level or a 2-level degenerative spondy, we can start to take those principles of spinopelvic parameter and sagittal balance improvement and take that to the degen cases. The nice part then, as I mentioned earlier today in my talk, is the decortication. So we're going to go up here to L1, L2, and we're going to plan some decortication pathways. We're going to add this decortication tool over to the left side. And I'm going to plan to decorticate that facet joint at L4-5. I can make an adjustment as to the length of that decortication site. It's a 7.5 millimeter decortication tool, and then I can backfill that with bone graft. I can quickly add another decortication site for the opposite side. And again, this is especially helpful for MIS cases, but it can be done for open cases and MIS cases. I can even plan my incision. I can go down here, change the windowing, see the soft tissue envelope, and I can plan my incision for an MIS technique from the midline, and I can estimate my incision to be 4.5 centimeters off the midline on that side, only 4 centimeters on that side. So I can customize For instance, a trauma case where I'm going to stabilize and fixate and fuse with just percutaneous incisions. So with that, again, this robust software planning, this can be done ahead of time if you do a CT to fluoro workflow, or if you prefer the scan-in plan, you can use the O-arm to do the spin with the patient in the prone position, and then do the planning on the workstation, then execute placing the screws and the instrumentation. So now we're going to go over to the cadaver and sort of demonstrate one pedicle screw placement and one decortication. All right, so it wasn't mentioned earlier, but there are a few steps to get the registration of the robot. So prior to this, Rachel and Judd have taken a couple of fluoro shots, registered the Mazor robot to the preoperative CT scan, and registered the navigation. So this is a dual navigation system and robotic system. And because it was a robotic system first and the navigation was integrated, if the navigation for some reason is completely off, the robot is still accurate to 1 millimeter accuracy. So we have the head up here and the feet down here. The arm is mounted on the patient's left side in this case in the lab. Typically it's mounted on the right side in the operating room in a very, very efficient manner. So Judd's gonna send the robot over to the left L5 pedicle screw. There is a monitor here that can be draped within the Mazor drape so that I could operate it myself. But as a surgeon, I'd rather focus my attention down here rather than on the computer screen. So we'll go ahead and send it, Judd, to the left L5 pedicle. A lot of safety features built into this, so when it's moving, there's a green light that's blinking and there's a buzzing sound, so you shouldn't touch it. When it stops, you hear a bonk. So now we're at the L5 pedicle screw. I can ask Judd to raise or lower the arm if we need to. It looks perfect. I'm also going to take a machete, go right down the pipe and make a little stab incision. And again, we're just demonstrating kind of the least invasive technique. We're going to extend that incision just a bit all the way down to the bone. And then it's really 4 steps or 4 sets of instruments. The first is a navigated cannula. The next is a navigated Midas drill. The next is a navigated tap. And finally, a navigated screwdriver. So this is the first one. It's a navigated dilator with a soft tissue cannula. We're simply going to go down and with just a couple of finger twisting technique, we're going to be set on bone. Now I need to see the monitor. And then we're going to slide our cannula down. We can see the navigated instrument in blue, the screw trajectory in green, and the yellow is the planned screw. I'm going to leave that cannula and take the navigated dilator out. Go to my Midas for Mazor, which is a 30 millimeter drill bit. And we're just going to go down with power and try to prevent my carpal tunnel from getting worse. We're going to lift the drill off of the bone. Give me some power. And then we're just going to drill a pilot hole. And again, under navigation, you can tell it's a very rigid system. Take that out. Then we're going to go with an under tap navigation, again with power. We can see the navigated tap there in blue, the navigation confirmation with the green, and then the screw trajectory. And then we're just going to fire this down. We'll back that out. The accuracy is so good. I know we're all trained to start sticking ball probes in there and feel the channel and all that. Really don't need to do that. We're going to take the cannula out, switch over to a navigated powered screwdriver. Again, we're going to confirm the trajectory, the virtual screw, and the planned screw. And then again with power, with very little 2 to 3 finger technique on the hand drill, drop that screw in about 10 seconds. We're going to release the screw, and this is an MIS screw, so we'll just release this here, gentle tug, and that's one pedicle screw. So we've standardized the placement of a pedicle screw using the navigated robot, 4 steps. Really no reason to do ball probes down the pedicle shaft, really no reason to do neuromonitoring. Again, the navigation of the robot is 1 millimeter or less accurate. So then we're going to demonstrate just the decortication. So let's actually go over to right L4-5, and we'll do the decortication at right L4-5. Again, we're going to now do a fusion part of the operation using the robot, which we were not able to do until last year with the most recent software and hardware upgrade. We'll again make an incision down through the skin and down to the fascia. Usually enlarge that just a little bit. And again, while we're showing the least invasive technique MIS, you can do this open or mini open, navigated dilator and cannula. Very, very soft technique by pushing the instrument down. You can see the facet joint. We're going to drop the cannula to keep the soft tissue out of the way. Take the navigated cannula out. We've now switched the drill over to this acorn bit, which is 7.5 millimeters in diameter. Those decortication trajectories and plans are up to 20 millimeters deep. And I can simply go down the cannula, verify on the navigation. There we go. And then using the same technique, kind of a bird beaking type of technique, we're actually going to drill down. And actually, this trajectory was for part of the bone resection. There's another trajectory for the facet fusion. My apologies. But again, you see the idea. We're creating a 7.5 millimeter by 20 millimeter hole. This drill bit is designed to pull the autograft out, which you can use if you want for the autograft. We don't have the equipment today, but there's essentially that caulk gun that I showed in my video. It's preloaded with up to 2 cc's of DBM or whatever autograft. You slide that down the cannula, squeeze the pistol grip about 4 times, and you've delivered 2 cc's of autograft into that facet fusion. And so now you can imagine if we can do a decortication and facet fusion using the robotic arm with that precision and that accuracy, we can then use the robot and the computer planning and the decortication tool to do our actual primary decompression. So Judd has moved it to another trajectory. And so we'll just repeat the exact same 4 steps. So small incision through the skin and fascia, all the way down to the bone. Navigated dilator and cannula. Confirm that, and maybe we can zoom in on the other screen. Perfect, so that's now the facet decortication. I can take that same acorn drill bit, go down the cannula, and then again do the facet decortication. You can see the tip of that acorn bit is pretty sharp, but it doesn't cut on the tip. And so what we've been able to do now for the past 6 months is use this tool to actually do our primary decompression. So for the first few cases, I would plan and leave 1 millimeter of bone and facet joint or facet bone before I got to the ligament and flavum. But most of us are doing the surgery because there's very thick ligament and flavum. So after a few cases of proving the accuracy and precision, I put in the microscope and my tubular retractor and see that there's a little eggshell of bone. Now what I do is I plan down to the ligament through the entire inner surface of that facet joint. And so now we're able to, for instance, if we can go back to the other monitor, Judd's going to show you a level where we've planned 4 or 5 trajectories using that decortication tool. And you can imagine with 3 up to 6 or 7 trajectories, we can actually do greater than 90% of the bone resection for a TLIF, hemilaminectomy, and even contralateral decompression using the robot and taking advantage of the computerized planning and the precision of the robotic arm. So you can see several overlapping trajectories of that decortication tool. And if you just plan those decortication pathways and trajectories appropriately, you've essentially completely done the decompression. So very much look forward to tomorrow when you all will get to rotate here to this station, and we'll let you drop some screws. I'd be happy to answer any questions. But the Mazor robot for me has been just an amazing advancement in my toolbox and has been able to allow me to do 70 to 80% of my lumbar fusions, degen patients as an outpatient, especially with this type of technique, and now more standardized and more efficient because I can use the tools to do the decompression, and now I can just put in my microscope and finish off the decompression with about 5 to 10 minutes of removing the ligament, residual facet joint, and now I'm back to doing the inner body part of the operation. And with that, hopefully we'll give everyone back some time so we can get to happy hour. Any questions?
Thanks very much, Dr. Chua. That was great. Any questions for Dr. Chua? I think some exciting times with the ability to use the robot to remove bone. You know, it's definitely a step in an interesting direction. So, Dr. Chua, when you decorticate those facet joints, what are you doing to salvage that bone?
So with a decortication tool, that drill bit's actually designed, and it actually pulls out a little bit of, I think Rachel already wiped it off, but the drill bit actually pulls some of that bone out. That's number one. Here's a little bit of a smear of bone that came out with that decortication pass. You know, much of that bone, though, is kind of cartilage, and I'm not sure how good that bone is. It's kind of toothpaste consistency, so I typically don't rely on that autograft. I oftentimes do a little MIS technique into the PSIS, and there's a device that I can get 10 cc's of cancellous bone out of the iliac crest, and I'll use that. I'll use some of the other DBMs that are produced and designed specifically to go into the gun that's delivered into this spot. And then in some cases, I'll use a BMP in an off-label use and get an extra small sponge and just cut it into pieces and stuff it into that facet joint.
Nice. Cool. All right.
I just have,
oh, yeah, Rod has an
I have one
announcement.
more question, Rich. That was great. What's your thought on, so I don't know, I think you talked about it earlier, but what's your thought on, how much of this technology, like you talked about decompressions, doing osteotomies, do you think in like 3 years, we can just let the robot just do the whole case?
I do. I actually do.
Yeah.
And my hope is that before I retire, I get to be like the Da Vinci surgeons and sit in the corner with my shoes off and get to do the operation. But realistically, I think the engineers are very close to figuring out how to make this a mobile arm rather than a static arm. Right now, we're using a static arm and just doing reproducible drilling and bone resection. It's just a matter of time before the robotic technology will be to the point where it's a fluid moving arm, just like the robots are building the Tesla. And again, if you look at any video of a Tesla, 90% of that car is made with robots. There's not 10% is with a human touching it. So I do think we're moving in that direction, but it's, step-by-step iterations of the technology. But I do think, I don't know if it's 3 years, it might be 5 years, but I do think that we're going to be able to do that. Some of you may know we're already doing remote technology surgery across 5G. So there are surgeons in the United States doing surgery remotely using 5G technology in Europe and in China. I think very recently was the first case where they did a spinal fusion remotely using a robot in China, where the surgeon was in the US doing the manipulation of the robot, sending that information across 5G to China, and the robot there is doing all the movement. So the technology is out there. Just think about the technology on your iPhone that's in your pocket right now. That technology building a Tesla, the automation of electric vehicles and hybrid vehicles, you put that into these machines, and I think sky's the limit in a short period of time.
And then one less technological question is, I'm still trying to figure out, what do you think is the best incision for one level? Because I don't know, I'm kind of going back to doing one midline
Well, it's a
instead of, 5 stab incisions and.
It's a great question.
So-
I will tell you, having taught hundreds of surgeons the robotic technique, the surgeons that struggle the most with the robot are the ones who try to do a small midline incision for, let's say, an L4-5 TLIF with instrumentation. The beauty of this software is to optimize your trajectories of the pedicle screws. In order to do that, it's more of a lateral to medial trajectory than we're all used to doing with our open technique. So I think if you can get comfortable doing, now perhaps you could do a midline incision to do your decompression and inner body, but then do a couple of stab incisions. And I know it doesn't look great, but they all heal just fine. Or you can go to doing 2 paraspinal Wiltse type incisions, 3, 4, 5 centimeters off the midline, put in your screws through those incisions, through the fascia, do your decompression however you want to do it, endoscopic, microscopic, tubular, mini open, or pedicle screw-based retractors. You have all of those options when you use the robot.
So what do you do? Because I like the midline, bigger incision, keep the fascia intact, and do Wiltse through the fascia.
For the screws, then what do you do for the decompression and inner body? Do you go back to the midline and strip it off?
Just do it through the stab incisions.
Yeah, that's essentially, I essentially do 2 paramedian incisions. I use the robot and put in the opposite screws first, and then I'll drill and tap my screws on the ipsilateral side. I'll use the robot to do my facet fusion on the contralateral side. I use the robot to do my facetectomy and laminectomy on my side. Then I put my tube in, then I bring my microscope in, finish off the decompression, do the inner body, and then the robot goes out of the way, the microscope gets out of the way, drop the 2 screws that I've already pre-drilled and pre-tapped on my side, drop the rods and close. Prior to using the robot, I would do the standard navigation technique of a spin, do your surgery, do another spin, make sure all your screws are good. This is so accurate and so precise because of the planning and because of the registration. I no longer do a spin. I do 1 AP and 1 lateral, make sure my screws are good, close and be done. And this has made me a much more efficient surgeon. I thought I was pretty efficient and pretty fast, but the robotic technique and standardization, and you just saw 4 steps, and I can even get it down to 2 steps. I can skip that dilator and I can go right to my Midas drill and cannula, drill my hole. I can skip my tap because I've planned the screw to go in a nice flat spot, and I can drop my screw. So I can even make that technique even more efficient with 2 steps to drop 1 pedicle screw.
Cool, thank you so much.
Nice.
Can I ask?
Great. Oh,
Yeah,
yeah,
go
we have
ahead.
another question.
I would like to ask, does it have the same accuracy for levels that is away from the navigation frame? Like, for example, if you are doing long construct.
Yeah, I think the question is the accuracy of the navigation as good the further away we get from the frame? Was that what the question was?
Yeah, that's my question.
Yeah, so it is as accurate, and I would argue it's more accurate because this is such a rigid arm attached to the table and to the patient. So there's less play in this than there is, let's say, your O-arm stealth navigation system. And so it is as accurate up at the upper middle thoracic spine as it is down at L5S1 or the F2AI screws that we showed so elegantly earlier today. And by the way, this is, this bridge that attaches the robotic arm to the patient with a PSIS pin, although that's not on label, we use this attachment. We go all the way up, we can go all the way up to T7, and it's accurate and the reach is there. And so we can minimize the amount of times, we may have to do registrations. When we do long constructs like that, some people have the idea that, gosh, we need to take the robot and disconnect it from the patient and move it up and register again and move it up and register again. And that's simply not the case. We may have to use our C-arm to re-register because you can only get 3, 4 levels at a time, but the robot will reach all the way up to the mid or even part of the upper thoracic spine simply with an attachment rigidly into the PSIS. There are other attachments of the robot to the patient, so if it's an open case, Just like your navigation with O-arm and stealth, there's spinous process clamps, there's dual spinous process clamps. But for my preference in a lumbar degen practice, it's almost always this PSIS pin.
Awesome. Well, thank you so much. This concludes the day. And I guess the next event is the happy hour.
Yeah, so you guys, so you can actually walk to the, it's called Stoop Brewing, and there's 2 locations. Don't go to the one in Ballard, because you can't walk to it. So it's the one in Capitol Hill. And then, we're fortunate in that you can walk, it's not too bad, and the address is, basically, it's on Broadway. Yeah, exactly, Gary's got it right. And then there's gonna be pizza and beer, and then we can hang out and have some fun. And then tomorrow, we start early, so no going out late, okay? So you need to be home by midnight. And if you're not, your daddy Kojo is going to be looking for you. So, and you don't want to see Kojo if you're out late. So, any questions at all? Everybody's good? You guys having fun? Awesome. Okay, cool. See you guys in a little bit.